Senator Perry,
Here, present.
Senator Hall, Senator Miles, Senator Hughes,
Here.
Senator Blanco,
Here.
Senator Sparks,
Here.
Senator Cook.
Here.
There being 6 present, a quorum is established. Good to see everyone this morning. Before I go into my opening remarks, I have some sad news for our office. This will be Sally Buck's last 2 hearings with us. She came to us grew up in Houston and went off to Vanderbilt, saw the light and came back to Texas, but she will be entering law school at the University of Texas. And so we want to wish her well. It is a very sad day for us, but we didn't want to stand in the way of that. And what I love about the young people that come and work in our different offices is her keen interest now in healthcare, which probably wouldn't have been the case 18 months ago. So anyway, Sally, thank you for staying through these 2 hearings today. And we're going to miss you, but you're just right down the road, so we know where to find you. Members, I want to thank all of you for coming after a holiday weekend. I hope everyone enjoyed Independence Day. And yes, some remorse about the USA not winning last night, but Belgium played a great game. Today and tomorrow are going to be 2 very full days with meaningful issues that we will face in this interim, and then more importantly, as we move into session. We will take up the following charges, and if I could read those, many of you in the audience have read them, but those that are watching haven't, as given to us by the Lieutenant Governor, Dan Patrick. We'll first take up the addressing social impacts of THC product consumption. And the charge is to study the impact of THC on increased healthcare costs, mental health emergency detentions, and the risk of being diagnosed with a THC-induced psychotic disorder. Make recommendations to decrease healthcare and criminal justice costs. The second charge we'll take up today is strengthening crisis-related mental health and homelessness services. And the charge specifically says, determine the state's authority and procedures for providing public mental health services and the intersection of those services with homelessness and addiction. Evaluate the effectiveness, consistency, and outcomes of competency restoration for criminally charged individuals awaiting trial, as well as processes for civil inpatient and outpatient commitments. Make recommendations to prioritize the most acute populations for treatment in order to reduce public safety threats. And then under our monitoring charges today, we will monitor the mental health programs and services provided through the Texas Child Mental Health Care Consortium, better known as TCHAT. So members, I do want to thank the Lieutenant Governor for trusting these topics to our committee. These are important issues for all Texans, and I'm grateful for his leadership and, again, the trust that he puts in us as members. We are all acutely aware of the issues and challenges related to homelessness in Texas, whether it's here in Austin, the capital city, or in many other areas of our state. It's crucial to delve into the mental health connection to the homeless problem. If not, we will waste time and funding on narrow-minded programs that have seemingly proven not to work. The state of California famously spent $24 billion to tackle their homeless problem over the past 5 years, yet last year found they have essentially the same level of homelessness as when they began. Many feel those funds were untraceable across over 30 programs that viewed being homeless as a housing problem instead of perhaps underlying correlations between mental health and homelessness. In Texas, we are setting a much higher standard today. We are intentionally exploring the connection between mental health and homelessness. And we are even going to step further with an additional charge, and that is the issue and impact of THC. We all remember the efforts led by our own Vice Chair, Charles Perry, to address the availability of THC in the market. Members, your staff may have done this for you, but I think setting the stage of progression of where we are today. So going back to the 2015 session, I was a newly minted senator, not new to this building, but new to the Senate. That was SB 339 by Senator Kevin Eltife, sponsored by Representative Stephanie Click. And it created the Texas Compassionate Use Program, TCUP. It was signed by the governor, authorized DPS to license dispensing organizations, and it established a vertical integration model. The qualifying condition was intractable epilepsy only. Fast forward to 2018 when the Farm Bill passed in Congress. And then in the 86th legislative session in 2019, HB 1325 by Representative Tracy King and Charles Perry, and it legalized hemp in Texas following that Farm Bill. It removed hemp from the Texas Controlled Substance List, and it gave some other, established the Texas Department of Agriculture licensing program for hemp cultivation. There were some unintended consequences, which I'm sure Senator Perry will talk about too, which created the regulatory gap that enabled the rapid proliferation of high potency consumable hemp products. Then in that same session, there was HB 3703 by Stephanie Click and Senator Donna Campbell being the sponsor, and expanded TCUP qualifying conditions. It added MS, ALS, autism, terminal cancer, incurable neurodegenerative diseases. It reduced prescribing physician requirements from 2 licensed neurologists. And then in Senator Perry, you carried Senate Bill 195, which was a very important bill that required DFPS to collect data on children testing positive at birth for alcohol or controlled substances. That data collected under SB 195 shows that in FY 2024, 1,559 children tested positive at birth for THC. And in 2025, 1,896 children tested positive for birth for THC. You see that increase. In 2021, House Bill 1535, Representative Click, sponsored Senator Schwartner, further expanded TCUP to qualifying conditions and raised the THC cap. It doubled the allowable THC concentration from 0.5% to 1% by weight. It did establish the compassionate use institutional review boards, that's CURBs, to oversee research programs and study the medical use of low THC cannabis with a required biennial report. Then HB 567 by Representative Franks, the sponsor being Senator Hughes, established the patient protections for TCUP enrollees signed by Governor Abbott, and it protected TCUP enrollees and their parents or guardians from adverse legal, custody, and disciplinarian actions. It addressed concerns that TCUP enrollment could trigger DFPS involvement or be used against patients in legal proceedings. Then in this last session, 2025, the 89th, HB 46 by Representative Tracy King and Senator Perry, which most significantly expanded TCUP since the program's creation. It took that to from 3 to 15, and at least one TCUP designee per Texas Public Health Region, and satellite locations now permitted. It replaced the 1% THC by weight cap with a 10 milligram per dose unit. Added to that, and it covered added new delivery methods. And as of August 2025, Senator Perry, 123,308 patients are registered in CURT. So I will also say that Senate Bill 2024 by Senator Perry, sponsored by Senator Leach, banned the retail sale and marketing of all THC and cannabinoid vaping products in Texas. It expanded the definition of e-cigarette products to include any vape device or cartridge containing cannabinoids. It is a Class A misdemeanor offense for marketing, advertising, or selling products, which is fined up to 1 year in jail and a $4,000 fine. I will say that also during the session, Senator Perry, you worked very hard on SB 3 that would have banned the sale of consumable hemp products except CBD or CB6, I believe it is. It was vetoed by the governor. He cited constitutional challenges of the ban, and instead he offered an executive order in August of this year that mandated age restrictions, which would have put the age at 21. I think that would match our alcohol sales. It creates a THC regulatory system, and it directs TABC and the Department of State Health Services and DPS to create a comprehensive regulatory system for THC products in Texas. It expands product safety and testing requirements. It prohibits packaging or marketing that appeals to children. It increases regulation and enforcement. It creates a stricter licensing and higher fees. I will say that the Department of State Health Services proposed the following rules: age verification, inspection, total THC standard, product recall, testing and testing requirements, packaging, licensing fee. But I will say that I believe we'll find today that even though those rules have been formally adopted in March of 2026, there is a lawsuit against that. I would say very common sense approaches to being able to purchase a product of such potency by young children. So the topics we have before us are absolutely connected. How does THC impact the mental health of its users? How does mental health relate to homelessness? And how does drug use relate to homelessness? It is my hope that we can use today's testimony to better understand the mental health impact of the availability of drugs, and specifically the impact of THC. How is THC impacting the mental health and the mental stability of Texans, but specifically adolescent Texans? It is ironic that so much public health focus was dedicated to the learning loss among the young people due to COVID-19. We know that certainly does exist. However, there has not been the same level of questioning about the possibility of larger dangers of learning loss and sinking graduation rates for young people impacted by drug use, and specifically, just because of its availability, THC. Today, we will also explore the drug use impacts in our second charge, located squarely at the intersection of homelessness, mental illness, and drug addiction. How can we address the connected issues through the public mental health system? We have a growing number of individuals in Texas that are living on the streets with mental health conditions that inhibit them from seeking sustainable treatment, a stable life, and the American dream. With no comprehensive plan, we instead have a 911 system, hospital ERs, and jails that are used as the first point of entry for these complex medical conditions? Is the increased drug use from THC and other drugs causing more psychosis? Are genetic mental illnesses just on the rise? How can our law enforcement and public health agencies improve their collaboration to help more Texans? These are all questions that we may not have a clear answer to today, but I think it is incumbent upon us to ask those questions and to see if there's a way that Texas can address this that is different than other states like California, who has spent a lot of money, and yet we've not seen any improvements. The budgetary issue came up in our last hearing. Hospital costs are ballooning. And we had witnesses from the teaching hospitals of Texas, along with the Texas Hospital Association, testify to the fact that ERs are flooded with these types of cases. If you recall, I asked a specific question of our hospitals. How many people are brought to the ERs as a part of the mental health response? I've not yet received an answer from the Texas Hospital Association, but I did receive an answer from THOT, the Teaching Hospitals of Texas. It's astonishing. Let me give you those numbers. In 2025, the 17 member hospitals of THOT had 36,983 emergency detentions. That's just in those 17 hospitals. That is up from 35,995 in 2024. And to date, which would be at the end of actually May, not June, because June just ended, it's 24,826. You see that we're on a pace to nearly double those numbers from 2024 and 2025. What's that costing the taxpayers of Texas, as many of them uninsured? In 2024, just under $250 million. In 2025, $275 million, again, only at those 17 hospitals. So you have to put a times how many of the hospitals, and you get the picture. So the questions we are asking today are tough, and the answers may be even tougher. But I'm proud of the members of this committee for being the very thoughtful group of lawmakers that we are. Sometimes we agree, sometimes we don't agree, but America deserves that, and Texas deserves that. And I have faith that we can find solutions that will improve our state's public health and safety while also respecting the dignity of every Texan who has lost their way due to the fog of mental illness and substance abuse. Members, in studying for this hearing, I kept going back to just the mounds of information, statistics, and wrestling with it. And I've probably never gone into a hearing that I'm more nervous about, because this is such a large issue. And one of the things, and it's not in my notes, but I kept reading and reading, and I'm like, when I say reams of paper, I think it's over 1,000 pieces of paper that my staff gave me. Thank y'all very much. There's some things that are missing. And I called my staff at Maureen, I think it was 10:15 or 10:30 last night. And one of the things that I did miss in this was sometimes I ask, where's the family? Why is the family abandoned these individuals? Or how do we give families the tool? Shouldn't that be the heart of what we talk about? And so just down the road, we have the famous LBJ library. And this morning I was kind of doing some, we used to call it Google. I guess we're now Clauding it and Chat GPTing it and AI. And I looked back at the war on poverty, which was almost 60 years ago, when a famous Texan said, I'm going to declare war on poverty. And you look back at all those programs and you have to say, where are we today? probably know better. I looked at a lot of critics. There's some things that came out of that was okay. But really, if you look at the poverty levels, flat, about what it was back then, declined a little bit, went back up, all these different questions. I'm not sure that government solves things well for people, but today, maybe, perhaps, we can give tools to our communities. Maybe we can give tools to our families. Maybe we can give tools to caregivers that give these people a better way of life. And perhaps, just perhaps, we can look at the correlation of what you're going to hear in some of these presentations of psychosis and schizophrenia and bipolar that many are starting to prove, or the onsets of those come from drug use. I'm old enough to remember, and I don't know if it was a Democrat president or a Republican president, the frying pan and the egg. And the egg is your brain, and then it goes in the frying pan and says, this is your brain on drugs. I'm old enough to remember that. Senator, you're pretty young, so maybe you should Google that tonight or Chat GPT.
Yeah.
But these are tough issues, and so I look forward to the presentations today. The answer won't come today. We'll observe. But working with each and every one of you and our 181 members in the next session, I hope that Texas can chart a path forward. With that, I'm gonna ask Senator Perry, who's been on the front lines of this. There's some good things that have happened, and there's some bad things, and there's been some consequences. And you and I sit by each other on the Senate floor, and while we're in the same party sometimes, and we're both rural lawmakers, we don't always agree. But I've had the pleasure of serving on your committee and watching your work on this. And so with that, Senator Perry, I would like for you to address some of these issues before we get in the panel.
Thank you, Madam Chair, and I'll try not to be too repetitive. Some of your data points are my data points, so it tells us we're reading from the same playbook. At the end of the day, you and I have served long enough that we could write our own scripts, and they'd almost parallel in every aspect on most issues. This issue is interesting because it started out as an agricultural initiative. It's moved to state affairs. And I think rightfully so, it has finally found its home in the medical side of the conversation, that lots and lots of misinformation, lots of lies, lots of mischaracterizations of what THC is and what it does and what it doesn't do. And hopefully today through your committee, we'll just add more statistics. Unfortunately, as far as solutions go, we had a solution in the sense that we had a ban of the things that are causing harms in communities. Our governor vetoed it, and a large part of his veto was over we would get sued if we didn't veto this bill. Well, to the governor's surprise, maybe, but to the people involved with this industry, not surprised. This is their MO. They know they're going to get laws passed against them, and then they sue and tie it up for decades so that they can expand their addiction and trap more people in it. That is their MO. That was not news to me. I knew we were going to get sued. So the state looks kind of funny in some directions because we had a law that we would have had enforcement and had clarity for enforcement had it not been, and we would not have allowed it to go another 3 to 4 years in spreading the poisons that it does. So I'm frustrated, if you can sense that, and my frustration on this has been pretty high since 19 because it was an agricultural product that showed promise in a market for construction, for fiber replacements, for alternatives to sheetrock. It was a real product that had a history of being used for ropes for decades and still is. But what we have is the bastardization by an industry for profit and pure profit with no consideration to those people that get addicted on it over the last, I'd say, roughly 10 years. So I'm going to give a little brief update and kind of where we're at. And then I've also moved to a little more of an aggressive position. I know that y'all would find that surprising that I'd ever be aggressive about something I'm passionate about, but the cost of this stuff, the taxpayers can't afford it anymore. I mean, we are chasing addiction at every level. It infiltrates CPS, foster care, jail cells, medical, mental. Family dynamics are destroyed by it. And the cost of that, I'll give you one, $562 million in Texas agencies, $562 million in public spending on substance abuse disorders, excluding Medicaid. You know, we had a big hearing on private health insurance cost or insurance health cost, rising cost. Private employer-sponsored health plans across the nation, $61 billion associated with mental health and substance abuse disorders in 21. $35.3 billion in direct medical costs attributed to substance abuse disorders. And I know that I'm going to get beat up by all the naysayers and the haters and the trolls out there that that's substance abuse. You didn't break it out. But let me give you some statistics from TDCJ. Beginning in 22, prior to 22, surprisingly, most of this industry cranked up after 19 and about 21, 22 is when all these industries got footholds. 21, alcohol-related abuses or issues in our TDCJ was 89,182. Controlled substances was 82,848, so it was flipped. 22, controlled substances moved to 80,074 on alcohol. So since 22, it has been an exponential increase in the controlled substances. It is tied to THC. And if you go to our criminal justice system, in next session, Madam Chair, we're going to have a lot more tracking. We're going to nail down the THC instances in our ERs, in our private health insurance arenas, in our state agencies arenas, in our TDCJ systems, all across the board, because that's what they'll say, that's not THC. Well, yeah, it is. It correlates really well with this law and the abuse of it. The cost of picking up the pieces and the messes this stuff is created is going to get laid at the footstep of this industry. And we will change statutes because of the lawsuits that have come out. We will name the reasons behind the $10,000 fees per retail joint. We got kicked out. I think it's $150 something stupid license fee now. But all these little court battles that they find little workaround and loopholes, we're coming back at them. And we're going to do enforcement dollars. We're going to put enforcement in every agency that's tied to this. And this legislator, I hope the legislature is going to be very aggressive, making sure we fill up our jail cells and the problems that it's created with the people that are distributing this stuff. My patience is run thin on this. So, you mentioned HB 1325 was the hemp bill for farm and agricultural use. It's been exploited, expanded, loopholed, and created havoc amongst families, the industry, and another addiction source. This is like the vape conversation we had 15 years ago. Oh, we're not marketing it to kids. Oh, it's going to be a substitute for secondhand smoke. It's going to replace. We got kids in high school now with vapes hidden in their clothes. Superintendents don't know if it's THC or pot, but they can't do anything about it because they would literally have to require a strip search of the kid to find out what's in it until the kid freaks out in class and has a psychotic episode. Then they know it was THC. That's what we've allowed to creep in. So the cost of doing business is going to get so high that most of them will go out of business, I hope. And then the state won't be picking it up and the taxpayers won't be picking it up. Colorado's done a study. This is not a new study. The state spends $4.50 for every $1 of tax collected on to mitigate the cost of marijuana. So the idea that they're going to cover their cost is ridiculous. And that's not even including the social cost that we don't pick up. You mentioned it, 225, 1,896 kids tested positive at birth. Alcohol fetal syndrome was a big issue, still is. Unfortunately, you don't know that the kid had it until usually their puberty level. This is being tested at birth today. 2,660 calls resulting in 283% increase in calls to 218 since 18 to the Poison Control Center on cannabinoids. 2025, 44% of the calls regarding natural cannabinoids and only highlighting non-synthetic products are still extremely dangerous. 55% of the calls or 2660 of them were edible products that we banned under SB3. 51% were regarding neurological symptoms, and another 20% of victims experienced cardiovascular systems. So we're finally building data that this stuff harms not only the neurological side, but the cardiovascular side, your lungs, etc. The vape, the popcorn lung, that's in tobacco also. 6% of the caused life-threatening symptoms or exposure from cannabinoids that result in significant disability. So in the 89th, we did have some success. It snuck under the radar because they were watching the SB3, but they didn't catch the SB24. We banned all cannabinoid vape pens, including all cannabinoid vape pen cartridges. But let me give you what the industry did to that. They separate the pen and the cartridge now, put them side by side. They don't call them a vape anymore. They just separated them, and they are getting by with that. That is what this industry does. That's who we're dealing with. They have no credibility. And no, you should never believe them. So we've banned the vape pens, and it was a significant piece of their margins. And they separate the two and sell them as such individually now. That's how they work. That's what they do. And they brag about it on Facebook. Here's how you can get around it. Dishes and THC recently adopted rules regarding consumer hemp products in response to the governor's executive order. The age gate. Age gate is just another way to say this is how we gain more access to a market. Age gate does not stop sales to minors, partly because we don't enforce, but it gives this false assumption that they're being good actors. That was a give. That was low-hanging fruit. This industry knows if you put that out there after or before they start selling, that they have the quote, sympathy of the public, because now you're an adult, you can make your own decision. So to be clear, yeah, they put 21 on their sign. Some of them had done it prior to sessions because they, quote, they had a little bit of a conscience that day. But they do have it out there, but it's not stopping access to the minors. 0 to 19 cases is up exponentially. But here's the other thing. We also banned marketing to childlike products, the catchy, those are on shelves today. You know why? Because the industry sues under a First Amendment right that they cannot be regulated for how they package their products. Do you know today, if you go to those shops, you're going to see the little Skittles takeoffs and all the cartoonish stuff still sitting on the shelf because the industry would sue you. That's this industry. So we have been vindicated. And I knew we would be. But, again, industry ties us up in courts. Texas Supreme Court held that dishes can schedule Delta 8 and any other form of THC as a controlled substance other than Delta 9 that falls below 0.3% THC. 0.3% THC was the federal act, the Agricultural Code Act, in which DEA and the Drug Administration and all of the federal laws said this is not intended to be a consumable product. Never was, never has been, and the 0.3 has always been in federal statute. Texas has been tied up in court since 19 over this issue. Supreme Court has held dishes has the right to regulate as a controlled substance the Delta 9 above, or Delta 8s, the synthetics. Anything below 0.3% is legal, and that's consistent with federal law. But the industry can't survive on that. They like to get you extremely high very quickly on stuff that you don't know what's in it. So they're not going to let that stand. They're going to try to figure out how to get it to the Supreme Court and tie it up in court. What's going on in the federal hemp law? To this administration's credit, I know that people read it as mixed messages, but it's truly not. It's consistent with Texas teacup. Federal law, current federal law, no 3% Delta 9 THC is legal federally. That is the Agricultural Code. That is DEA. That is the whole federal administration's agency levels that interact with the THC conversation. However, the new federal law Takes effect in November 26. I'm assuming that there's lots of money been written to federal legislators and lots of lawsuits pending coming. No more than 0.3% total THC. It's consistent. No more than 0.4 milligrams of THC per product, and it bans all synthetics because the Agricultural Code Act was never meant to be consumables or synthetics. So it's in our favor through November 26 when it goes in effect. I'm holding my breath, but I'm sure the industry is going to spend enough money to buy enough influence to try to sway it. But we'll see where that goes. What is consistent with Texas and federal law, and I'll personally say this, I have empathy, compassion, and sympathy for those that are tied up in addiction. For whatever reason, be it organic trauma, the third-party trauma, whatever your reasoning is, whether it's unmet expectations and you just don't deal with life, I can appreciate the need for comfort and to be truthful. None of this solves the problem. It may numb you from the problems, but it doesn't solve them. It's a passive. It kind of gets you on. You can control it maybe, but I have that compassion and sympathy. But at the end of the day, the taxpayers can't afford a whole lot more of this because truthfully, there's only one way to change this, and it's an individual decision to change. You got to have a heart conversion. Hopefully you've got a support. Hopefully you got people that have the faith. It's the Trinity. The good Lord that created us, the Christ that saved us, and a Spirit that moves us. We're at our breaking point financially. I'm at my breaking point from a conscience level. I don't know as a society how we can allow this stuff to perpetuate itself in the name of profit. I don't know how these industries live with themselves or look at themselves in the mirror every day knowing what they're doing. But as a state legislature, I'm tired of chasing addiction with another addiction and having the taxpayers fund it. So the taxpayer is going to stop funding at a minimum next session. There's going to be analysis done, and we're going to have the dollars to support the ask. If we're going to have to keep some element of this. But what is consistent with the federal law and the state law is we do see that if you're in the addiction and this provides some minimum relief, although it does not solve your problem, and you need it to get along the day as much as you can, then it goes under the teacup program. It will be administered by a physician that has your best interests at heart and knows your complete medical and mental history. That's what's consistent with the federal law. And that's what he did when he, quote, descheduled it, as much as I don't like that idea because it just opens another foothold. This is the MO. This industry is extremely patient. They got time on their side. They're going to work through it, but they know if they can get a medical federal conversation started, then it moves to recreational. By the way, most of your recreational states regret ever doing it. They've seen the consequences of it. They've seen workforce productivity drop. They've seen car wrecks and accidents and unintended consequences from it. They've seen addiction spiral out of control, and they aren't making money on it, and they wish they could get Pandora's box back. Texas is fighting it for its life on this issue. You know, Ronald Reagan's wife, I think Nancy's the one that started war on drugs. And she was made fun of and still is today. But, you know, she was right. She saw the big picture of where this stuff is so insidious and it gets into every fiber of society and every element of a family that it gets a hold of. So here we are today. We have a teacup program. It will be fairly robust once it's fully intact. I will tell you, hundreds of applicants applied for that, and the majority of those applicants were recreational pot companies from around the country. They weren't people with a heart to try to fix somebody's ailments on a medical level. So don't kid yourself. And I think DPS has done a pretty good job of trying to filter out what is, quote, good versus bad. But at the end of the day, this industry is, it's just pathetically motivated to do bad things so they can make a lot of money. I'm glad we're having the hearing about the medical side of this and the things that go with it. I'm just kind of done. You know, this session is kind of a solution-driven session for me. I don't know where this lands. I'm filing the ban again with things that the courts have ruled that we didn't do to get that right and see what next level they can come up with. But at some point, the court's got to say, you know what? They've answered all our questions, and maybe this next session's it. But I don't want to see another family with a kid in a basement that's non-articulate because they drank a THC beverage or they smoked something from a vape that they didn't know what was in it, or it's 100 times what it was supposed to be. There's nothing good from this stuff. There's no virtue in it. You know, the interesting dynamic is, and I don't know how to read this, but the alcohol industry has said that their sales are way down because this industry is taking their market share away. So I don't know how to read that, but that's kind of where it's a big industry and it's gotten a big foothold illegally. And they'll argue it's legal, but they're just playing courtroom shenanigans. They've never tested the merits of the product. Thank you, Madam Chair.
Thank you. Members, between the chair and vice chair, we've taken up a good portion of your day, but I appreciate your passion, Senator Perry, sitting on your side of the floor, our side of the floor. I watched your emotion, your passion to do what's right, and Texas is better for it. Thank you for your leadership. Members, any other statements? With that, we will move forward in the panel that we have assembled today. I think members, today we're not taking public testimony because it's going to be a long day. So I think that most of you have already registered. So the chair calls Aubrey Adams, Steve Dye, Donnie Lucia, Domini Lucia, Dr. Lucia, Dr. Matthew Rossheim, and Dr. Amanda Hall. I believe we have 5 seats up here. And the microphone moves. So you're going to have to pick it up and move it over by you, and y'all are going to have to pass it along. We will start today with Miss Adams. Miss Adams, welcome. Thank you for being here today. And let me say, while we're not going to do the timer today, is that not coming on? Hold on one second. How about now?
Yes, we got it now. Thank you.
And what we're going to try to do is we're going to hold our answers till the end. We're going to give you each about 10 minutes, maybe a little less, a little more. I'll move you along. Just again, a long day ahead of us.
Good morning, Chair Colhorst, Vice Chair Perry, and the members of the committee. Thank you for this opportunity. They call fentanyl a weapon of mass destruction. I disagree. Fentanyl is a weapon of mass death. THC is a weapon of mass destruction, causing chemical injuries to the brain and the body. My name is Aubrey Adams. I'm from your future, Pueblo, Colorado. Colorado was promised marijuana legalization would be safe. Instead, my hometown went from the home of heroes and being famous for the Pueblo chili to being known as the Napa Valley of marijuana, where homelessness, organized crime, and violence have flourished. Oops. In March of 2025, the Wall Street Journal published an article, The Rise and Fall of the Napa Valley of Cannabis, about my town. Marijuana businesses are now closing, leaving our community to bear the lasting social and economic costs that were never fully counted. These weren't costs I watched on television. They happened in my own neighborhood. Brad Fowler was murdered over a sale of legally homegrown marijuana. His body was found laying feet from my parents' garage on a Friday morning at 9 a.m. Another Friday, just after noon, gunfire erupted in front of my house and vehicles crashed in my neighbor's yard. Marijuana legalization empowers gangs, illegal trafficking, and organized crime. Home grows of marijuana turn every home into a potential drug house. Within 1 block of my home were 2 marijuana grow houses, and my neighbor, who had 3 young boys, couldn't let their kids play outside because of the marijuana smoke, odor, and drug trafficking. I gave marijuana tours to people across the country and from other countries to show them the reality of legalization and that the media and the elected officials weren't showing. I took these photos from my friend's horse training ranch. Families stopped bringing their children there because the marijuana was being grown behind the fence and processed in the barn next door. I was also featured in a documentary called Chronic State, where you see me show a marijuana operation run by Cuban nationals. But my story is really about my son. We were a happy family, active in church, Boy Scouts, and our children's school. He became addicted to marijuana. He got industry products at school and neighbors. The neighbors gave him their legally homegrown marijuana in exchange to sell to other kids. Then came the paranoia, delusions, and violence. My son ran barefoot. My younger son ran barefoot through the snow to escape my older son. I didn't know I was witnessing THC-induced psychosis. My older son attempted suicide and was hospitalized multiple times. When I asked if drugs were involved, I was told, it's just marijuana. Be grateful it's not meth or heroin. We were in crisis, desperate. I turned to the Department of Social Services because I couldn't find treatment for cannabis use disorder. They provided a home therapist and 23-hour holds in a juvenile detention center, which saved my life and his life several times. I lost my dream job because I had to protect my family 24/7. Some nights we locked ourselves in our bedroom, and I prayed my son wouldn't find the key to unlock our gun. No one talks about the jobs the families lose or the trauma we endure. My son briefly progressed to meth, entered an inpatient treatment, and was heavily medicated. After discharge, he relapsed to THC, calling it his medicine. After about a year, social services closed our case, saying there was nothing they could do anymore. After another police confrontation, sorry, I think I'm way ahead of myself here. Here we go. After another police confrontation and being detained, denied treatment unless we could come up with $36,000, we found a dual diagnosis program in San Diego. He tested positive only for THC, and there he recovered. He became a leader in his program. Then we found Houston Family Recovery Community, where host families welcomed him into their homes. Something's wrong with this. It's jumping around. I'm sorry. Excuse me. There we go. Meanwhile, my husband was told marijuana was safe for his trauma and panic attacks. After using 24% THC purchased at this store in Pueblo West, Colorado, he didn't get better. He became depressed, suicidal, and emotionally unstable. He was hospitalized in a psychiatric unit and suspended from his job. Before his discharge, the staff there warned me to leave because they feared his behavior would escalate. I packed what I could fit in my car, some clothes, lawn chairs, air mattresses, my 2 dogs, and we started over in Houston. We joined my son's recovery community, and I became a host mom for youth, for teens and young adults in recovery. My younger son, who never used drugs, developed PTSD from his brother's psychosis, and he attended Archway Academy, a recovery high school. My older son never made it back to high school. Then, hemp-derived THC products appeared in smoke shops in 2019. Because my son's treatment program allowed nicotine vaping as a harm reduction strategy, he regularly visited these smoke shops where he was pressured and marketed to try THC at the age of 19. After 3 years of sobriety, my son relapsed. He became estranged from our family for almost 5 years as his mental and physical health deteriorated. During this time, I founded Citizens for a Safe and Healthy Texas to prevent Texas families from living Colorado's nightmare and to expose how hemp-derived THC became legal. Treatment wasn't affordable. We lost all our equity. I was diagnosed with cancer. To pay for my son's treatment, I lived in a friend's house for only $150 a month. Their generosity helped me keep going. My husband eventually realized THC was harming him. After he quit, his doctors were able to discontinue his psychiatric medications, and I finally felt like I had my husband back. After 8 years of separation, I moved back to Colorado to live with him and heal our relationship. Then in June of 2025, when I was advocating for SB 3 to ban hemp-derived THC, my son called. He said, "Mom, I'm going to take my life today. I don't want to live like this anymore. You've done everything you could. Please don't blame yourself." He survived. We flew to Houston and we brought him home. The upper picture is when he's healthy. The middle picture is when he looked like last June. He's emaciated, unable to eat, testing only positive for THC. You can see how thin his legs are. That's the hotel we had him in. He said an ER doctor diagnosed him with cannabinoid hyperemesis syndrome, CHS. He detoxed at our home, walking for hours a day to calm his brain. It took 5 months for him to test negative for THC. 5 months. Today, he's gained weight, he has a job, but he still fights every day for his mental stability. And he tells me, "Mom, tell the legislators marijuana's poison." Behind every marijuana policies are families like mine. This is Ladin Skinner from Texas, once an athlete, an engineering major, an aspiring model. He now lives with cannabis-induced psychosis that has led to repeated hospitalizations, homelessness, and jail. He's only 23 years old. My community in Colorado is still suffering. Homelessness and psychosis have become common in our neighborhood. One young homeless man sat on my front steps for hours talking to people who weren't there. You'll see him on the left. Another wandered in the Sam's Club parking lot, an obvious mental crisis. He had a mask on and was screaming not nice things. Today, my neighborhood is filled with boarded up businesses, burned homes, and abandoned properties. This is my neighborhood I live in Colorado. This is not the Pueblo where I raised my children. I no longer feel safe in my home. When my home has been vandalized, I call the police. They don't come. They say I'm not a priority. People do die from the effects of marijuana. Cannabis-induced psychosis can end in suicide or progressing to other drugs like fentanyl, as people are desperately trying to escape the paranoia, voices, and hallucinations. Because our government rarely tracks marijuana-related deaths or routinely tests for THC, I created the Every Brain Matters Memorial, and I'm honored it is recognized in the 2026 White House National Drug Control Strategy, an important step towards acknowledging these lives lost. In 2018, I estimated that marijuana had already cost my family $170,000, not counting the lifelong trauma. That's why I produced Colorado's Cannabis Crisis, Profit or Loss, to ensure policymakers hear the truth from Colorado's experts. Through my national organization, Every Brain Matters, we provide free online support groups for families affected by marijuana addiction, psychosis, and CHS. We equip families with hope and recovery tools, but most of all, we help them survive when public policy has failed them and marijuana promoters blame them. My final message is, whether THC comes from marijuana or hemp, it can cause psychosis and has the highest transition rate to schizophrenia among all drugs, including meth. You can't regulate away psychosis. You cannot tax away schizophrenia. You cannot pay away the suffering of families. No state should consider retail THC. There's a devastating lack of education, and no medical or behavioral health system can handle the consequences. Please, committee, do everything you can to protect Texas families. I would also like to add, after a year of trying to meet directly with Governor Abbott, his staff is telling me he's too busy to meet with the families that have been harmed here in Texas. I hope he changes his mind. Thank you for this opportunity to share my story.
Thank you, Ms. Adams, for that heartfelt testimony. We're sorry for your suffering, and we continue to pray for your sons and your family.
Thank you.
God bless you.
God bless you too. Thank you for all you're doing. Thank you.
Chief Dye.
Yes, ma'am. Good morning.
If you would move that, Chief.
Good morning, Chair Colkhurst, Vice Chair Perry, committee members. My name is Steve Dye. I'm here this morning representing the almost 1,700 chiefs of police that are members of the Texas Police Chiefs Association. Sheriff Hawthorne also wanted me to tell you, because our concerns and observations are identical, that I'm also speaking this morning for the Sheriff's Association of Texas. On behalf of TPCA, we thank this committee for addressing the societal impacts of THC product consumption. TPCA looks forward to the continued conversation on how to best protect the health and safety of our communities. Validated medical research continues to be published, verifying that THC consumable products are extremely harmful, particularly in our younger populations. Our continued local engagement with our citizens still finds significant community concerns about the proliferation of these businesses and the accessibility of these products in our communities throughout the state. Our public safety concerns and observations continue to include cannabinoid variants being chemically modified from industrial hemp, then mislabeled as edibles and other consumables and openly and illegally sold in Texas. State regulations have not been effective, with more than one aspect of those regulations already being legally challenged. State regulations do not restrict packaging in ways that appeal to children. Products with high THC content continue to be marketed and sold as hemp products. No established guidelines exist on the amount of THC that is safe to consume. Police investigations have found these consumable products testing up to 80% THC concentration, well above the legal limit of 0.3% for hemp products naturally grown or from marijuana in the past that had a THC concentration of less than 5%. THC concentrates such as waxes, oils, and shatter can exceed 80% THC concentration. THC is infused into normal-looking foods and packaging and sugary flavors often targeted at youth consumers. Data suggests that THC products become more available in the environment, or as they become more available in an environment for adults, its access to children also increases. Evidence suggests that heavy and early use of cannabinoid and cannabis is associated with an increased risk of developing schizophrenia, bipolar disorder, depression, and anxiety. Emerging studies suggest high THC increases the risk of psychotic symptoms and cannabis use disorder in heavy users. Today's cannabis variants are isolating higher amounts of psychoactive compounds, making it more likely a person develops an addiction. Some studies have shown underage consumption may lower IQ in young adulthood. The law enforcement challenges for these THC consumable products continue to include loopholes in the current law allow THC compounds to be sold as hemp and have created a vast retail market for these unregulated products. At last count, almost 9,000 retail locations. Manufacturers make the erroneous argument that Delta 8 THC variant products are hemp products and not cannabis products, therefore making them legal. Labels on many products do not reflect the level of actual amount of THC inside the package. Mislabeling is leading to accidental intoxication and overdoses. Cannabis plants naturally create numerous compounds called cannabinoids, therefore making it impossible for police officers to distinguish between each. Before criminal charges can be filed, products seized by law enforcement must be tested by a certified lab, which creates a significant expense that most cities cannot afford. Police departments that do file criminal cases, like mine and me, are often sued by the hemp industry, creating yet another expense for cities to endure. Police canines cannot distinguish between THC consumables and hemp. Minimal data is available on how these consumable THC products affect driving behavior, and intoxication levels are oftentimes difficult to detect. Most THC products are produced out of state where Texas has no oversight authority for quality control. THC consumable products are intoxicating and yet another issue dropped on the doorstep of law enforcement to handle along with all of the other societal problems that we have inherited over the last couple of decades. Daily, officers around the state of Texas are dealing with significant issues because juveniles have become addicted to these highly potent products, which are devastating many families. The reality is the public perceptions of marijuana have not kept pace with the easy accessibility of high potency and more dangerous products. The wealth of the cannabis industry continues to override community and legislative efforts aimed at protecting the health, bless you, and safety of our communities. The proceeds from these THC consumables are vast, with some flowing into foreign nation states. I would be remiss if I did not add that TPCA studied but could not support regulation for many reasons. But essentially, for regulation to be effective, you have to have two ingredients: a trustworthy industry and enough regulators. We have neither. We did support the expansion of TCUP because we want people with legitimate medical issues to see licensed medical professionals in lieu of self-medicating. I'm going to show you some pictures now on some of the stores in our city and around the state. As you can see, as Senator Perry mentioned, still packaged to look like chips, snacks, candies, obviously aimed at our youth particularly. You'll see some more photographs at the top. On one of the search warrants that we ran in Allen, this was a minimum daily sales goal from one of our stores. The clerk said that they usually hit the supermax. That store is open 7 days a week. There's over 20 stores just in my city. Multiply $7,000 by 9,000 stores.
How many?
That's the money.
How many?
We think there's about 9,000, give or take, known retailers. So you've got billions of dollars flowing through these stores. And we do, as I mentioned, we do know that a lot of this money is ending up overseas. This is an example of an officer in an investigation where we have two concerns. The labeling does not match the actual THC concentration in the package, but what we've also seen is covering labels. So on these two products, what you'll see is they covered the label with a label that said it was below 0.3%, when in fact it was well above 0.3%. We have made public videos going into these stores where the clerks are telling us they know these get you high. They'll tell us which ones are the strongest. And so this is intentional deception. Again, most of the products coming in from out of state, we have no way to validate the authenticity of what their lab reports say, other than when we're able to send it to a certified lab in Texas and find out that, in fact, many times it was over the 0.3%. And I think that's the last one, Maureen. So thank you for your time this morning. I'll be happy to answer any questions at the end.
Thank you, Chief. We appreciate that presentation. We'll definitely have some more questions. Doctor, if you would state your name for the record, who you're with, and you may begin your testimony.
All right. Good morning, Chair Colcourse, Vice Chair Perry, and the committee members. I'm Dr. Dominic Lucia, a board-certified physician in general emergency medicine, as well
Dr.
as
Lucia, pull that microphone just a little closer to you and pull it up like this. It bends. There you go. We want to hear everything you have to say. Good.
board-certified in both general emergency medicine as well as pediatric emergency medicine, representing the Texas Medical Association and over 60,000 members. We thank this committee and the Lieutenant Governor for spotlighting the growing impact of tetrahydrocannabinol, THC products on Texans and the healthcare system. I also want to take a brief moment to acknowledge my wonderful family, my wife and 6 kids who have joined us today.
You have 6 kids?
I do.
God bless you.
God bless me. 5
And
of them
thank
are
you.
daughters. Yeah.
5 daughters. You are truly
I'm very blessed.
You'll never spend a
Absolutely.
holiday alone. Congratulations.
Based on my experience in one of the largest pediatric emergency departments in Central Texas, I'm increasingly concerned about the impact that THC use has on infants, children, and adolescents. Unfortunately, my emergency physician colleagues and I witnessed the negative impacts THC has on our patients, including profound sedation, respiratory depression, altered mental status, all resulting in intensive care and monitoring in the ER setting and beyond in our ICUs. By now, we've all seen how widely THC products are available on the market. Emergency department visits related to THC have also demonstrated an alarming and significant rise over the past several years. At my pediatric hospital, cannabis overdose visits have more than quadrupled from 2021 to 2025. And in our hospital system of Baylor Scott and White Health, those encounters were 348 in 2021 and now 900 plus in 2025. Additionally, poison center calls related to THC increased sharply from just under 700 in 2018 to more than 2,600 calls in 2025. And over half of those cases involved individuals 19 years old and younger, including 23.5% among children aged 5 and under.
Get out.
My daughter Ember back there is 4 years old. I'd like to share a few patient stories to add some texture to my comments today as we go through. Nurse comes in to the doc workroom. We have an altered mental status in room 3, and it is a 4-year-old. And we'll change the name to protect those. We'll call him Rhett. I rush into the room with my residents. The nurse is already hooking up, monitoring on this child. He is breathing extremely slowly, way slower than he should. Eyes are rolled back in his head, pale as a ghost. Mom is crying. Father's quiet. I do a sternal rub. That's the first thing you do to try to wake Rhett up. And he gives me a little gasp, a little grunt. We automatically prepare airway protection equipment. We get monitoring on him. Then the next hour, we spend thousands, if not hundreds of thousands of dollars working Rhett up to see why he came in altered, why he's nearly unconscious. He requires external respiratory support. And only about 2 hours into the ED visit, as we're waiting for some of the labs, including the urine drug tests, are the parents able to tell me that they called back and the older sibling has told them that they had some gummies in their room and there was 2 of them on the nightstand and now they're missing. And if you know these gummies, they can provide 25 to 50 milligrams each on a tiny little body like Rhett. That's a massive amount. Rhett now has to spend the next 2 days in our pediatric ICU, being monitored consistently. His parents are a mess, his siblings are a mess, and it has a major impact just from this accidental ingestion on this family. And children like Rhett are particularly vulnerable to consequences of accidental ingestion and poisoning, including serious effects on neurologic and respiratory function, increased susceptibility to mental health conditions as they get older. THC poisoning can persist for hours, with growing numbers of cases, as I mentioned, requiring ICU admission. We'll take another case a couple of years ago I had. We'll call her Julie, new to the area, new to a local high school, 15 years old. Found unconscious in one of the school restrooms. 911 was called. Julie was rushed into our ER. Again, not that much different picture than Rhett. Unconscious, what we call snoring, agonal respirations, barely breathing, only grunting to pain at that point. Parents followed close behind, came in, had no clue what was going on. With some investigative work, some input from the other kids at the school, we actually found in her backpack an empty bag of Stonios, which is an Oreo mimic. It was packaged in the blue Oreo paper. Each cookie, 50 milligrams of THC. She had ingested 2 of those, which was enough to keep her asleep and altered for the next 36 hours. She was admitted to our ICU with intensive care, nurses at the bedside, monitoring external respiratory support, and eventually woke up enough to take the steps to ambulate, to be able to eat on her own, and eventually go home. You can only imagine how that impacted that family, both socially and financially, from that hospital stay. During adolescence and young adulthood, there's critical development that goes on, decision-making, impulse control, and THC use, particularly in the form of addiction, can lead to long-term negative impacts on attention, memory, and learning. We also know that teenagers and young adults who use THC are at higher risk for developing substance use disorders. About 3 in 10 people who use cannabis may develop cannabis use disorder, particularly early with continued use. In short term, THC use we see in the ER impaired judgment, altered perception, anxiety, panic, temporary psychosis, hallucinations and paranoia, and impaired coordination and reaction time. Long-term effects are equally concerning, including potential addiction, unmasking psychosis, schizophrenia, cognitive impairments, and CHS, which is mentioned earlier, cannabinoid hyperemesis syndrome. Another example from my ER is a young man we'll call Justin, 17 years old. Within 1 month in our ER, Justin visited our emergency department 14 times. He was in there with cannabis hyperemesis syndrome, could not stop throwing up. The hot showers at home are not working anymore. He was losing weight rapidly. He was often dehydrated and would come in each visit using hours and hours of bedtime while I had injured and ill toddlers and children out in the waiting room. He first did not admit to using this, but after the second or third visit and some drug testing that he and his mother consented to, we found out that what the issue was. He kept coming back and back. And in his case, I don't know of his ultimate outcome, but we've seen patients like Justin that then convert to schizophrenia. They convert to the psychosis part of it, depression, anxiety, and they keep treating with the thing that is causing it. That's the trap here. And then there's impact on adults. There's alarming trends that extend into adulthood. According to 2025 National Health Rankings, 14.4% of adults in Texas report using cannabis products in the last 12 months. A lot of them are self-medicating, masking true psychiatric issues. And then recreational use is not without its bad outcomes. One of my chief residents recently told me last month there were 3 young women who were getting together. They had been friends in college. They're in their late 20s. They're getting together to share memories. And one of them brought some edibles. None of them had ever had edibles before. They decided to try it that night for fun. The husband of one of them walked in, all three unconscious, passed out. These products, you don't know the levels of them. Most people aren't aware. They're dressed up in these pretty packages. That was 3 different ambulance transports to the ER. Both of them required boarding in our adult level 1 trauma center emergency department anywhere from 24 to 36 hours. There are no beds upstairs. There's 40, 50 patients in the waiting room, all because of this recreational use of THC. So from perspective of pediatric healthcare, our young Texans are facing both immediate and long-term physical and mental harm from increasing exposure to THC products among children and adolescents, often in forms that are more potent, accessible, and more attractive to youth than ever before. Safeguards that center on public safety, comprehensive health of Texans, and reducing the burden of preventable healthcare costs must be prioritized. Thank you again for this opportunity to speak about our concerns in the healthcare field regarding THC consumption and the health, safety, and well-being of children, teens, and adults across our great state.
Thank you, Doctor. Dr. Rossheim?
First of all, thank you to the chair, the vice chair, and the committee for inviting me to testify today. My name's Matthew Rossheim. I'm an associate professor at the University of North Texas Health Science Center in Fort Worth, Texas, and I also serve as a scientific advisor for Texans for a Safe and Drug-Free Youth. However, today I'm here on my own time talking about the research that I've conducted on these substances. I'm a public health researcher with 18 years of experience conducting research on the marketing, regulation, use, and harms of intoxicating substances, and I've published more than 100 peer-reviewed publications on this topic. My research focuses on THC and other intoxicating consumer products, particularly how retail availability, marketing, and policy influences use and public health outcomes. So today, I'd like to make 3 main points. First, from a public health perspective, the central question is not whether a product is called hemp or marijuana. The central issue is whether these intoxicating THC products are widely available, because availability drives use and use drives harms. Much of the public discourse is focused on whether a product is classified as hemp-derived or marijuana-derived. Those distinctions may be important legally, but they're much less important from a public health perspective. Consumers are generally seeking intoxicating effects, and hemp-derived products can produce effects similar to products sold in state marijuana markets. From a public health perspective, the relevant exposure is THC. The 2024 National Academies on Science, Engineering, and Medicine report concluded that THC use is associated with increased risks of psychosis, progression to schizophrenia spectrum disorders, motor vehicle crashes, and respiratory injury. The report also identified evidence linking THC use to depression, anxiety, bipolar relapse, suicidal ideation, poisonings, and other adverse health outcomes. And youth and young adults are especially vulnerable to many of these risks because the brain continues developing into young adulthood. And some of the national research that we've conducted on increased THC poisonings have mirrored what we've seen in Texas, strikingly similar. So in one study using a nationally representative sample of hospital emergency department visits from 2018 to 2023, we observed over a 400% increase in pediatric poisonings, that is from kids from 0 to 11 years old, and 90% of them were for kids 4 years and younger. And so calls to poison control centers, emergency department visits involving THC, they've all increased substantially in recent years, particularly among young people. But the risks are clear for everyone, not just young people. According to national surveys, today more than 20 million Americans meet criteria for a cannabis use disorder, which is the scientific terminology for addiction. Importantly, these harms arise from the THC itself. There's no regulatory framework that can eliminate the inherent risks associated with THC use. The primary way to reduce these harms at a population level is to reduce the retail availability of intoxicating THC products. And one of the most consistent findings in the public health research literature is that greater availability of psychoactive substances leads to greater use. This has been observed for alcohol, tobacco, THC, and other substances. My research has also documented widespread retail availability of intoxicating THC products both in Texas and nationally. I did a survey of vape shops across all 50 states, Washington, D.C., and Puerto Rico, and found that 74% of them were selling intoxicating THC products. But these products are also being sold in gas stations, convenience stores, grocery stores, and other retail settings that are widely available to the public. And retail availability is not just merely a convenience issue, it's one of the strongest determinants of use. When products become easier to obtain, more people use them, and when more people use them, more people are harmed from them. They suffer the adverse health, safety, and social consequences associated with using these products. So availability drives harm, and use drives harm. Availability drives use, and use drives harm. Second point is that the public health test for THC retail policy is whether it meaningfully reduces retail availability in practice. So not surprisingly, our national research found that states that prohibited the sale of intoxicating hemp-derived products had substantially lower retail availability than states that permitted sales, to the tune of 16 times the odds. Lower selling these products. By contrast, states that had regulatory approaches that were short of prohibitions were not at all significantly associated with retail availability. It was not even clinically significant. So it was like 90% versus 92%. So in other words, the strongest predictor of whether these products are widely available in retail stores or whether they're prohibited under state law. In contrast, states with extensive regulations often continue to experience widespread retail availability, especially when laws are difficult to enforce or leave gaps that can be exploited. And you mentioned one of the gaps that they're exploiting here in Texas. Texas took an important step with Senate Bill 2024 by targeting THC vapes and concentrates. From a public health perspective, this modality-based restriction is very meaningful because vapes and other material that can be vaped, like these high-potency concentrates, can deliver extremely high doses of THC. At the same time, the broader scientific lesson is that product-specific laws work best when they're part of a comprehensive and enforceable framework. If one product category is restricted, but other intoxicating THC products remain widely available, retailers and consumers may shift toward other products that produce similarly intoxicating effects. And so the effectiveness of a policy depends not only on how strong it appears on paper, but whether it meaningfully reduces retail availability in practice. Third, THC products are often sold within a broader retail market built around intoxicating substances. So in 2025, I did an investigation of major smoke shop chains in Texas, and I documented the sale of all of them selling not just THC products, but other hallucinogens and inhalants and things that act on opioid receptors and other psychoactive substances. And this is really important because policymakers are not simply addressing one product category. They're addressing a rapidly evolving retail marketplace that's centered on the sale of intoxicating products. And so these findings suggest that many of these businesses are not organized around health or wellness or therapeutic products. Rather, they operate within a retail model that's built around the sale of intoxicating substances. And so as restrictions are placed on one product category, we see this within Texas and in other states, they're substituting them by pivoting towards other intoxicating substances that they sell. When I ask sometimes about THC in states that have banned it, they say no, but we have hallucinogenic mushrooms and kratom and whippets and all these other intoxicants that you can purchase. Several of the products identified in our investigation have been the subject of FDA warnings regarding serious adverse health effects, and this observation is difficult to reconcile with claims that these businesses primarily function as health or wellness-oriented retailers. For policymakers, the broader takeaway is that the public health challenge extends beyond any single product. It includes a retail marketplace whose commercial incentives are closely tied to the sale of intoxicating substances, often including products associated with significant health risks. So in closing, I just want to emphasize three main points. One is that from a public health perspective, the concern is exposure to intoxicating THC products, that retail availability is driving use, and use is driving these harms. Second, the strongest policies are those that meaningfully reduce retail availability, that are enforceable and being enforced in practice. And third, Texas has already taken a really important step by targeting THC vapes and concentrates. The science suggests, though, that these modality-based restrictions are strongest when paired with broader standards that address the full range of intoxicating THC products. And as Senator Perry mentioned, the federal hemp standards that are scheduled to take effect this November provide an important regulatory benchmark. They move away from the narrow Delta-9 THC-only approach and towards total THC, including THCA and all other cannabinoids with marketed as or having similar effects as delta-9 THC. They also address cannabinoids synthesized or manufactured outside of the plant and set a very low total THC threshold for finished products. And so from a public health perspective, those features matter because they focus on the core exposure of concern, which is intoxicating THC, regardless of what chemical it is or modality. So ultimately, public health outcomes are shaped primarily by how available intoxicating THC products are in practice. The more clearly laws address total intoxicating THC exposure and retail enforcement, the more likely they are to reduce use and harms. Thank you for your time, and I look forward to any questions.
Thank you, Doctor. And Dr. Amanda Hall with the Department of State Health Services. Sorry, we have you kind of on the
I'm on the corner here.
corner
Let me
right
get-
there.
Okay, and can I also get the clicker? I'm going to move that over. Well, good morning, everyone. I'm Dr. Amanda Hall. I'm the Deputy Commissioner for the Community Health Improvement Division at the Department of State Health Services. I'm also serving as the Chief Medical Executive for the department. Today, I'm here to talk about THC exposure and health outcomes. All right. There we go. Oh. Okay. So today I'm going to be focusing on data from 4 different data sources. First, I'm going to start with data from the Texas Poison Center Network that has already been referenced by both Senator Perry as well as Dr. Lucia. I'm also going to be talking about EMS medical service response data from our EMS and trauma registry, looking at our hospital discharge data through the Texas Healthcare Information Collection, also known as THCIC, and then finally looking at death data through vital statistics. So starting with the Texas Poison Center Network, we're going to be looking at data today that ranges from January 1st of 2021 through May 30th of 2026, so partway through this year. The TPCN is made up of 6 regional poison centers that are based at hospitals across the state. All U.S. poison centers use the coding and fields from the National Poison Data System. Poison centers can receive calls from the general public, as well as healthcare providers and physicians and others who are concerned about an exposure or who have a health-related question. When receiving these calls, they track information such as exposure type, quantity, clinical effects, and demographics of the individuals that may have been exposed. On average, the TPCN receives 244,506 calls per year, or 670 calls per day. From 2021 to 2025, roughly 600,000 calls were from the caller's own residence, and nearly 285,000 were from a healthcare facility. For today, we're going to be focusing on calls received to the TPCN related to cannabinoids, including THC, CBD, and synthetic marijuana. Okay. So this slide shows data on the THC exposure calls between January 2021 and May 30th, 2026. There were 10,515 THC-related exposure calls to the center during that time period. The majority of these calls were for children aged 0 to 19. Of this group, the largest is children from the age of 0 to 5, followed by teens from the ages of 13 to 19, and then children aged 6 to 12. We're going to look in more detail on slide 8. Of the THC-related exposure calls, almost 5,000 were treated, evaluated, and released from an outpatient setting such as an emergency department. Of those, 1,138 were 0 to 5-year-olds, 474 were 6 to 12-year-olds, and 1,283 were 13 to 19-year-olds. This slide shows the annual number of calls for THC exposure concerns to the TPCN. There has been a steady increase in the number of calls over the last 5 years. The last bar is data through May of this year, and comparing it to the number of calls so far in 2026 to previous years, we continue to see an overall increase in the number of calls year over year. Slide 6 shows THC exposure calls by THC type. Cannabinoids are classified into 3 main types on how the active ingredient was sourced or modified. Natural cannabinoids are produced naturally by the plant, and this is represented by the blue bar on the graph. Semi-synthetic cannabinoids are made by chemically modifying natural cannabinoids, and it can also include some pharmaceutical preparations, but this is represented by the orange bar on the graph. Synthetic cannabinoids are human-made, mind-altering chemicals that act like naturally occurring THC. They are sold illicitly as products like K2 or Spice, and this is represented by the gray bar on the graph. The classification depends on what the patient reported or what the healthcare facility determined to be involved in the exposure. But as you can see from the chart, semi-synthetic products are increasing over time. Cannabis product types are defined by preparation method and how the cannabinoid is utilized, and that is what we're looking at here. This bar graph looks at the number of calls for the different preparations from January 21 to May of 26. Each year is represented by a different color. Please note that once again, the green bar is for part of calendar year 2026 and only shows data through May. The most common calls about THC-related products were from edibles and plants, with edible calls increasing significantly over time. As I discussed earlier, one of the most significant takeaways from the Poison Center data is the number of calls involving children. This table shows the age breakdown for THC exposure calls, and as you can see, the highest number of calls are in the youngest age group under 19. You'll also see that there are almost 1,500 calls during that same time period for 20 to 29-year-olds. There's also nearly even distribution of THC exposure calls for males and females, which has been a consistent pattern over the years. Here, we're looking at clinical effects on body systems. A patient can have multiple body systems affected by a THC exposure. These categories are not mutually exclusive. Notably, the neurologic effects are more prevalent than any other factors, with cardiovascular and gastrointestinal following behind. This slide shows the THC exposure calls broken down by healthcare treatment locations. As I shared earlier, the largest number of THC exposure cases were treated and or evaluated and released, which is the bottom row on this table. The second largest groups were managed at a non-healthcare facility. This typically means the caller's personal residence. And some additional information about the outcomes. So of the 10,515 exposure calls that were received during the time period we've been talking about, 7 calls involved in exposure that results in a death. 633 calls had a major effect, which means the person exhibited symptoms that were life-threatening or resulted in significant residual disability or disfigurement. The majority of calls were due to exposure at a person's own residence. Most calls came from a healthcare facility, the person's own residence, or another person's residence. We're now going to switch gears and we're going to talk about EMS response data. We collect this data through our EMS and trauma registry. We collect data from every EMS response. And currently we collect data from around 700 EMS agencies across Texas. The system itself currently houses over 44 million records, and while EMS agencies have up to 90 calendar days to report their data, most data is reported within 48 hours. The data we're going to look at today is from 2020 to 2024, and will cover close to 23 million EMS responses. There were roughly 4.8 million EMS responses reported to DSHS in 2024 alone. Of those, 0.002% were related to THC. Information that is transmitted to the registry includes ICD-10 codes for certain data elements, and then the team at DSHS can analyze those codes. There are 2 major ICD-10 codes related to THC exposure. They are listed on the slide. F12 covers cannabis-related disorders, including cannabis use, abuse, and dependence. And then T40 is a classification used for cannabis-related poisonings. For the EMS registry, EMS agencies have typically reported on the F12 codes. This graph shows the most recent 5 years of data for THC-related EMS responses. As you can see, the number of responses related to cannabis have decreased since 2020. Next, I'm moving on to our Healthcare Information Collection hospital discharge data, also known as THCIC, and we'll be looking at data from 2021 to 2025. THCIC involves the collection of administrative claims data from over 1,700 Texas hospitals, freestanding emergency medical centers, and ambulatory surgical centers required by Texas Health and Safety Code Chapter 108. This data set also uses ICD-10 codes, including the F12 and T40 codes that I mentioned earlier. Hospitalizations counts are tabulated using principal diagnosis, which is defined as the main reason the patient was treated based on the final determination at discharge. Each patient may have more than one hospitalization within or outside a quarter and/or a year, so it is possible that a single person could be counted more than once in this data set. So now we're looking at the data from January of 2021 through June of 2025. There were 4,315 THC-related hospitalizations reported during that time period. Similar to the Poison Center data, these hospitalizations have increased yearly. However, the percentage of total hospitalizations remains relatively stable at 0.03 to 0.04% of total hospitalizations. The greatest number of THC-related hospitalizations were for the 18 to 44-year-old age group, followed by the 0 to 17 age group. The 0 to 17 age group has had a steady increase in the number of THC-related hospitalizations during this time. Here we go. And so this slide does show the cannabis THC hospitalizations by year. And it's a little touchy. There we go. And then this slide does show the hospitalizations by year and by age group. Finally, I'm now going to look at our vital statistics data, looking at the death certificates around THC-related deaths from 2021 to 2025. This data comes from death certificates. DSHS first queries a file for ICD-10 codes for all deaths where the underlying cause of death was related to drugs. Then the search is further refined by using a free text search for keywords related to THC and the death record. And so for the 5-year time period from 2021 to 2025, there were 19 THC-related deaths of Texas residents that occurred in Texas, with the highest percentage in 18 to 44-year-olds. And that concludes my presentation, and I'm happy to answer any questions.
Thank you. I'm going to do one quick thing. Miss Adams, if you would switch out and just sit in one of the reserve seats, and Dr. Tim Stevenson, I just want to get a quick update on, welcome, Senator Miles. Good to have you here today. Please show Senator Miles as being present. Dr. Stevenson, I added you just because of last night and over the weekend looking at a few things. The question specifically that I asked you cover is where we are on lawsuits and implementation. So state your name for the record, who you're with.
Dr. Tim Stevenson, Department of State Health Services, Consumer Protection Division, on the charge.
So Senator Perry and I kind of went through different things. The Governor Abbott, issued an executive order in August of 2025. Some pretty simplistic approaches to age governance, validity of content, some of those things. What has happened since with rulemaking and then with lawsuits?
Yes, ma'am. I'm quite familiar with lawsuits in my role here in the past 6 years. I know you mentioned the governor's order starting in this year, but also or September 2025. But I do want to hit the lawsuits we've been through.
It is September 10th. That's right.
From really once the rules were first implemented in August of 2020. And the program officially started. We started licensing registrants, our licensing manufacturers, and registering retail sales of hemp distributors. We were one of the first products that came, and the definition is critical, as you and Senator Perry both gave a fantastic summary of where we are historically, but the definition of Delta-9 THC at a cap of 0.3 in the hemp product at a plain reading seems like a low-level, non-psychoactive products. However, industry very quickly started adding things like Delta-8 THC, a product synthesized from cannabidiol, which is not psychoactive, but can very quickly be converted to Delta-8 THC. It is psychoactive. Our department scheduled a slightly different schedule from the federal schedule on controlled substances because we believed that synthetic THCs could be added to the product, such as Delta-8. We were immediately embroiled in a lawsuit on that, so the department was not able to control Delta-8, which was primarily added by industry to consumables, edibles like gummies, and that hence the lawsuit. After the lawsuit, we've not been able to control that until till this time. So that was embroiled in the court. We just got the lawsuit from a decision from the Texas Supreme Court, finally making its way through the process June 5th of this year. So all of that time, Delta-8's been added by industry. We've not been able to control that in the product. Another product that was added to...
And what was that final Texas Supreme Court ruling?
Yes, ma'am. They determined that Delta-8 could and should be a controlled substance. It was not the intent of the legislature. The Supreme Court said that these products be, psychoactive products, be on the market as consumable hemp products.
So is there any mandate, age, restrictions? Where are we on all that?
So then the governor's order came. He directed us to set a age limit of 21. We immediately promulgated emergency rules to help establish that 21-year-old age gating. We collaborated with Texas Alcoholic Beverage Commission, TABC. They are helping us to test and to enforce that in the shops. So we did emergency rulemaking and then final long-term rulemaking since the governor's executive order, establishing a minimum age of 21 or above.
So that's not under a lawsuit right now.
The age restriction has not been challenged by the lawsuit, no, ma'am. In those same rules, in accordance with the governor's executive order, we included THC acid, which is another another analyte. It's naturally occurring in the cannabis plant, the tetrahydrocannabinolic acid, THCA. When heated, it's immediately converted to Delta-9 THC. And so industry's been adding that to the product, and vapes or smokable products, baking products that are to be baked, heated, concentrates, as were mentioned. Industry could add at unlimited levels until this rule went into effect March 31 of 2026. We were immediately challenged on that and constrained for a moment by the courts, but that has been reversed. It's been, and that could still be challenged in the court system. But at this moment, we're implementing and controlling THC acid along with THC Delta-9 at the 0.3 cap. So 3 lawsuits, ma'am. The Delta-8 primarily in synthetic analytes, smokable products, and now THC acid and the fees that we increased with the rules that were effective March 31. We were challenged on fees. First court said we could not charge those fees, and then that's been reversed by the appeal court. It could still be challenged up in the Texas court system.
Thank you. Before I go to the members, Chief Dye, a couple of points of clarification. I just did some simple numbers. So it's about a $25 billion industry on a good day. If you have 9,000 locations at $7,800 a day, I would say somewhere between, let's just give, not every dispensary or whatever we call them are going to have those kind of days, but it's somewhere between a $15 and $25 billion industry. Is that correct?
Well, it's everybody's best guess because there's no record keeping on these. So I would say certainly 10 to 20 would be our educated guess.
Okay.
Billion. yearly.
And that was before 2019. That industry did not exist. This is a new industry with billions of dollars. Is that correct?
For
Just off of these kind of
we
products.
saw the retail sales locations, yes, ma'am, in that 2019, 2020 time period is when they started popping up.
Okay. I want to follow up on one thing that you said, which was I loved your quote of trustworthy industry and enough regulators, and we have neither.
That is correct.
You say that most of these products are made outside of Texas. Are they made in the United States or are they made outside of the United States?
We see a lot coming out from West Colorado, California, toward the western United States.
Are they all made in the United States or some of this?
Oh, no, ma'am. No, ma'am. They're
Give me
imported
other
from
countries that
overseas.
make
Yes,
this.
ma'am. Absolutely.
Who?
Well, China for one, and others. And sometimes some of the chemicals used will come in from other states and be assembled here in the United States. That's about my limited knowledge. But yes, when they're synthesized, those chemicals can be coming from out of state. But typically, the products we see on the shelves are almost always coming from out of state, Colorado and California.
And on a lot of products, we have country of origin. Sometimes when we buy our fruits at the grocery store, I like to know where they come from.
Yes, ma'am.
We have nothing of that sort on these labels.
No, ma'am. They will come with a certificate of analysis, but we're not able to verify that because the labs are not, that are giving those COAs are not here in Texas. So what we found in our investigations, when we've actually seized and filed criminal charges and tested products in a certified lab, we found that many, many times, more than not, the content of THC in the package is far greater than what is on the label. The labeling has rarely matched up with the actual concentration of THC in the products that we've seized.
And I mean, I'm new to this because as you explained, it was kind of in the agriculture world and then it was in state affairs, but just a simple question.
Yes, ma'am.
So we have no idea the strength of these different edibles. Y'all can tell I've never been in one of these shops. Like it's in a cookie, it's in a gummy, it's in
The
a.
simple answer is no, we do not. And I can explain, but we're just validating our certified results on the level of THC versus what's on the label, and we're not finding them to be the same. Almost always much higher product in the package than what is depicted on the label in our
Anything in the
investigation.
executive order that says, hey, if you're above this level, you're going to be penalized? Anything there?
Only again, the specific chemical compound THC delta 9 is capped at 0.3. Our testing has shown that delta 9 THC is typically at the 0.3 or below. However, ma'am, all the other analytes can be added at an unlimited amount, except THC acid with the current rule. So those two compounds are controlled, the rest are not.
And then to Dr. Lucia, you talked about hospitalizations, incidents in your ER. Do you see more incidents of accidental ingestion leading to hospitalization or conscious ingestion?
Intentional, yeah, that we see more right now in teenage intentional ingestion, but we certainly see both. But if you had to score one way or the other, intentional ingestion by teenagers, adolescents is the leading group, but the accidental ingestions, as you saw with the data, are certainly there too.
I'm going to ask somebody here on this panel, could a 12-year-old, a 15-year-old walk into one of these shops and buy this product? They could
Not
before
legally,
the
ma'am.
executive order or Senator Perry's bill.
So legally, no. In practical terms, because there's such a proliferation of these retail establishments across our state, it's been very easy for them to do one of two things: have a surrogate buyer, or a person known to them that's older that they can then get the product from.
Now that
It's
happens with
accessibility.
alcohol as well.
Well, we do regular undercover stings for tobacco and alcohol.
Okay.
We find high levels of compliance, however, not perfect, however, very high levels of compliance. What we have found with the THC concentrates, because they're not being regulated otherwise, that they're equally comfortable selling at a higher rate to underage people.
Do we
is
do
what we
sting
found.
operations on THC products?
Well, we have in our department, I'll let Dr. Stevenson speak to the state.
Texas Alcoholic Beverage Commission has been helping us since the governor's order on sting operations for age.
Okay, I used to own and operate convenience stores, and like this was something we pounded in ID, and I mean, like, you know, TABC does a really good job of making sure that people aren't selling to underage.
Well, they do, but let me expound on that point. Both Dishes and TABC are great agencies, but here's the problem. TABC has 60,000 plus alcohol retailers that they already have to manage. When I need to do a proactive sting on an alcohol establishment in my city, there's a wait time. It's very difficult to get a TABC investigator because they're spread so thin across the state. So again, TPCA, we studied this. If they're not able to really effectively keep up with all the alcohol responsibilities, how are they going to be able to now add the THC responsibilities? And I can tell you since March 31st, we've seen no difference at our stores. We've had nobody coming in from the state to look at those stores. It's still been left at the doorstep of the local agency, at least at this point. Now, I get the question a lot, how is this different from alcohol? Alcohol is, they self-regulate at a very high level. When you see a container of alcohol, beer, wine, or liquor, you can be very confident that what is in that package matches the label. They're very good about regulating, and they test themselves. So that's the biggest difference is we don't really know what's in the package on a THC consumable, but you can have a high level of confidence that what you're consuming on the alcohol side is what is on the label.
Just tied to that, ma'am, the slide that I have right now shows the level of full-time equivalent, 7 inspectors for the consumable hemp program, almost 15,000 combined manufacturers and registrants. So we're getting there about every 6 to 7 years. They start with a license. We don't do pre-licensure inspection. They start a business. We get there when we can, sometimes 6, 7 years. TABC, as Chief Dye said, is spread thin, and they are helping and supporting, but the regulatory framework is very porous.
And to the doctor's point of clarification, many people say that marijuana is not addictive, rather it only causes dependency. Can you talk to that? And what's the difference for me between dependency and addictiveness? And Ms. Adams, you may want to say something to that, and then we're going to go to members. What's the difference between dependency and somebody being addicted to it? Is it synonymous or different?
It's the same. It's a physically addictive chemical. It hijacks the reward system of the brain. So when old school hippie weed was around, about 10% of users used to become addicted. Now that number's up to about 30%. So the higher the potency of the drug, the greater risk of addiction. So that's what this industry is all about, addiction economics. They want to addict their customers because they want more customers using. And I also, if you wouldn't mind, could I comment a little bit about the amount of THC in the packets that I gave you large packets today, but I wanted to equip you with the right information. When I say I'm from your future, like my colleagues and I, we have really put together some very valuable resource information. So the 0.3% is by dry weight. So one little gummy can have almost 9 to 10 milligrams of THC. And science shows a minimum of 10 milligrams can cause psychotic symptoms, meaning hallucinations, paranoia, delusions. Me, if I eat a gummy, like if I have a gummy bear, I want a handful of gummy. I like sugar. Everybody likes sugar. So a handful of gummies can have up to 100 milligrams of THC. Those are causing chemical injuries to the brain. So that's when we say 0.3%, 3%, it's by dry weight. And that law has been changed on the federal level where it's going to be cleared up. So this explains how the industry is loopholing in their deceptive predatory marketing system to get as much THC in their products as possible. They're also taking the CBD molecule and then converting it to all the different variants of THC too. So I've got that. So
Thank you.
Thank you.
Doctors, dependency versus...
Yes, so the clinical term for addiction is cannabis use disorder, and it kind of indirectly assesses the dependency on a substance in various ways. Some of the questions are about tolerance that someone's established, having to use more of it to get the same effects, withdrawal symptoms, negative consequences that they experience from use, and things like that. And so the most recent estimate was that more than 20 million Americans right now meet that criteria for a cannabis use disorder. So that's more than 7% of those 12 and older in the U.S. are meeting that criteria for basically
20 million?
20 million Americans right now, yes, meet that criteria.
How many
according to national
How many
standards.
Americans are dependent on alcohol? Anybody know that?
I don't know that off the top of my head, but I think 2022 is the first year that daily cannabis use surpassed daily alcohol use in the U.S.
So more people use.
We're using cannabis daily than alcohol daily.
And I can tell you that 10 to 15% of alcohol users become addicted or dependent. We're talking, depending on what study you look at, but the CDC is saying 30% of marijuana users are becoming addicted.
So a more addictive drug. Doctor, you got anything to add to that?
Yeah, I just think the question results in a reality of the users of cannabis are acting just like we see the users of other what we'd consider high potency drugs, heroin, fentanyl, those sorts of things. They are stuck in life over and over and over. I mentioned the teenager patient that was in our ED multiple times over a month and beyond. That was just a month sample, but those folks are back again and again because they can't stop.
So as Chair of Health and Human Services, I have to ask this question because I've, Senator Perry, during your SB3, I don't know about y'all, but I got a few emails here and there, hither and yon. And many people claim that this is something that has helped them with chronic pain. It has helped them with different issues. That is, when I went, Sarah Miles, you missed it, but I went chronologically on the number of bills that were passed since 2015. I think you joined us in the Senate in 17, 19. And so we've added certain illnesses to teacup in a way that a doctor could prescribe it. But what would you say to a veteran out there or to someone who says, hey, I lost a bunch of weight because I don't drink alcohol at night. I just take a gummy now. What would you say to them, to the doctors?
Great question. So I view these as two entirely different markets, right? It's true that cannabinoid-based medications can have therapeutic benefits for certain populations. They're FDA-approved cannabinoid-based medications for patients with severe seizure disorders, HIV/AIDS-related anorexia and wasting, chemotherapy-induced nausea and vomiting. They've deemed that for those specific populations, the benefits can outweigh the risks, even though they document that there are risks. That's not what these products are being sold for. It's illegal for them to market them for therapeutic purposes. People may anecdotally notice the benefits that they're seeking, like someone who's smoking might lose weight, or who's drinking alcohol might, it might numb some of the temporary anxiety or things, but it's not medicine and can't be sold as such. So to promote the rapid commercialization of this drug because it has some therapeutic applications, I think there are very clear parallels to opioids as well, right? That there are therapeutic and medicinal benefit to them, but they shouldn't be widely sold in smoke shops to anyone who wants to purchase them.
That would be no different than us potentially just saying we don't need pharmacists anymore. Just put everything on the...
Right. It would be promoting self-medication.
Doctor, you got anything to add to that?
He said it really, really well. At least in the emergency department population, we just don't see a lot of these positive use cases, quite frankly. On the adult side, you may see some of the cancer patients that are on it through teacup or being guided by their physician. But what we do see is the mass majority of folks that this is causing massive problems in their life that's been explained on this panel time and again.
So stat from Dishes, calls to North Texas Poison Center, which is just one, regarding children exposed to cannabis rose over 1,000% from 2019 to 2023, sobering statistic. Last thing I'll say, and I'll open it up to y'all. You use the word opium. quick search in history would talk about the first Opium War in 1839 to 1842, and then you would look at Second Opium War in 1856 to 1860. These are interesting things. We saw what that did to certain countries. The century of humiliation. Sometimes I say, are we entering that century with the side effects of a drug that we don't know what percentage is put in there? We don't even know the country of origin. We don't know what's in it. So I would say to everyone listening today, be super, 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 super careful until this new law goes into effect in November and we can wrap our arms around this. I'll go Senator Perry,
Thank you, Madam Chair.
and I'll go
Real quick. I mean, not real quick. There's so much unpack here. I want to qualify something I said. Federal and state laws are consistent on this level, and I mentioned the teacup medical application. The reason that the administration descheduled that is to provide, this is the industry narrative that he has adopted, right, wrong, or indifferent, time will tell, to provide more research opportunities to see if there are medical benefits to cannabis. That's the only thing that changed at the federal level. Now, there's already people coming out and said they're going to hit a brick wall because there's really none. But to your point, there are acute chronic ailments in cancer treatments. Of nausea was one of the big things starting out. The epilepsy, I forget the little girl's name in Colorado, escapes me, was one of those very first. So it's kind of akin to, we have methadone, right? This is kind of potentially a new methadone, but it is administered by a physician and not by a drugstore or a gas station attendant. I want to create or dispel some of the false narrative that you will hear after this hearing on Facebook. We are a 53,000 employer in the state of Texas. We provide billions in taxes. Here's what they've done, Madam Chair, with that. They've counted every gas station attendant that has one of these products on the shelf. So it's not 53,000 employees. Those will still be in business the day after a ban. So it's a false narrative. But this industry is known for false narratives. Everything they speak to is pretty much untrue. So I'm just telling you, everything you hear is probably not true. They don't have 53,000 employees that are dedicated to the sole purpose of dispensing THC product. Most of these industries will still be here the day after because they existed before. So real quick, I'm going to run down two things. I don't want to fall into the trap. I call it the trap, adult versus kids. We've all co-opted that today. It's the kid, it's the kids, it's kids. Well, we all want to protect kids. It's a primal responsibility as a human and as a parent and as a grandparent. We want to protect our kids. But this is not just a kid issue. Let's be clear. First of all, the statistic that the health 18 to 44 is one of your biggest impacted and growing populations. And you know what people tell me? Well, if it's on a retail shelf, it's got to be legal and safe. That is what the co-opting by this industry. It's on the shelf. Do you think the state or the government would let us have something that's not safe on the shelf? And in testimony in prior session, there was some definitely under 21 incidences, but there were a lot of kids. And when I say kids, 21 and up into their 30s and 40s that have impacted negatively. So do not fall into the trap that this is a minor issue, because it is affecting our adult population, our working adult population, our population we depend on to be productive tax-paying citizens and raise healthy families. So that is the growing population here, and it's only because they perceive that it wouldn't be on the shelf and available. So that's the first thing I want to hit on. Secondly, and you hit it here, so 10 milligrams is kind of where the impact sets in.
Well,
Maybe not. But what I'm getting to, I heard 25 milligram dosage, 25 to 50 on those gummies that the kids took. So truly, is 25 milligrams too much anywhere, anytime? Because I heard one of the advocates for this industry say, I took my 25 milligram gummy.
so
Today.
can I comment about
Yeah, I just want an answer. Is 25 milligrams going to produce a positive benefit?
So the problem with this drug, it's a fat soluble drug. Unlike alcohol, it's a water.
I get it. It stays around.
So you cannot predict how much THC will turn a brain into a psychotic episode.
Okay.
What we do know, the higher the potency, the more frequent the use, the younger the brain, the more at risk.
Okay. Good.
Science is showing that just a little as 10
Well,
milligrams and 5 milligrams can induce psychosis in a laboratory.
I point that out because when the general public hears 25 or 10 or 1, they don't know. And so effectively it's consistent. We really don't know how bad, at what bad level it starts.
So if I'm taking 2 or 3 milligrams of THC, maybe I've brought into the false narrative that it's going to help me with sleep, which it does not. It does not help with sleep. It disrupts the REM cycle. But if I fall into that and I'm taking like 2 milligrams a night, that fat soluble substance is building up in my body, especially my brain. So maybe in 5 days, I might have an adverse affect to it. Maybe it might take me 6 months, but that's what it's doing. It's building up in my body. And that's the biggest deception of this industry.
Right.
I want to.
I'm so sorry.
Senator Perry, you and I talked about this on the Senate floor, and you talked about it being fat soluble versus alcohol, which
Stays
is
with
water
you for
soluble.
months.
I want to hear the doctor's answer on his question.
Sure. So 5 milligrams of THC is enough to have intoxicating effects among users. 5 milligrams is, yes. In Texas, we've seen individual containers of gummies containing 10 to 20,000 milligrams of THC on the label. And so very, very high potency. And so some states have attempted to regulate the potency of them by having serving limits or container limits. And what we've seen is this usually results in just a changing of packaging and labeling, and people, it doesn't change consumer behavior. They'll cut it into smaller pieces or add more servings on the label. In some states where they have total per container of 5 milligrams, they'll use THCP, which is being marketed as 33 times more potent than regular Delta-9 THC. And there's some clinical evidence to suggest that it binds much more strongly to the CB1 and CB2 receptors. So the industry is constantly figuring out chemical workarounds. With regard to the question about therapeutic effects, I feel like that's a separate question for if it's being sold in teacup systems to figure out, but these products that are being sold in the broader retail supply chains are not being used for therapeutic purposes.
So I'm going to stay right here with the medical guys real quick. TMA, y'all have a medical license as doctors and physicians, correct?
Yes.
At what level, when some counter clerk tells you, if you take this, you will feel this way health-wise, where's the boundary? And does your association pursue practicing medicine without a law, without a license?
Yeah, I can't speak to the teacup rules. I can speak to the grittiness.
Not teacup, retail.
Of a
This is all about
person
retail.
Showing up at 2 a.m., a kid or an adult completely intoxicated. It's very difficult to tell what milligrams they took, how many of them they took. They often don't actually tell you the truth or know. And then as Chief Dye mentioned, the packaging is often bogus. So it's very difficult, at least in my clinical experience from the emergency department, to know that number.
Yeah, I'm asking, I agree with the milligrams. You say 5 is kind of a number. You say 10 is kind of a number. Truthfully, is we're not sure, but you do have evidence that 5 milligrams can get you wasted.
Yes, it
Fair
can.
enough.
Can
And this
be
is an industry
intoxicating.
built on getting you wasted. Let's be clear. On the medical licensure, what oversteps that conversation? If you have someone in your ER and they say, I've taken THC and I was told it was going to help me with migraines, is that practicing medicine?
Who are they told by?
The counter, the clerk at the counter, is that practicing medicine?
That's dangerously in that area, telling someone that.
So as a TMA association out there, I've been chastised for being too sympathetic to physicians in the sense that I really wanted them to deliver care without barrier and let them practice independently. Same time, they have arraigned me for coming after broadening the scope a little bit. But I would say there is a market prime for this conversation because they came after me on a bill last session about expanding scope for physicians, and we can have that different debate. But point being is TMA has a role in shutting down this medical delivery system that is being purported and perpetuated, falsely creating problems for you. All right. let's go to Mr. Stevens. Can you come back up real quick? It goes to Chief Dye too. You don't know if if your agency goes into one of these shops and you now have prohibitions against THCA, you have prohibitions against Delta 9 above 0.3, you have confidence that Supreme Court says Delta 8 and synthetics alike and lights are not allowable. You can't tell what that product has in there when you go into that store, can you?
No, sir, we would have to test it.
So the only way you'd know it if there was truth in labeling and it said, we have all this stuff. And they're not going to do that, obviously, because it's illegal.
Some put those on the label, the THC acid, but we haven't been able to require it.
But the point being, industry's not going to tell you the truth if they did put it on there. But my whole point, and it's Chief Dye's point, and you, sir, made an excellent data point that states that regulate gain nothing because the cost of trying to figure out who's lying is too expensive. Fair statement?
It is. Laboratory testing is very expensive.
How much does it cost to get a product tested off the shelf?
About $1,200.
$1,200 per product per test.
Yes, sir. For the battery, that would be total THC, Delta 9.
Synthetics and lights, a whole bit. So if we wanted to know if that product that's marketed as Skittles today off the counter is legal or not legal, and legal is 0.3 or less, Delta 9 only, basically.
Yes, sir.
Which takes about 99% of the products off the shelf today. We could have confidence pulling it off, but until we spent $1,200 and how many weeks?
It's about a week turnaround.
Week turnaround.
You will see some different numbers, but that's an accredited, validated laboratory.
$1,200 per product per test for 1 week. You, sir?
Interesting enough, Senator Perry, to that point, when some of the shop owners in Allen thought that the ban was going to go into law, some of them told us we're out of business because they cannot stay in business if they sell only non-intoxicating THC. So I thought that to be very interesting, and that was by their own admission.
No, that is true story. I mean, across the board, if you do the vapes and you get gummies, intoxicating levels, then we're all out of business, which is a tale, right? So my point being is, Madam Chair and members, I would love to think regulation could get you there. Maybe, I really don't. But if there's a good argument to be made for regulation, it's not going to ever get there. There's not enough money. I love your statement on that. I do think it's interesting, and you raised K2. Somebody did K2. K2 was, but I mean, Senator Huffman and me, the day it got started, there was a group of women called WASP, Women Against Synthetic Pot. And they were aggressive in that legislation. And they came in and they hit these walls, and we had kids dying on this stuff. And we outlawed it and banned it immediately. And on your chart, K2 did not expand. It's been relatively stable and constant on a very, very minimum level. So the point you made, sir, if you ban it, you will see impacts on access. K2 is a great example of that, because this is the modern day K2. It really is, because it's all synthesized. We have kratom. Kratom in its natural state provides some benefit. We have kratom synthesized that's as bad as everything we're talking about today. So it's this human need to expand something that was potentially probably good in nature. Coastal Labs, you had an interesting slide. EMS calls are down, but I would correlate that to, because what the industry is going to do is run out there and say, see, we don't have a problem because all these EMS guys are saying it's not out there anymore because they're not retrieved. The poison control calls went up. And you made the comment, a lot of this is being handled at home now. So I don't know statistically, but correlation and statistics matter to me. It seems to me as poison control saw an uptick, people weren't calling the ambulances as much.
That is correct. And I had asked the team to kind of go back and look at that. I will say that the same data we saw on the EMS responses, they said you would see similar trends when we observe fatal and non-fatal drug poisonings. They believe, looking at the 2024 data, it's more on level if we went all the way back to 2019. As far as the EMS runs go, we don't have the data yet for 2025. We have to go through our process of finalizing that. But yes, the numbers did go down while the number of calls did go up.
Well, I would think that's logical and common sense, but I knew that was going to be the narrative that comes out. And it'll still be the narrative because truth doesn't matter. But I think it's important to have that on the record, that it correlates very much so with the response that was given through poison control. Madam Chair, I could go on, and I there's a libertarian in all of us. We're all a little bit we kind of move from a little liberal to conservative, and then we always keep a little libertarian about us. And I always hear this argument, well, it's adults. Here's the difference. And I'm not going to compare addictions. I love what Governor Perry said one time. Texas is a great state on so many levels, but we're still the least drunk in the room sometimes. We've got work to do. But my point is, a libertarian that chooses to do something that is not affecting anybody but themselves, that's one thing. But when a libertarian takes a drug such as this, gets addicted, it costs me room at the ER, in my private insurance market, at the state health resources, and mental addiction to boot, or whatever other cost there is societal to the court systems, and we're not even addressing that. If you have regulations, you create a path to the court system that will not take this on because they're too busy handling the other social problems that have come from addiction. So there's no path to fix this other than getting rid of it. Because my DAs, to their credit, have to pick, do I prosecute the child rapist or do I prosecute the drug addiction? And so this is not a fixable issue, but my point, I guess, is whatever you do on your own time, if it doesn't impact me, I don't really care. But when you start costing me taxpayer dollars, then it's not a libertarian issue. It's not a right issue. And that's kind of where this cost of this stuff is about.
And I would add to that psychosis and permanent disabilities. Chief, you were shaking your head on that.
Well,
and before I go to Senator Blanco, then back to Senator Sparks, and then to
Yes, ma'am. Not to get too far off topic, but that is a legitimate obstacle for law enforcement. Cost of testing, available resources to go into these places in an undercover capacity, and many district attorneys are not filing the charges because of other caseload issues and or their discretion. So I'm in Collin County. My DA has decided they will file these cases criminally, but it's very inconsistent across the state. Many of my peers are not able to get those charges filed in their home counties.
one of the things you made a point about TABC, and we're going to have to do this in the next session, is give them more money and hire more officers to control this. And that's an excellent point that you made up.
One real quick question to Mr. Stevens. Do you have, and I don't know that it's part of the licensing process, does it ask for the citizenship or the country of origin as far as the owners of these licenses? Because if I'm not correct, the dishes list that I looked at has a large, whether they're citizens or not, a large Middle Eastern connection in name and name only, just on a very high level.
I don't have that on the top of my head, sir. I'll get back to you.
Do you know if we ask it?
There's some backgrounding on the manufacturer, so those would be citizens. I can't say for certain on the record.
And I'm not painting that if they're from out of this country, they shouldn't have a right to have a license if they're legally compliant with everything in aspect. But I think it goes to laundering. Remember, Madam Chair, a large part of these are cash businesses. That's $7,000 a day. I can almost guarantee you 90% of it's cash and very few of it's traceable with card, but maybe not. Maybe it's changed. The banking laws used to, when it first got started, the banking laws restricted those deposits.
I remember that.
I don't know where it's evolved to, but Chief Dye, can you speak to that?
Well, yeah, I can. So you'll hear like 6 to 8 billion annually in Texas. We believe it's much higher because a lot of it is likely not being reported. That is our investigative assumption. We do have some pending criminal cases, so I can't go into any more detail, but I can
Do they
tell
have?
you
Do they take cash only, or do they take?
they'll take cash or card.
Okay.
I can't go into too many details, but we have found vast amounts of revenue flowing overseas to countries that do cause some security concerns to our country, and that's about all I can say on that. But that is that has been proven investigatively, and that is still ongoing.
And then before I go to Senator Blanco, thank you, Senator Perry. I want to ask this quick question, just in the line of questioning. I'm sitting here thinking alcohol sales for liquor end at 9 p.m. and they're not available on Sundays, if I remember correctly. Am I right on that?
Yes, ma'am.
And then for beer and wine, it's until midnight. And I think on Saturdays it's like 1 a.m., but we restrict sales. Are sales restricted, Chief, on these products at times, Sundays, et cetera?
I'll let Dr. Stevenson follow up, but not to my knowledge.
No, ma'am, no restrictions.
So you can sell this stuff 24 hours a day, 7 days a week?
Yeah, and one of the things that when we first started looking at these, we weren't seeing a lot of traffic during the day, and then we found out a lot of the traffic is after hours, after dark.
Well, there's definitely a reason why we cut off alcohol sales, and in Texas we've chose not to sell hard liquor on Sundays, we beer and wine at midnight, I believe it is, if I remember correctly, and we there's no you can do 7 days a week. You can walk in one of these stores at 3 a.m.
Yes, ma'am.
Who thinks that's a good idea? Never mind. Senator Blanco.
Thank you, Madam Chair. Question for Dr. Hall and Dr. Stevenson. Regarding the executive order, how frequently are the age-gating inspections enforcement activities occurring?
We're just gathering data from TABC. They did their emergency rulemaking. They started, I believe, in January with some stings, but I don't have data from them on the numbers. It's minimal, as Chief Dye said, just because they have their whole other industry. They did not get additional full-time equivalents or resources to do this.
Okay, so we don't have the data, or you can get the data?
We're working on getting it right now, sir. We don't have it.
Okay, so then my follow-up question was on complaint-based inspections. Same thing. You won't have the data.
I could get that for you, sir. We do
thank
have complaints. One of the most common complaints is that they don't have a license.
Okay. Outside of the request for FTEs to improve inspection schedules, are there any other potential requests that could improve the agency's regulatory capacity, such as new technologies or any kind of improved? I know Senator Perry talked about laboratories and the cost, but any kind of improved laboratory capacity?
Yes, sir. With the fees coming in, if those were to be, and that is an ask that our department will have with the Legislative Budget Board upcoming session, to appropriate those fees to accounts that we can then use for enforcement, for laboratory testing to increase frequency, and full-time equivalents to increase the inspection frequency. If we were to get a complaint that some establishment doesn't have a registration or a license, we need to send an inspector to verify that they're in business. And then again, that takes FTE. So we find a fair number of our 7 resources involved with follow-ups on complaints. So big part of our resources are just spent on those complaints, and then not resources for just routine surveillance of the industry.
One of your slides said 6 to 7 years
Yes, sir.
for inspection. So I know this is not an appropriations hearing, but just for our knowledge, how many FTEs are we looking at?
23, sir, to get to a 2-year estimated frequency.
23 to get to a 2-year
Yes, sir.
frequency.
46. It's not just easy math. We did some calculations in 46 to get to a 1-year estimated frequency. That's driven a lot, those assumptions, based on the number of registrants and stores that we have.
Yeah.
But those are our best data, sir.
Okay. The district I represent, I think maybe 3 senators here, we share a border with New Mexico, which legalized recreational marijuana. That was 5 years ago. Do we currently have in our enforcement or regulatory tools, do we have the ability to differentiate between Texas-derived hemp THC products or the marijuana that's produced or purchased in any other state?
We do not, sir. The way the rules in the lawsuits have shaken out, the original bill statute said they could not manufacture smokable products in Texas. So they're not manufacturing smokable products. Every smokable product on the shelf comes from out of state.
Yeah.
That was one of the lawsuits that we lost, that we did not prevail, that they could sell smokable products. So they can sell smokable products, but they're not manufactured in the state.
Okay.
Other products can come in, sir. We have no restriction on out-of-state products coming into the state.
Yeah. Okay, thank you. I just find it interesting that this state spends billions of dollars in border security, trying to mitigate drugs and other things to come into this country. Yet here we have this unregulated stuff in our neighborhoods, close to schools. It just doesn't make any sense to me. Those are my questions. Thank you, ma'am. Thank you, Chair.
Thank you, Senator Blanco. Follow-up question from Senator Perry, which was licensing fee. What's the
Our original, the bill that was passed through the executive order, effectively, how much was the licensure fees for manufacturer and retailers?
$10,000 for manufacturing and $5,000 per register.
And what is the status of that today?
We're implementing that. We were March 31. We implemented it, sir, this year. We were enjoined in the court for a short period of time in May. That has been reversed.
So the 10,000 and the 5,000 is on go?
It is a go.
Is that
today.
upon license renewal, or is every retailer supposed to write a check today for that?
On renewal? So if they
And
have a
so,
license,
Can you get me a list of those retailers that are coming up over the next 12 months prior to session and going through session, and revenues expected to be in that? Because I'm going to need the number we're going to collect and figure out what the true cost of this drug is. And we're going to re-up to cover the cost at local. Because what I envision, Madam Chair, is a grant program where locals can apply for their cost that is not part of the state cost in administering this if we can't get rid of it.
I could also say, sir, that this fee still may be challenged to the Texas Supreme Court.
Senator Sparks and then Senator Cook.
I think my witness may have stepped out to take a call.
Okay, he did. And so I'm going to go to Senator Cook and then we'll come right back to you.
Right.
Thank you, Madam Chair. Dr. Hall, I'm just curious. So I work in the ER, so I not always, but frequently will kind of feel and see things that are going on in society in a very real way. The synthetic K2 was just a different world. And in my opinion, in my experience, do frontline responders, do folks in the field, as they're collecting data that you're showing us, do they have a way of differentiating between natural, semi-synthetic, and synthetic?
So I would have to go back to my team because the EMS and trauma registry, which is the runs, the data is based on looking at those ICD-10 codes. So I need to go back to them and see if there's additional fields where folks are doing that. For the Texas Poison Center network, there are also other fields. They're collecting it based on kind of those standards by the national center, and we can look and see if they're able to kind of drill down further.
Yeah, I think I'm curious about types, brands, and ingredients. Okay, cool. Thank you. And then it's my understanding that the original emergency rulemaking included a ban on marketing to children, but that was dropped from the final rule. Do we know why?
That is in the rule today that are in effect now. They must be 21 years or older to purchase.
I think you're talking about the packaging marketing to children, and it was my understanding that was not included in the final regulations.
Do we know why it was dropped?
The packaging is childproof, required to be childproof. We were building our rules off the governor's order, not a statute, a bill passed by the legislature. So we were careful with the crafting of the rule in accordance with the governor's order.
So why was it dropped?
It gets to licensing, labeling, packaging laws and precedents.
Thank you. I just appreciate all of y'all's testimony today. And if feel called, I have a district that's extremely pro-cannabis and has spoken loudly to me about this repeatedly. And I just want to say on the microphone, I think it's pretty well established that there are some therapeutic values to THC. There just are. It's really, really important to keep young minds away from any kind of altering substance. As health professionals, we know that. I think one of the most important things that we could do to save our state money and have a positive public health impact would be to end prosecutions for low-level THC possession crimes. There are estimates that it could save us hundreds of millions of dollars. And in the same way that a chemical substance affects a mind, so does incarceration. And so I think that's just something important for this committee to consider. Thank you all so much.
Thank you, Senator Cook. Senator Sparks, I think, had a question for the chief.
I did. Thank you very much. So I'm trying to figure out, okay, all the different ways that these products are costing the taxpayers, as Senator Perry was kind of talking about. From the law enforcement side, you have any idea what it's costing our local law enforcement, or it would cost our local law enforcement to try and enforce these new regulations as we look at, is it going to be better to ban it, or is it going to be better to regulate it? What's it going to cost for law enforcement to try and enforce a regulation?
Yeah, great question. I don't have an exact number, but in our analysis and consideration on behalf of TPCA to decide whether or not we could support regulation or even recommend it, that was another of the big obstacles. Our member chiefs told us over and over again, we don't have people to handle what we've already got on our plate. And I think if you'll look across the state in your districts, you'll see that many of your police departments are struggling just to stay fully staffed. We have not had the popularity in our profession over the last decade that we did in 1984 when I started. It is getting better, but we have limited resources, and so we have to prioritize. So that was one of the big considerations in not being able to support regulation, is that we knew that we were not going to have the staffing at all. The reason that my city and some others have addressed it is because really twofold. We took the time to become educated on the harm of these products and how they were being openly sold illegally, and my community started to speak to me. It was the number one complaint that I received when I became chief in Allen in February of 2024. And in fact, we did shut down a couple of stores that had a lot of the high school kids going into them. So our community was very vocal that this cannot be tolerated in our city. So it's a case-by-case basis. We would all love to have the resources to go out and regulate these stores, but again, just limited resources with many, many priorities. And that's why I mentioned that in my words, is that we're heavily involved in homelessness, mental illness issues. I mean, we're the gatekeeper because people know one number to call, and that's 911. So that's a long answer, but I don't have the exact. But it's been a concern. We're just not going to have the resources at the local level.
And Madam Chair, thank you for that. Visiting with my rural law enforcement agencies, I mean, every one of them says we don't have the resources to handle any of this. Thank you.
To end this, you mentioned homelessness. I'm going to give you all a statistic to the doctors, and then I'm going to come back to the homelessness because that will be our next interim charge we take up. I'm looking at a Wall Street Journal article, more teens who use marijuana are suffering from psychosis. And it goes through here, and the statistic that I was looking at this weekend, chances of developing schizophrenia or bipolar disorder after drug-induced psychosis by drug type. To the two doctors, I can certainly give you this article, but it lists cannabis as number one. Can I say that again? So the chances of developing schizophrenia or bipolar disorder after drug-induced psychosis by drug type. Number one is cannabis. And that's like, it's like 50%. I mean, it's like off the charts. Then, like, not even a close second is amphetamines, and then you go to hallucinogens, alcohol, down the road, opioids, cocaine, underneath all of that, and sedatives being last. So when we look at what we see in an increase in schizophrenia and bipolar disorders, which in the next panels we'll see some percentages there of homelessness and why that is. What do y'all say to that? Is cannabis the driving force behind schizophrenia and bipolar disorders? And I say that as a question mark.
I think it goes back to what Dr. Rossheim mentioned, is there's such a casual usage of this. It's so broadly dispersed that now you have this drug that high schoolers are visiting on a daily basis, and we're seeing so much more of in our emergency departments that it's unmasking or causing this mental illness. I can't say I've seen a 17-year-old with a cocaine addiction, but I've certainly seen them with a marijuana addiction and then subsequently having the psychosis from that.
Doctor, your research?
So I think Dr. Lucia answered it brilliantly. I don't really have much to add. I'd say the someone else mentioned it earlier, the high potency of these products as well are a very big risk factor. And as I've mentioned, states have tried to regulate certain potencies, and they've figured out chemical workarounds or other modality-based workarounds to those laws. And so that's part of it as well, why we're seeing that is the extraordinarily high dosages of THC people are consuming.
So the average THC content of cannabis seized by the Drug Enforcement Administration was 15% in 2021, up from 4% in 1995. Many products advertise THC concentrations of up to 90%. And a emergency room physician from Scripps Mercy Hospital in San Diego said, quote, "This is attacking young brains." Would you agree with that, doctors?
Absolutely. That's the reason I'm here today.
Ma'am, in the 9 stores that we hit, we found 7 to 78% THC concentration with an average of 29%. And remember, the law is 0.3 or less. And those are not the 9 stores that we hit in Allen. Those are the on our validated testing.
But you
7 to
can buy
78%.
7 days a week,
average.
24 hours a day.
That is correct.
And almost every smoke shop I've gone to in Texas has sold 99% THCA concentrate.
Say that, lean into that microphone
Sorry.
and say that loud.
So almost every single smoke shop I've gone to in Texas, I've gone to tons. Almost all of them are selling 99% THCA concentrate, which converts to roughly 90% Delta-9 THC by weight.
And we don't see this as some kind of war on us.
Law enforcement does. That's why we've been here every time. This is
We don't see this becoming like a scourge on our society, of which we potentially cannot recover from with our young people. Thank y'all for being here today. Members, any other questions? Thank you so much. Thank you. Members, we'll now move into another interim charge, which is the strengthening crisis-related mental health and homelessness services, and as charged by the Lieutenant Governor, determine the state's authority and procedures for providing public mental health services and the intersection of those services with homelessness and addiction. Evaluate the effectiveness, consistency, and outcomes of competency restoration for criminally charged individuals awaiting trial, as well as processes for civil inpatient and outpatient commitments. Make recommendations to prioritize the most acute populations for treatment in order to reduce public safety threats. The chair calls for panel 1, Sheriff Brian Hawthorne, Jennifer Tharp, District Attorney Tharp, David Gonzalez, and Judge David Jan. Thank y'all. Sheriff, let's begin with you, and we'll move to Miss Thorpe, and then Mr. Gonzalez, and then the judge to wrap this first panel up. Welcome, Sheriff. Good to see you again.
Chairman, Chairwoman, Chairperson, thank you. All right.
I'm a woman.
Appreciate it.
Chairwoman's
All right.
great. Chair, whatever.
And I appreciate
Lois.
the opportunity for us to be here and for this committee. We've spoken for this committee before. Sometimes I feel like we're giving the same testimony, every session, but I know this committee is here for the right reason. Thank you for the opportunity to speak today. My name is Brian Hawthorne. I am the elected sheriff in Chambers County, Texas, as well as the president of the Sheriff's Association of Texas. I appreciate the chance to share the challenges that sheriff's offices face every day when responding to mental health crisis and public safety issues related to homelessness. In many areas of Texas, law enforcement effectively has become the front door in confronting mental health crisis and the chronic public safety threats due to mental illness, substance use disorders, chronic homelessness. This creates major resource burdens for local government, law enforcement, and exacerbates the public safety threats. Deputies are called to address situations that are fundamentally health and social issues, but they are as well criminal ones. They are expected to respond quickly, safely, and effectively, often with limited tools. Responding to mental health and homelessness related calls consume significant time, staffing, resources, and county budgets. Transporting individuals for emergency detention can require long drives, especially in rural Texas. Calls frequently involve repeated contact with the same individuals who cycle between homelessness, crisis episodes, ER visits, and the jail. Pre-arrest diversion is the most effective strategy to reduce jail bookings and connect individuals to care, but diversion resources are uneven across the state. Many counties lack rapid access to response care, mobile crisis teams, crisis respite or drop-off centers, and 24/7 behavioral health support. In many rural counties, behavioral health professionals are scarce, unavailable. Expanding access to telehealth may be the only practical way for law enforcement officers to connect individuals in crisis with licensed mental health professionals in real time. Psychiatric facilities play an important role. Since 2017, the Texas legislature has invested more than $2.5 billion to replace and renovate hospitals across the state, including new hospitals in Houston, Dallas, Lubbock, and Amarillo. Yet not all of this capacity is available presently, even with the facilities that are fully constructed and renovated. We must ensure that the facilities become and remain properly staffed. Currently, there are 39 local mental health authorities across the state that are political subdivisions tasked with providing community, public, and mental health services. One of the key challenges that counties and cities face is the lack of consistency on how to work with the local mental health authority. First, none of them operate the same way. Some local mental health authorities serve one county, while others have as many as 20 counties in their region. Their funding resources and resource allocation methods vary depending upon the regional structure and the population mix which they are tasked in serving. Second, they have different policies and standards for administering community-based services. So one local mental health authority may provide consistent outpatient treatment. Others divert those services for other needs. While it may be difficult to create a standard across the board that will work throughout Texas, the committee should explore establishing basic guidelines and procedures that local mental health authorities can follow across the state. In full disclosure, I have kind of learned that there are some processes in play that I'm learning from the Texas Council. The committee should also examine secure data sharing practices amongst hospitals, local mental health authorities, law enforcement agencies, and housing providers to identify frequent users of crisis services and coordinate interventions before individuals return to crisis, and examine how to ensure that the individuals can have a more effective long-term plan of care, including additional commitment options. Counties also face significant challenges with individuals who are repeatedly found incompetent to stand trial, but lack appropriate long-term placement options. As a result, these individuals often cycle between the treatment facilities, homelessness, crisis episodes, and the county jail without achieving lasting stability. Unfortunately, we do not have a strong central data collection on these individuals because they are interfacing with local governments, law enforcement, local mental health authorities, the courts, and acute care hospitals, which are all siloed. Additionally, our jails continue to see individuals who have their competency restored, then return to the jail only to sit for weeks or months waiting for a trial. They regress, they need to be restored again. They enter a cycle of restoration, waiting, and regression. That repeated cycle also unnecessarily takes up those much needed mental health resources multiple times for the same. During the 89th legislative session, the legislature passed House Bill 305 with a unanimous in the Senate and 136 votes in the House. Governor Abbott vetoed the bill because of a short 14-day time frame that concerned him, but he vowed to work with the authors in the coming session to address these concerns. I strongly urge you to work with him and pass a bill that he will sign. The issue is as much of an emergency that we have in the criminal justice system. I hope the governor will make it an emergency item next session so it can be passed and implemented quickly. On a positive note, 36 counties have a jail-based competency restoration program working with their local mental health authority to restore competency inside the county jail without the need for sending the individuals to state hospitals. Currently, only a handful of those programs are covered through state grants. The rest is entirely funded by local governments. The sheriffs believe that the competency restoration programs should have no financial impact on local governments and should be paid for by the state. Lastly, the Senate should look at expanding the grant program created under Senate Bill 292 of the 85th legislative session. Under the current grant program, counties with a population of less than 100,000 must match $1 of the state money with 25 cents of local government. While this may not seem like a lot, I have sheriffs that struggle to purchase patrol cars. Some recommendations that we have is to expand the crisis diversion infrastructure, to increase the availability of high-capacity psychiatric beds, create a basic standard that all local mental health authorities can follow across the state, support 24/7 telehealth and co-responder models, and strengthen long-term housing and treatment options. The Sheriff's Association of Texas and the Texas Council of Community Centers is launching a statewide technical assistance initiative to strengthen the collaboration between Texas sheriffs and local mental health authorities. We're in the early stages and looking forward to this partnership to provide training, resources, coordinated support, and aim to improve the relationship between sheriff's offices and local mental health authorities. Law enforcement officers are committed to serving their communities, but they cannot shoulder the burden alone. With targeted investments, improved coordination, and expanding diversion resources, Texas can improve the outcome for the vulnerable individuals and ease the strain on county law enforcement. And I'm prepared to answer any questions, and thank you again, Chairwoman.
Thank you, Sheriff. District Attorney Jennifer Tharp.
Good afternoon. My name is Jennifer Tharp. I'm the District Attorney for Comal County, and I am starting my 5th term of office. I mention that because I had the privilege of sitting through your earlier panel and talking about the dynamic. I serve the community that I grew up in, and I've served as a prosecutor in my community for 22 years. And seeing the changes and the impacts just these last 5 years have been absolutely astronomical. As the sheriff mentioned, we did not coordinate our testimony, but I found it very interesting in listening to his comments because I think it's the same theme and some of the same points that I would raise today for the panel. The individuals with mental illness and substance use disorder, along with homelessness, have a greater representation in our criminal justice system now than I would submit to you I've ever seen in the last 22 years as a prosecutor. It's so common for these same individuals to cycle in and out of our criminal justice system, and often we see them interacting mostly at our jail or in our emergency room departments. We in my community had 1 hospital for the longest period of time. We now have 2 with some standalone ER clinics, departments, but it is absolutely a growing issue. I think the end result that you see is often mental health and substance use along with homeless issues. It's absolutely an ever-growing, increasing problem, and the population, every county, whether you're big, you're small, you're rural, you're urban, or I guess my community would be called mid-size. We have a growing need, and we have not grown our resources to be able to address the issues as our population has grown. Law enforcement plays a really important role. They're, in my opinion, probably the gateway, and there's a lot of push and desire for diversion from a law enforcement perspective. But I think one thing that absolutely has to be realized is law enforcement is still charged with the responsibility and the duty of community safety, safekeeping, peacekeeping, and to be able to divert someone requires somewhere to send them. You can't divert if you have nowhere to send them to. And as the sheriff mentioned, absolutely, there is a critical lack of diversion options. My county, we're probably sitting over the 200,000 population size. We do not have a diversion center. We are in the process of building a 16-bed extended observation unit for mental health to be able to divert them from our jail before booking. But that's 16 beds. We're building a facility that we know on day one is inadequately sized, but that's the best we could do by virtue of what we've got. We used our ARPA funds to build the infrastructure. We are in a long-term contract with our LMA to do the operations, but they're going to be dependent upon the state for the ongoing operations costs. And again, we're building it knowing day one we're going to have a long waiting line. We do not have any inpatient mental health facilities in my county. We don't. We've never had that, and we've needed them for decades. We originally started out sending individuals to the San Antonio area, and right now we are transporting individuals for inpatient treatment to Kerrville, to North Austin. We have very limited options for a state hospital bed. We are dealing with private psychiatric hospitals. And I do have some recommendations, and I will address some of, in my opinion, scope gaps, as well as some issues with regards to the way our statute works right now. But just sticking with the sheriff's last comment, I'd like to talk about on the criminal side, pre-booking, yes, diversions are absolutely helpful. I do think they can work. But as I mentioned, you have to have somewhere to divert them to. If you have nowhere to divert them to, there is no diversion. And what you see is this repeated cycle of showing up at the emergency room department, or it's another call for service for law enforcement. In an ideal situation, it's as simple as a public intoxication, criminal trespass, criminal mischief. But that's not the only call for service that law enforcement is dealing with. I mean, you pick up the news, you look at any news media outlet, you're seeing an increasing, alarming issue of growing dangers to not only neighborhoods, but even public transportation issues. And it is not anything that's unique to just the large cities. It can happen in small cities too. Things that I would like to address and I hope to highlight for this committee is with regards to competency. The state's wait list is still an issue. I do think there are some opportunities that counties have taken upon themselves. We have a jail-based competency restoration program in our county. It has been a game changer for us. But jail-based competency restoration is not appropriate for every individual who has been deemed incompetent. When we have an individual that is deemed incompetent, we do what is called a flex order. And what that means is the judge gives that flex opportunity where we try to first restore their competency while they're in our jail. At the same time, they go on the state's wait list. I have 9 individuals right now on the state's wait list, one of which is for a very violent offense, and he is number 434 on the list. Yes, ma'am. And by virtue of his offense, he will remain in our jail until he's able to either restore competency because he is willing to go through our jail-based competency restoration, or is maybe at a future date appropriate for it, or 2, we get him to the state hospital to restore competency. As mentioned, there were delays in the past with regards to once someone was restored competency, then waiting in line for trial. I am very proud in our community that is fast-tracked from our court system, from our judges, from defense, from prosecution. Once they are restored to competency, that case is number 1 priority. Because it can be an issue, and I did see that historically, where someone would restore their competency and then regress, and then we go back to the cycle of trying to get them to restore. Other things to mention with regards to insanity, individuals that have been deemed NGRI, where there is an issue of where to place them, if it's appropriate for, or they need to be inpatient, or even more concerning, where they're not, even with incompetency and not likely to be restored, if they're not appropriate any longer for the state hospital where they go. And unfortunately, we've had individuals who then have been placed in assisted living or retirement homes surrounded by other people, very vulnerable population, and it's just, quite frankly, a recipe for disaster. And then finally, what I'd like to highlight for this committee is the, in my opinion, underutilization of court-ordered mental health treatment under 574. I do believe there are some reasons why that is underutilized. It's not, in my community, a lack of desire to pursue court-ordered mental health treatment, but there are major gaps when you have a community and you do not have an inpatient facility in your county. And I'll explain that a little bit further here in a second. As to competency, I think what's important to understand is what it is and what it is not. Competency is when an individual cannot appreciate the criminal justice system, the charges against them, as well as to assist in their defense. In order to restore their competency, yes, there's an evaluation that is made. And yes, there is treatment when they are restored to competency. But that treatment that they receive is with the effort for them to understand and appreciate the charges against them and to assist in their own defense. It is not long-lasting, not long-term, actual mental health treatment. It is just to assist us in being able to move the case forward. If we have an individual that has been deemed incompetent, we cannot plead the case, we can reset the case, or as a prosecutor, you can dismiss the case. And there are plenty of cases that are not appropriate, whether it's by virtue of the threat that this individual may pose to the community or by virtue of the victimization that took place. And so for these individuals, until we can restore their competency, they either languish in a jail, or we try to fast track it and get them on this in the state services, or we restore them within our jail. I mentioned some of the issues with regards to individuals who are deemed not likely to be restored because they don't get to remain at the state hospital and in that inpatient setting any further. They're returned to the community. And the problem is, for communities where we are sending them out of our community to restore competency, you better believe that we also don't have somewhere for them to go when they come back to our community, not likely to be restored. So that step down need is absolutely missing. With regards to insanity, and I mentioned this earlier, we do have an issue for individuals. When someone is deemed not guilty by reason of insanity, the total time in which the judge can have jurisdiction and supervision of them depends upon the case by which they were deemed not guilty by reason of insanity. It's not it is a finite time period that there is supervision, if at all. When it comes to individuals that are now out in the community because inpatient is no longer appropriate, it's no longer acute at that point in time, they're not on probation. They were deemed not guilty by reason of insanity. So there is a huge lack of supervision and oversight for those individuals who were found not guilty by reason of insanity that are then released from that inpatient situation. As to diversion options, there are some counties with some really good diversion programs. There are many counties that do not have diversion opportunities. I do think that's an underutilization, but there is a lack of funding out there. And for counties to have that drive, you've got to have some sort of dollars to get it started. In terms of the civil arm, which I think needs to be addressed, because I do think there's an opportunity, instead of that individual going to jail on that public intoxication, criminal trespass, criminal mischief, that first interaction with law enforcement, I do think that Texas has made great strides from a law enforcement perspective of being able to recognize and be aware of mental health issues. We do have an MCOT team. We've had that for a period of time. We have wonderful mental health officers. The city of New Braunfels, our population is probably over 100,000. On call, we have about right now probably between 8 to 12 officers. Of those 8 to 12, I may have one of my 2 certified mental health officers on call. And so realize there is a huge lack of resources from law enforcement. And it is no disrespect and no shame to law enforcement because they're already struggling right now to fill the positions that they have. They're under-resourced, and it is a profession that is becoming increasingly more challenging for individuals to, 1, be willing to go into it, and 2, to stay in that same position. In terms of the civil arm, I think what's important to realize is the first step, if we were filing a civil case against someone by virtue of their mental illness issues, we look at either an emergency detention. An emergency detention can either be with or without a warrant. If it's without a warrant, it has to be law enforcement. The acronym for it is called an APOW, apprehension by law enforcement without a warrant. That emergency detention, whether it's by law enforcement without a warrant or with a court order, is for a period that they can be detained for up to 48 hours. That's a real short window to try to get to the bottom of things. And realize for law enforcement, the first step that they're trying to deal with is this an intoxication issue connected to it? Because intoxication is absolutely going to play a part in it. And then second, does this individual have any injuries? Now, law enforcement under emergency detention can take that individual straight to a mental health facility if they have one in town. As I mentioned earlier, if we're sending someone to Austin Oaks, which is North Austin, that's a 5-hour round trip for that law enforcement officer, assuming that facility is able to take that person. The next step after emergency detention is an order for protective custody. An order for protective custody requires a probable cause hearing within 72 hours. The problem is when I send individuals out of our county for mental health treatment, they're released from the facility and I have no idea. So when I send them to go get help, they're released in 3 days and I don't see them again until my sheriff tells me about them when they hit my jail.
So keep going. I'm going to have to I've let you have some liberty there. And we do have 2
Yes.
other panels.
Yeah,
And I think they're going to speak to the whole process a little bit. So if you could wrap it up in a couple of minutes.
Not a problem. My suggestions, let me just jump to that. My suggestion would come to Chapter 574. For individuals who are placed by virtue of a court order or an emergency detention, so we have an official proceeding that has been filed, Law enforcement or whoever the placing individual is, a judge or law enforcement should be notified before that individual is released from that inpatient mental health facility. That lets law enforcement know that individual is coming back to the community to make sure that they don't fall through the cracks. And the next time we deal with them is at some sort of 911 call or arrest. Number one, we should be notified. Number two, we should have access to the treatment and the medication that they receive to provide to our local mental health authority, because it's hard to have that continuation of care if we don't know what they were given to know how to follow through with that. So notification absolutely needs to happen. I think another dynamic that needs to be dealt with is on involuntary commitments. The ongoing issue I have is we will get an order for protective custody where a court order is issued that says, take this individual and deliver them to this mental health facility, and it's involuntary. It's a court order. They get to the private psychiatric hospital, and that patient goes from involuntary status to then the hospital now has allowed them to be there voluntarily. And when you're there voluntarily, guess what? You can leave voluntarily too. And that is what happens. So I've gone through all of the jump through the hoops. We have massive concerns about this person's safety or their threat to other people, and we need a court order to put them there, but they are allowed to walk out the door because the hospital has now made them voluntary status. That needs to change. In my opinion, that's a violation of a court order, but who am I? With regards to the time periods, I think when 573 and 574 were adopted, it assumed that all the players and all the facilities you would take individuals to and the hoops you would jump through are all in the same county or at least close by. That's not the reality. I've mentioned 12 hours, 48 hours, 72 hours. Now realize that also assumes all those hours are taking place during your normal business hours. To get a court order, I got to track a judge down, to get that judge on the phone, to get it reviewed, to get it notarized, to get all of the documents. A lot of times we are racing the clock and these individuals keep falling through the cracks. Like I mentioned, 574, it has that avenue for court-ordered services. And so when I send an individual for inpatient against their will help, I need to have notice because the next follow-up should be getting them back in front of the court for court-ordered outpatient mental health services to follow through with them. That's never happening, and until, again, they get arrested again. Thank you. Happy to answer any questions. Sorry for going too long.
Yeah, no problem. Mr. Gonzalez.
Hi, my name is, let's grab this right here. My name is David Gonzalez. I'm in private practice. We are a group of lawyers and social workers dealing with the comorbidity of addiction and mental health, as well as trying to figure out the underlying causes, much like the ER system. What's the root cause? I cannot echo enough of both what the Honorable Ms. Tharp and Sheriff Hawthorne. It is an overwhelmingly complex series of issues. So if I can just take, Senator, what you had said at the beginning, which is what are the things that are missing? Where's the family? Why has the family abandoned the individuals? And how do we give them the tools? As a small business owner, we do constantly more with less. And so without asking you for more money, which I know everybody asks you for, I'll suggest 3 business principles that might address a really complicated series of issues. The first is the 80-20 rule. How do you identify the overutilizers, and is it a good return on investment? Number 2 is where are the bright spots? I know Maureen already is doing incredible work trying to figure out the counties and the organizations, the entities that are already doing less with more and finding ways to do so. So rather than try to take the systemic problem and fix it, let's just do more of what works. And the third thing is, what's the problem spectrum? In other words, you're taking a complex system. Can you break it down into a complicated system? Maybe find some simple or some recipes to do so. Otherwise, we never make any progress. It's just too difficult. Statutorily, we have wonderful tools. I could not agree more. Like, you have done a wonderful job with 4 different ways, from 46B commitments to 573 and 574, jail-based restoration, court-ordered meds. But there's 254 counties with different resources and different priorities, and it's hard to have everybody do the same thing. But I think the tools are there. The resources aren't for kind of outpatient, almost, what restorations are. But I'll begin first with kind of that's something I learned. Many years ago, I was lucky enough to be at a symposium. And so what these psychologists and public policy folks, they made each county send a district court judge, a county court judge, a prosecutor, a defense lawyer, and probation, and put us all in a room. And they said, you are in charge as a system of figuring out where people are in 4 quadrants: high risk, high needs; high risk, low needs. Those are mean people. They don't need things, but they just hurt people, and you put them somewhere else. High needs, low risk, or low needs and low risk. And you divert the low risk, low needs because they spend resources that's not a good return on investment. Your criminal trespasses, your people that are just cycling through and through. Where you spend your dollars on are the high risk, high needs folks, or the high needs, low risk to prevent problems. And so we know that in that quadrant system, we can figure out, and we have good data collection. I agree that we don't do a good job of coordinating, but we know who's had a dozen different competency evaluations at $2,000 or $3,000 a pop every year or two. We know the folks that are the high frequently utilizers. The question is, what do you do? Do we need another competency evaluation at a very expensive issue each time? And so that's the first thing is figure out who is utilizing a lot of our resources. And the 80-20 rule is often that 80% of your resources get used by 20%, or you find out where that is and stop the bleeding right then and there and look to see what that investment is. The second issue, and I think that the chief said this beautifully, we're the gatekeeper because people only know one number to call, and that's 911. And so they're all treated like criminal emergencies. So a story I can tell you, I can just read the email. The most sophisticated consumers, which are lawyers and law partners, don't know what to do. And so this is an email I get from a law partner. Please let me know if you have any leads on an attorney who's got expertise with emergency mental health decisions. I've called criminal lawyers, civil lawyers, family law lawyers, and it's all left us stumped about what to do with the mental health crisis where a family doesn't want to call the police because it's not a crime, but they're also afraid of that family member acting violent or oppositional, and they don't want to get hurt. They don't know whether to call 311. They don't want to call 911. So sometimes they call their last lawyer. And so you have public defenders, and you have mental health public defenders, and you have folks like us with social workers that try to do crisis management. And so on the front end, do we have another way, instead of 911, of diverting it, kind of like poison control? There was some other analogy. I don't know what the analogy is, but we know that there's other types of resources there to divert. Families are also a really good early warning sign. They know when a family member is acting differently or dangerous. The problem is they don't always commit a crime, and so the sheriff can't do anything. The county can't file. The parents often don't know, how do I get an emergency psychiatric call? I mean, that becomes a lot of the clarification that I think the statutes are there, but it's just no one knows what to do because 911 is the easiest number to call, and then the system kind of has to go from there. So I will say some of the bright spots is that regional public defenders' offices who have embedded mental health officers, who have longitudinal relationships, kind of end up being the primary care for some of the most high utilizers. And so knowing that those relationships are there, knowing that the family trusts the public defender because you're not going to call the police necessarily, and I can confide in you that maybe they were using drugs in a way that I may not say this to the police, I do think that's a bright spot. Last, so where are the solutions that we can look for in terms of a complicated or complex problem? I couldn't agree more with Ms. Tharp. If there was the equivalent of like a nursing home's the wrong word, but you've got jail, which is a very high security facility. You've got outpatient, which is almost nothing. We don't have an intermediary structure where, like, there used to be something called sobering centers where I could put you in a drunk tank and you sleep it off. You need stability, and it's more than a day or two to get medication, to get some sort of place where folks can either walk into a community or have somebody refer it to. And that, I think, is one of the bigger holes that we've got, is some intermediary place. So based upon those comments, I appreciate your time and attention. If there's anything else you need, I'll be here to answer questions.
Thank you, Judge. And is it Jan or Jan?
It's Jan.
Okay, so you Americanized that, I think, a little.
I believe my grandfather did about
from
World
my
War One.
Czech
Yes, ma'am.
background. Okay.
Okay. Good afternoon, Chairman Colkhorst, Vice Chair Perry, and members of the committee. My name is Dave Jam. I serve as one of the probate judges for Denton County. I'm a statutory probate court judge here in the state. I've been involved with the Commission on the Texas Judicial Commission for Mental Health since 2018 when it started. I've been a full commissioner on that commission since 2020. I've been involved in the criminal justice system or the civil commitment system since 2004 when I started in Denton County as an assistant district attorney. Served as the associate judge for the probate court, then had a short stint as a criminal court judge, and then back as the presiding probate court judge. So I've been in this field for quite a while. I'm going to just requote everything Sheriff Hawthorne and DA Tharp said, and then I'm going to read my statement so I don't get mission creep because they opened up a whole lot of things I would love to talk about. I did submit written testimony that's a little bit more detailed than this. In probate courts across the state, we're seeing a combination of new cases and a small group of the same names coming back through our courts again and again. Very quickly, the process is that someone in crisis can be detained by a peace officer or under a magistrate's warrant, taken to a facility for evaluation, and held for up to 48 hours. If more treatment is needed, our court decides whether to order inpatient or outpatient treatment or for how long. I can't walk through the full statutes today because it would take much more time than we have. I'm glad to take questions on that, but I want to spend my time on where this breaks down. Where mental illness and homelessness collide with the law, someone with no home and no family member available to step in often can't qualify for the least restrictive outpatient options because they don't have a place to reside when outpatient services are being offered. Additionally, outpatient isn't regularly ordered throughout the state because the law requires that outpatient services be available to that person, and in most of the state, the capacity simply isn't there. Additionally, hospitals are not recommending for people to come out of inpatient and into outpatient care, and as a court, I can't just say, well, we're going to put you in outpatient if nobody's asking for it. If the hospitals aren't asking for it, the district attorneys aren't pushing for it, I can't just tell you you're going to do that because that's the court dictating process, and we're supposed to react to filings in court, not tell people what to file in court. This creates a crisis where the inpatient stays are short. We treat the crisis, but not the instability underneath it. Texas is a crisis commitment state, meaning you have to present a danger to yourself or others to be able to be held inpatient. That's a big gap between competency, as District Attorney Tharp mentioned. This puts the person back in front of us within weeks or months. Why the current process can't solve this long term? This isn't a process problem. It's a capacity problem, and it looks different depending on where you sit. In rural counties, that's often little to no inpatient mental health care within any reasonable distance. Officers used to transport directly to a state hospital, but those beds are now overwhelmingly occupied by forensic, not civil commitments, and that leaves civil placements dependent on local authorities purchasing space from private facilities in a market where demand outpaces supply. In urban areas, it's a different problem. Safety net hospitals in high-volume regions report emergency detention volumes in the tens of thousands annually. That's a scale problem no amount of bed capacity alone can absorb. Those are two different problems. A rule built to solve a large urban hospital system's volume problem will not fix rural access and may make it worse. These laws are written with some flexibility so communities can tailor solutions locally. What works in Harris County will not necessarily work in Denton or Grayson counties. There is no one-size-fits-all solution. That's the conclusion the Judicial Commission on Mental Health reached when we convened stakeholders on this exact issue. While temporary commitments may be ordered for 45 to 90 days, in reality, most patients stay in the hospital for 7 to 10 days. In Denton County, my county, I'll hazard to guess that that's probably 5 to 7 days. So once they've been held on an emergency detention, we never get the opportunity for court-ordered inpatient treatment or court-ordered outpatient treatment because they're released by the hospital. And it's that gap that I know the DA was just talking about. Additionally, the court and hospitals can't provide additional supports unless the patient is recommitted. However, an assisted outpatient treatment program has proven that community-based outpatient treatment for the right candidate can reduce future hospital stays, interaction with the criminal justice system, and promote long-term stability in housing and employment. More funding for these programs and the services they require would benefit the state. An additional recommendation would also be continued support of the Judicial Commission on Mental Health, which creates toolkits, hands-on assistance with coordination among courts, mental health providers, hospitals, law enforcement, housing providers, and community organizations as they all serve overlapping populations. Improved information sharing, coordinated case management, and cross-system planning improves continuity of care overall. Going to stick back where I had to make some notes from the other participants. In Texas, we have 254 counties, which I know you are all well aware. In 150 of those counties, mental health is handled by the county judge. That's the constitutional county court, who may or may not be a lawyer. In 134 of those counties, there's less than 20,000 people. Those resources do not come anywhere close to what I have in my county. So when we go and try to educate someone in that role, it's real hard to say, well, why don't you do this, when that option just doesn't exist. In 90 counties, probate mental health is done by the county courts of law, and you have the 14 largest counties in which you have a statutory probate court. I've got a mental health staff. I've got a mental health court coordinator, a mental health paralegal. I have 2 staff attorneys. I have a county diversion coordinator that works for a county criminal court. I got a lot of options to coordinate and do some of the things that Sheriff Hawthorne and DA Tharp were talking about. Have to skip back to one of the first things you said, Senator Colkhorst. Where are the families? They're begging for help. They're denied information by HIPAA. The hospitals don't provide it to them. They're denied information by the confidential status of involuntary commitments in the courts. They're denied information and participation while they're incarcerated in the jails, and they're denied information directly, from their treating facilities unless we can get HIPAA releases from them. So the very people who are the support network we need to be successful are the very people we're denying all the information to and saying, well, you could check the court's docket. I can't verify or tell you if they're here or not. I can't verify or tell you if they've been held on emergency detention. The very people we need to support all of this, we are denying access to by laws that were never intended to punish the family members. With that, the legislature has invested significantly in inpatient care over the past 6 years. The next step is investment in community-based crisis services and outpatient treatment. In September, the Judicial Commission on Mental Health convened stakeholders from across the state on issues surrounding emergency detention. Resources are limited, and they're driving almost every difficulty that communities are having. What's actually working are locally built solutions shaped around what each community can support and not a single statewide mandate. Flexibility is key. Coordination and cooperation are key. And with that, I'm happy to take any questions, or else I could speak for hours on this. With that, I'll stop.
So I just listened very intently about I would say the maze that y'all work through. And I only heard once, and I think you called it an LMA. None of you spoke to your local mental health authority in great measure.
Oh, mine is the best.
Great. Tell me about it.
So my jail-based competency restoration is by virtue of a grant our local mental health authority obtained. They have a couple of
From the
staff
state.
within our jail.
Yeah.
Yes, ma'am.
Mm-hmm.
They are also the same group that will be operating our extended observation unit. Our local mental health authority is absolutely amazing. And I heard the sheriff's comments, and I do know that not every prosecutor has that same dynamic. Mine is one of the best.
There's 39 of them, so they vary differently. And I would also say, I guess, let me go through, if no one else, Senator Blanco, I'll go to you in just a moment. We look at the 80-20 rule, Mr. Gonzalez, and I was looking through some data, and you're right, there's so many repeat offenders. I want to ask this question. When we talk about the mental health crisis, the panel before y'all makes me think it's only going to get worse. If we have drug-induced psychosis, schizophrenia, and bipolar, you saw that. The number one thing that is, number one. Cocaine isn't even close. It's cannabis. And you can get that 24 hours a day, 7 days a week. There's hardly any rules around it. What are we going to do, Sheriff? And are we looking at, y'all have to deal with it coming at you. We're trying to say, how do we prevent it from happening? My mind is, how do we prevent that? And how many times do you see crime that is either drug or alcohol induced versus genetic?
Well, the majority of our crime that we see is definitely drug induced. Alcohol induced if it's like DWI and some family violence and what have you. But most of our burglaries, robberies, all of those things, especially the violent crime that comes, is truly tied to some type of drug addiction or something where they are craving that to feed their addiction, and they've got to come
Give me a
up.
percentage on that. Just spitball it for me.
I used to really enjoy walking through the jail and trying to get a grasp of who all was sitting in jail. And I will tell you that probably 60% of what we identify and see in the jail are somehow, some reason, they are in there due to drug-related issues. We used to call it the meth heads, but it's not the meth heads anymore. Now it's THC psychosis. We still have K2 issues. And who I really feel for are the families that really struggle trying to figure out. They know the kids are in a bad way and they have no place to turn. And then ultimately those families and those kids end up becoming adults, and then they end up becoming what we used to call meth heads that are no longer meth heads. Methamphetamine, it's still out there and we still deal with it, but we just deal with the toothless population, not the ones that are sitting in our jail causing all of the crime issues. I would say that we could probably really start identifying THC psychosis and other issues. And cocaine is so far down on the list. Don't get me wrong, it's still there and it's still a problem, but that's not what we're dealing with in our jail.
Senator Blanco.
Thank you, Madam Chair. Question for Sheriff, or really anyone in the panel. In El Paso County, we've got our crisis intervention teams that deploy with law enforcement and our local mental health authority, emergency health network. And this is with a trained professional. It's been very positive for our community. Are there other ways, such as those crisis intervention teams, or any other methods that you've seen that work with law enforcement to improve outcomes?
Well, I will tell you that Senate Bill 292 was one of the best things that ever came along. And if we can continue to grow and improve on that, Senate Bill 292 would be wonderful, because that's where most of us have been able, most sheriffs are trying to utilize that 292 money through their local mental health authority to create mental health deputies. And what those mental health deputies are, and it's exactly what the prosecutor said, is we've got to have follow through, because we can get them in the jail and we can treat them. We can either restore them or we can calm them down. But the minute they do get out, they bond out, whatever that process is that they get out, then they just immediately start regressing. And that's where the mental health deputy program is. Sometimes I feel like people don't realize the mental health deputy program isn't about responding and fixing the problem that's at their house. The mental health deputy program is really about, once they hit the jail, now it gives us as the sheriff's office to identify who that individual is, that he's a mental health issue, usually drug induced. But when he gets out, it's all about keeping him on the same medications, the continuity of medication, when he is in the free world and not sitting behind bars. And so those mental health deputies will call on him on a regular basis, depending upon what it is. They may call him on once every other day, once a week, once a month, trying to make sure. I can't tell you how many times my mental health deputy is loading up one of our consumers in the back of the car and taking him to the psychiatric appointment that he would no longer be able to make if I didn't have that mental health deputy program. So I tell you, you cannot expand 292 enough. And it's the rural counties, the counties under 100,000 that struggle. And I know coming up with 25% match doesn't seem like much, but when the sheriffs were here begging the Senate for SB 22 money, just so we can buy cars, guns, hire, do salaries, that additional 25% match is difficult to come up with. And El Paso has a fantastic program. Oscar is very fortunate on what he has there from Sheriff, the programs that you all have. It's the rural counties. I want you to know from the Sheriff's Association perspective, I'm truly here representing that 180, 175, or for sure the 150 counties in which they do not have a judicial court that is managing these. It is that general law, that county judge that was elected who earlier in the day he was farming peanuts and now he's trying to figure out how to deal with this mental health issue. And that's where the sheriffs, the prosecutors, everybody needs the help of this committee.
Senator, if I may, to kind of address that same question. In Denton County this year, I'm going to have roughly 1,500 involuntary commitment cases filed. The district attorney is going to kick back about an additional 300 to 350 that don't meet criteria for them to move forward with the prosecution after they receive the application from the hospitals. Currently, I'm pretty confident that Sheriff Murphy in my county has about 300 to 350 individuals in the Denton County Jail who are currently considered under psychiatric treatment cases. That's not to say that they're all 46B incompetent or that they meet the criteria for inpatient mental health services. They are just a psychiatric caseload in his hospital, in his jail. It's a misnomer to call the jail a hospital, but unfortunately, in a large portion of our country, the jail is the hospital of treatment for mental health illness, although we're making great strides to try and change that. Out of my 1,500 involuntary commitment cases this year, in talking with my district attorney, who's a dedicated prosecutor in my court, he's been doing it for years, and I've known Matt for 20 years. Of those cases that we believe are directly tied to substance use is probably 10% or so. And with substance use and homelessness or homelessness alone, it's about a 15%, overlap there in our total caseload. And when we look at super utilizers who have 3 or more emergency detentions in the last year, that's less than 10% of our cases. In the civil commitment realm, much different than in the interaction with law enforcement that ends up in being detained for crimes as a result of mental illness. I don't want to say crimes of mental illness, which is a term you'll hear or used to hear in the past, but it's crimes resulting from mental illness, which is the criminal trespass, sometimes the domestic abuse, vagrancy, and the sheriff could list those. I've got almost 1,250 patients who don't fit that bill at all, that are just chronically and severely mentally ill. So you're talking two entirely different structures between the 46B and the criminal case interaction. And I'm in a county that's got 10 criminal courts and 2 probate courts that we can interact with, communicate with. And when you end up in a smaller county where you've got a county court judge who's also the road and bridge guy, who's also the misdemeanor prosecutor, who's now, where's the follow-up on the mental health? And oh, by the way, he's the guardianship guy too. That's a plate. That's a lot. And then you've got a county attorney's office who's a county attorney, who's also in private practice, and a district attorney who's just the district attorney. And we're looking at these stretched resources that the district attorney was referring to. We've got to have tools that are flexible that we can apply, tools that will allow us to collaborate across county lines for those smaller rural counties. And that's me speaking, not the Judicial Commission on Mental Health, because I know I'm kind of here on their behalf too. The ability to do assisted outpatient treatment, if they've got a good program somewhere like Fort Stockton, that Presidio can tap into that with telehealth resources. That in counties where your LMHA is overloaded with services, the administrative code requires any jail-based competency service program to be funded through your LMHA. Well, everybody's got different priorities. If your county sheriff and the local county health department want to run a jail-based competency restoration program there, let the sheriff apply for the money. You know,
So
there could
would
still
you
be
open up 292 to sheriffs in that regard instead of just running it through LMHAs?
I'm going to defer that answer to the sheriff because I'm not entirely sure what
Oh, I
292
think I
funds
done
are.
hit something here.
So I think it all depends upon the local mental health authority. All right. And one of the things that you and I have talked about in the past is they don't all seem to operate the same way. Now I'm getting a little bit of education. I'm not afraid to tell you that Lee Johnson's opened my eyes on some things and so we're going to work on some collaboration, trying to fix some things from a communication perspective between local mental health authorities and sheriffs. But
We've been trying to do that for the last decade.
well, we have been, and I'd be the first to agree with that statement.
I put y'all on their
So-
boards.
I have sat on mine for the last 10 years, so I fully understand the importance of the sheriff having that ability to sit on that board. What I will tell you is that 242, a local mental health authority that is proactive and gets involved with the county jails, and in my case, we have the local mental health authority operates and helps and assists 5 sheriffs with their local jail. But then you've got some other local mental health authorities maybe trying to figure out how to manage 20 jails. And so there's a lot of difference between local mental health authorities and based upon the resources. The 242, in my aspect with my local mental health authority, it is perfectly fine having that program run through them. They do a very good job. Like I said, I can't complain about the local mental health authority that I participate with. One of the things, Madam Chair, that I really think I hope this committee will look at from a jail perspective for sheriffs is what we call long-term injectables. I'm not a doctor and I'm not going to get into the medication aspect of it, but just remember what I'm going to tell you about long-term injectables. I can't tell you the disruption and the problems that take place in the county jail with people with mental illness disorders. It's unbelievable. And I struggled with it. My local mental health authority got with me and said, hey, if your commissioner's court will start paying for, we can start using some long-term injectables on some of these people when the psychiatrist prescribes them. Been an absolute game changer on reducing the violence inside the county jail. So I will tell you that most counties cannot afford the long-term injectables. They're extremely expensive. Probably the least expensive one is $2,000 an injection, and they last about 30 days. But that's the best $2,000 my commissioner's court has agreed to spend. And we've been doing that for a number of years now. So those counties that cannot afford it, if there's any way the state could help with those long-term injectables, would be a fantastic thing, not just for the jail, but for everybody that's in the jail. Because the discomfort isn't just the person that's having the crisis. It's everybody they're sharing a jail cell with, or even, I can't tell you the sleepless nights that inmates go through because of an individual that all he's doing is banging on the bars. So
Senator Blanco, keep going.
Good to go. Thank you, Chair.
I'm going to go in order. Senator Hughes.
Thank you, Madam Chair. I think each witness, I've learned so much, and we have to get this right. And something I want to follow up on, and I'm probably the only one that doesn't grasp this, but Ms. Arbor, you talked about not guilty by reason of insanity. And of course, I guess folks have a perception of that from movies or from TV. You talked about supervision. So just walk us through that. So let's say a serious crime, a violent crime, for example, and they're found not guilty by reason of insanity. What happens after that? After that finding, where does that person go? What is the supervision like? What are the resources like, please?
So I can speak from a couple of particular cases we've dealt with. It depends on the underlying offense. Before that person, once found not guilty by reason of insanity, we have a court hearing. They're represented by counsel. The judge goes through the whole procedure to see in terms of what is the least restrictive option that's out there for a particular individual by virtue of his issues. It was inpatient placement, and so we had him in inpatient placement for a period of time. It's a finite period of time where the parties can go and request an extension by the court. We did that. Eventually, the facility he was at recommended that he could go from inpatient to outpatient. When he went to outpatient, one of the issues that we continue to deal with this particular individual is there's not good supervision and oversight of that. He was an individual that highly benefits from the long-lasting injections, but also did not like some of the side effects with the injections. And so this particular individual bounced between facilities and providers. The provider would make that recommendation for the injection. He would file a complaint against that doctor with the medical board, and we would go in these round circles, eventually to the point where then he became a threat, and then we'd have to take him back into custody, get him stabilized while inpatient, but again, continue to make complaints against the medical providers. It is a huge issue because at some point, we don't have an intermediate between lockdown inpatient facility and then out in the free world. And that's one of the step down I think lacks.
And do you recall what the particular offense was or underlying offenses in that case?
Aggravated assault with a deadly weapon ×3.
And if I can add, so one of the things is that
You pull the microphone a little closer.
yes, so it's based on the index offense is the number of years that we can supervise. So for my homicide, not guilty by reason of insanity, that's a 99-year supervision. For yours, 20 years. So the civil commitment lasts as long as you could put them in prison. So you can be revoked is kind of the wrong word, but maybe you need to go back into inpatient care if the outpatient. In Travis County, we use the probation department to monitor if someone's stepping from inpatient to outpatient. There's a dangerousness review board. So you start at Vernon, and so a team of doctors will decide if you can go from the max security down to either Kerrville or to Austin State Hospital for a mid-level civil commitment, to potentially then, if that person is medication compliant, everybody agrees the long-acting injectables are game changers about how that works, because you also have about a month to see if the person's not taking their medication. And if they're not, then they say, maybe you need to go back inpatient, and we'll then do another court-ordered med. So there's a lot of doctors that end up having a lot of supervision. Go ahead.
And if I may to explain a little bit about the forensic medications, we can order medications to be administered involuntarily while you're inpatient. Once you're outpatient, we no longer have the ability to order you to take your medications. We can suggest you do it, but we cannot enter an outpatient medications order under the law as it currently is.
Senator Hughes?
Thank you. Thank you, Madam Chair. Thank you.
Senator Cook, and then Senator Perry.
Thank you, Madam Chair. Sheriff Hawthorne, I just wanted to thank you so much for spotlighting House Bill 305. I was really, really proud to carry that with Representative Hayes, and I know that you know the problem more deeply than I do, and so I'm just really grateful that you're calling for it to be an emergency item. Thank you.
Well, and we hope you'll bring it back to the surface, because it is an important issue for the sheriffs and the prosecutors.
Absolutely. And we're in conversation with everybody to make sure it goes the distance this time. Thank you. I was really struck by a couple of comments about if we divert folks, then they've got to have somewhere to go. And I feel that deeply as somebody who discharges people from the emergency department. I spoke recently with a prosecutor in my district who relayed that they're encountering folks with intellectual and developmental disabilities, IDD, that they've never had on their radar because they are being cared for by an elder caregiver on a waiver interest list for years. The parent dies, and the IDD individual now becomes homeless. The IDD population is anecdotally also exploding in jails, as y'all know, and on the competency restoration lists. Shelters also are reporting a rise in persons with IDD seeking services. At the same time, I'm concerned that we're not adequately funding IDD services in this state, while almost all of the mental health facilities have exclusionary criteria for folks who have autism, are nonverbal, or have IDD. So my question is just, can you speak to this particular population? You know, could we be investing even further upstream so we don't have to talk about diversion? Just what are y'all seeing?
I'll take a stab at this. in terms of investing upstream from a prosecution focus, because I can only speak through that lens, my options really come down to civil commitments and then responding to the criminal dynamic. When you look at the civil commitment, it wasn't designed, I think, with understanding IDD. And so I don't know that it really is the appropriate lens and response and reaction to it. Then you look through the lens of the criminal aspect. And again, it really depends on the particular offense charge, but I do think it's a population that we really haven't contemplated how to best deal and how best to respond. And I would submit to you, I think we don't have adequate tools and resources.
I'm going to respond, if I may, Senator Cook, and goes back to a lot of different counties, a lot of different resources, a lot of different knowledge. I recently participated in a panel discussion with the Texas Commission on Jail Standards on how you treat people under a guardianship in jail, probably 6-8 weeks ago down here in Austin. Under Section 1102 of the Texas Estates Code, anybody can file an application with a court with probate jurisdiction for a court-initiated guardianship, which should result in the appointment of a guardian ad litem to go and evaluate whether that person would meet guardianship criteria. Now, I know I'm going to have about 1,000 calls in my phone when I get done with this from the other statutory probate courts for saying that. But that is a resource that is highly underutilized, both for temporary guardianships and permanent guardianships for people that meet IDD, people that have IDD and crossover into mental illness with interactions within the jail. I don't know many sheriff's offices that have ever applied for 1102s because it's not widely known outside of that civil guardianship role. And it goes into the silos that the sheriff was talking about earlier. We have a lot of good tools in our own individual toolboxes that we are not aware of across the practitioners of those that intersect with the criminal justice system and the civil system in regards to these areas. Recently spoke at the Texas Association of Counties with, have you tried doing a temporary guardianship to get somebody medications compliant, to get their Social Security fixed so you can get them into housing? County judge said, nope, never thought of that. Can I do all that at once? Well, you have all three of those jurisdictions, so yes, but you probably ought to separate it some.
And that was to an IDD.
Someone with intellectual developmental disability and, crossover mental health illnesses and homelessness. Those are all things that can be done to try and find outside the box solutions.
Thank you. And I just want to say, I just appreciate so many of y'all's comments. I think there's always a desire to reach for, like, what's the singular cause, and if it's a particular substance or something else. And I just want to mention that a major through line for folks who end up incarcerated are adverse childhood experiences. Many, much more so of a correlation than any one particular substance. And in fact, there's a lot of feeling that folks can survive a substance the less they have adverse childhood experiences kind of predating the use of that substance. And so I just appreciate such a focus on healing and investment. I think that's so important. Thank you all.
Senator Perry and then Senator Miles.
Thank you, Madam Chair. Just Senator Cook's comment, if we could replace the male role model that's lacking in so many of these homes and give them that stability that used to be there when we were kids. Dad'd reach over and pop you if you needed it sometimes and get you directed. We could probably reduce the budget by $100 billion and fix a lot of things that we try to address, but that's not in our purview. And if you answered this while I was out, I'm sorry. And it's for an attorney. Senator Hughes, if you can answer it too. Is it legal for a hospital to be able to just ignore a court order? I
brought this attention up to one of your future panelists here in a minute, and it is something that we are going to go back and look in. The last time it most recently happened when my county got word of it, we set it for an emergency hearing and issued subpoenas to have get testimony on the record. And in that particular case, we were successful. But part of the problem goes back to that notification piece. If I don't know that it is transitioned from involuntary to voluntary, I'm going to assume they're still there. One number I didn't give is that once we get an order for protective custody, we have to have within 72 hours this probable cause hearing. It's fast. It's not difficult, but it's still some hoops to jump through. After 14 days, we have to have a full evidentiary hearing. So that's anticipating we have sent someone for inpatient treatment. After 14 days, we have to have a hearing. In the last 5 years, I have had a total of 2 14-day hearings. In the last 5 years, I have had 2 14-day hearings. They are in and out before I even have a chance to find out how things are going, to then intervene to know what is the next best step. That is a huge problem. We need to get notification of what's going on if they're being released. I don't think we should be able to, a hospital should be able to change from an involuntary commitment to a voluntary commitment. And I do think that needs to be
I
shored
would agree with you. I listened to this, and it's kind of like the other hearings we've had this interim. It's kind of a Groundhog Day conversation. Every hearing, every subject matter, we just rehash the old stuff. State-supported living centers, I'm still not clear on what their mission is today. I really can't tell you. I know who's in them, and I know they do a really good job for some really, really tough, chronic acuity kiddos and things and people. I don't know. I think it's 13,000 bed capacity, and I think we've got 3,500 people scattered out amongst them. And I know the original purpose was institutionalizing people. And what is interesting to me, sad but true, this whole panel and this conversation every session has been, well, we need to do X. I hear now injectables, 30 days effect. That's no different than having someone in an institution that we drugged. And I'm not arguing that that wasn't necessary. My point is we keep chasing and going back to and retreading and things that arguably we don't like to admit we need, and we like least restrictive. But the truth of the matter is we don't have enough money to put a private caregiver the minute they leave outpatient or inpatient for that window that they're going to recidivize. I had a superintendent one time, and we don't always agree, but I asked him, I said, if you were king for a day because he was retiring, what would you do? And he said, I would hire, or I would place I'm going to say a nanny or a caregiver into every kid's home that does not have a family dynamic. And I would be successful in meeting the expectations of all of you guys at the legislature. It's the same thing. So where I'm going here is, I don't know where we jump, but I know what we're doing is not sustainable financially. And so if it is a repurposing of something that once was, that was abused in the civil system, you know, my basic understanding is a lot of men were having their wives committed and doing things that they shouldn't have been using the system for. But truthfully, there are people that are frequent flyers that we're never going to fix, that are going to harm themselves and harm other people, that we need to be honest enough to accommodate that problem and be very judicious. And when we do, but if we don't get back to that conversation, this conversation will be here 20 years in the next legislature. And I understand involuntary, and we value liberty and freedom. And it goes to the homeless. I tried to help homeless multiple times in my tenure. The last time I tried to help my homeless folks, and I could give you the granularity of what I did and where I landed, I finally determined the biggest challenge is not how I help them. It's setting the sweet in the shaft of those that choose to want to be helped first, because it's a very small population that really wants that help. And so that's the challenge, and that's our problems. On the IDD, I appreciate the conversation for sure. And I think I heard the judge here, and I want to make sure I'm clear. Our IDD population that may cross over, I'm basically, what I heard from a layman's perspective, not being in the court, is that there is a legitimate process to effectively try to separate our IDDs that may have committed something that got them into the judicial system, that we won't be incarcerating people with truly organic / mental organic stuff. I mean, we have a system. It may not be perfect, but we're not jailing IDD populations by statute or by rule intentionally. We have a process to sort back through that. Is that a fair statement or not?
I think that's fair. It's going to be education based for the practitioners. I am not aware of a large IDD population that is incarcerated in the state penitentiary system. I think and this is, I think, I have not collected stats on it, is the larger concern is the IDD population that's in the county jails awaiting resolution of their cases, and I think the sheriff could back me up on that, and what happens with them and how those cases resolve. And I want to, so yes, to answer your question, there are some things in there. I want to step back to your question to the DA on, can a doctor refuse a court order? Oh, I'm sorry.
No, you did.
May a doctor refuse a court order? When we as a court with involuntary commitment jurisdiction issue the order of protective custody for that individual to be held for a period of time up to 14 days based on probable cause, because Texas is a crisis commitment state and you have to meet that crisis commitment criteria, once the doctor feels they no longer meet that acute criteria, they can release you. And the premise behind that is judges don't practice medicine and doctors don't practice law, is the simple version of that. Likewise, most of the 45-day commitments that we enter for temporary commitments, on average, those patients are out 19 to 21 days, on average. Very few of them make that full 45 days. Going back to the district attorneys, we would like notice of that. Those hospitals are supposed to give discharge statements to the court. So the court will receive them, whether they make it down wherever they're supposed to or not statewide, and whether or not those hospitals are giving them to the court and the court's following up with those. Those are, some systemic problems with pursuing paperwork through the state. I know my mental health court touches about 55,000 pieces of paper a year. So, and that's just moving paper to move.
So,
All right, be quick. We still have
Just
more
a
panels on this.
clarification point. Everything that the judges mentioned is absolutely correct. The court is required to receive notice if they're still there on an involuntary status. However, if they transition to a voluntary, the court is no longer eligible to receive the notification. And that's the loophole that has been happening in our particular situation. You're right in terms of a doctor releasing. This is not a doctor discharging. If a doctor's discharging them, absolutely they need to be discharged. I don't want them in the facility. But when it's transitioned from involuntary to voluntary and then the individual is choosing to leave, that's where I think there's a huge issue.
Madam Chair, the IDD population concerns me just because of the obvious, right? The frequent flyers, I think we have to figure out which ones want help and which ones don't, and then have a place. And we don't have a place for the ones that do seek. You said something, it's their sentence, 99 years is what they're oversighted. If they commit one of those crimes, I'd argue if someone committed that crime, they shouldn't be civilly out on the streets, but that's a different conversation. On the IDD, you raise a good point. Our caregivers do medical stuff. These people are living longer. Down syndromes have a heart procedure that puts them into 80 years old. I'll just give a plug for a Marbridge community here in Austin is the standard, I think, for what caregivers are and where they transition their kiddos, if you will, into them. Lubbock's trying to get one of those, but that's a real problem because these people do end up on the streets if they don't have that go-to place. So state can look into some of those things, but I know Lee Johnson's coming up on the next panel. And I want him to be very succinct and not give me legal jargon and runs arounds. I like Lee, but he's very good at talking circles around people that are not in his world. I want to know what the mission of a state supported living center is because we truly, I keep saying there is no place to go but that's the logical place to go. Maybe we need to decide on how long and when and how.
That would be HHSC in a large part, but we are also talking about, nobody's mentioned LIDAs up here. That's a very interesting conversation. I'm just taking note. I'm just listening. Senator Miles.
Thank you, Madam Chair. Madam Chair, this is one of those rare times that I agree with Senator Perry on some things.
I agree with you. I Democrat senators today.
Okay.
Man, it's
I'm talking about me and you, though. That we keep addressing this issue, and I don't think anyone in here would disagree with me that our criminal justice, our county jails is not the right and proper place to be, and they shouldn't be the largest provider for mental health services. That's correct. Would you say so, Judge? I think we can all agree on that, can't we?
Absolutely, but I think it's been that way, Senator, for many years, right?
Yeah.
And so there's no doubt it'll be difficult to transition it, but we've got to transition it.
And that's where I agree with Senator Perry. We've got to come up with something, Madam Chair. And I'm glad that you're having this interim on this, because we've got to come up with something that changes that cycle. Simply put, it changes that cycle. I represent Harris County, as you all know. Harris County Jail is the #1 provider for mental health in the entire state of Texas. A jail, a county jail. And it shouldn't be that way. And we've got all these different programs. We've got all these different professionals. And what I'd like to come up with, colleagues, is a system, something different. Because, it's that old saying, you keep doing things the same way with the same negative results. That's insanity. No pun intended. It's insanity. We have enough knowledge here amongst all these professionals and others that we know. We've been dealing with this a long enough time, Madam Chair, that we should be able to come up with something that can start shaving the numbers. Something effective that can start shaving the numbers and stop pointing fingers at each other, different organizations and different levels. Senator Hughes, that we should start shaving the numbers, putting something in place that starts the cycle of putting our mental health patients, giving them the proper need and proper attention that they need instead of just locking them up. So that's where I agree with you at, Senator Perry. And it's got to be something that every level comes together on. It's got to be something that, nobody's fighting and grasping for funding. The main thing that should be important is the proper health and the proper care of our mental health. Madam Chair, I think we can do that. We've taken on larger issues. This is a large one, but we've taken on larger issues together. So I look forward to working with you and let's making it happen.
Me too.
Thank you.
A quick question. Whether they're mentally ill or IDD or having a psychosis from drugs, if they beat someone up or rape someone or they create a crime, they go to jail, don't they? So how many
Yes,
people
that's
are
what-
sitting
that's what
in a
they should-
jail that didn't commit a crime?
Well,
I think that's a fair question.
It is a fair question, but here's what I will tell you is that it's not uncommon that a sheriff's deputy or a police officer at 2:00 in the morning may not necessarily make this arrest on some other individual, but he's also trying to figure out what is in the best interest of the society. In other words, if I have a crime that I can file on them, all right, that they meet the criteria, the probable cause is there, I can write a good probable cause affidavit, and I'm really trying to protect this individual from himself or from...
So he's just having a psychotic moment. He didn't beat up his partner. He didn't beat up a child.
Correct.
He's just having a psychotic moment. How many of those people go inside the jail?
Well, they may, but they don't stay long. Those don't normally stay long.
Don't they go to the ER?
That's normally what we try to do with them. That is correct.
That's the first stop is the ER. It's not the...
If
Now,
your ER has the
walk in
ability to do it.
And they beat up some child, I mean, that's an arrest, right?
Correct. But normally
They're
you can
taking
almost...
one of those gummies and they're out of their mind and they beat up everybody in the room. That's a criminal offense, right?
Madam Chair, here's what I will tell you. The easiest, if you're a police officer or sheriff's deputy out there at 2 o'clock in the morning, the simplest and easiest thing to do is figure out whether a crime has been committed. So then you can start dealing with the issue. All right. And so one of the things that you'll find is sometimes it's a lot easier for a sheriff's deputy to create that probable cause, very legitimate, whether it's a trespassing, a disorderly conduct. I mean, we could go on. There's all kinds of offenses
Okay.
that could have been created. Put him in the county jail, and I can be back in business in an hour. If I
So
take him
instead
to
of
the
going to
ER,
the
I probably won't
ER
be back in business in an
Okay.
hour.
Instead of going to the ER, you go put them in the county jail.
That is a
And I want to
common
ask,
thing.
just as a follow-up, somebody said, I didn't use his words, but wasn't there a sobering tank, or did some one of you use it?
Some of the big cities and in metropolitan areas do have sobering centers. Rural Texas
Is that
does not
inside
have
a
rural
jail?
sobering centers.
Is that inside a jail?
No, it's usually, it's a diversion. It's a form of diversion. It's a form of diversion. And they're very successful. But like say, rural Texas, I can assure you, 200 counties don't have them.
All right, to pull this back to the charge, how many of these people are homeless? That you see the 80-20 rule or cycle? And don't all y'all, I don't want to go 15, 20 minutes here, just simple answers.
For a quick review for Denton County, since I knew that was going to come up, we looked at it and we think it's somewhere around 12% of our involuntary commitment population. And I'm specifying
homeless.
involuntary civil commitments, which is different than what the sheriff and the district attorney are generally dealing with, about 12%.
Okay. All right, good. Well, a lot of work to do, as Senator Miles says, and again, I think also I did want to say, probably should have said it in my opening remarks, that Senator Flores, Chair Flores, and I talked about the intersection of his committee and this committee, and what we're working on the mental illness side, which was very appropriate to put the THC charge in with today, and how that is, again, the psychoses and the schizophrenia and bipolar that we're seeing from the adolescent use of those drugs. Anything else, members? We have two more. Yes, sir. Yep.
Do we have
Senator Miles.
anybody here from Harris County Jail? Is there anyone here representing it?
We're not going to call them up
Okay,
right
no,
now,
no,
but
no,
we'll,
I'm not. Just
yeah.
wanted to know. Thank you.
Yeah, we'll get to that because we do have two other panels. I think we have 8 more people on this charge. Thank y'all very much for being here today. The chair calls. Mention lunch. Did you mention lunch? Oh yeah. Where's panel 2? Where's panel? It's this panel. No. Oh, sorry. Yeah, there it is. The chair calls Lee Johnson, Jordan Dixon, Trina Ida. Now, Mr. Johnson, I'm gonna not let you off this hook because I'm always coming at you about what y'all do out there, and but I'm gonna step back here to the restroom to come right back. I'm gonna be listening to you.
Appreciate that.
I'm gonna hand this to Chair Perry. So we'll go, Mr. Johnson, then we'll go to Miss Dixon and Miss Ida.
Go ahead, Lee.
Okay. Thank you, Chairman. Thank you, Madam Chair, members. My name is Lee Johnson. I'm blessed to serve as the CEO for the Texas Council of Community Centers. My slide deck is going around right now, and I'm going to walk through the slides that I've included. Senator Perry, I'm going to try to be as concise as possible. I will say your question about state-supported living centers is probably best answered by our colleagues here today from the Health and Human Services Commission, but I will. Be
I don't know why I keep lumping you into that industry, but I always do. But that's good.
So on slide 2, you'll see a few points about the system. I'll point out 72% of adults with serious mental illness and 28% of children with serious emotional disturbance served in the public system are low-income uninsured. 95% of Medicaid services are in managed care today, including mental health and substance addiction services. And the Texas legislature has invested substantially in mental health. I'm going to talk about that more in a minute. But first, I want to call your attention to the map that you see on the right side of that slide. And I want to point out that each of the regions that you see identified there were defined by a local process that involved the taxing authorities in that area. There are local boards of trustees in each of those regions identified. Those local board members are volunteers. They are community leaders, and they are appointed by the sponsoring entities for the organization. So that could be the county, the city, the hospital district, and in some instances, a school district. These local leaders have a connection to the services. And as Madam Chair mentioned earlier, I want to thank her because today we have local county sheriffs either as voting members of those local boards or as ex officio members that participate in that process in every one of those regions across the state of Texas. And then I want to say before I jump into the more of the presentation, just for context, think about the fact today that there are 39 local authorities in Texas. They cover all 254 counties of the state. Also think about the fact that there are over 900 hospitals in our state, including 157 rural hospitals, 1,200 incorporated cities, more than 600 courts, 239 county jails. I checked that number. It's the Texas Commission on Jail Standards number. 1,250 ISDs, about 9,000 school campuses, and 72 federally qualified health centers. I make those points to just say, as you all well know, Texas is a big place. All right. On my next slide, you'll see, this is on slide 3, you'll see on the left side of the slide services that are available on a statewide basis, and then on the right side of the slide, services that are available in certain local service areas that have been able to generate resources. So the sheriff made note of this in his testimony previously, but what I want to say for context here is that all local authorities across the state have a standard performance contract with the Health and Human Services Commission. The contract requires certain services on a statewide basis and includes standardized outcome measures and required reporting on the use of state funds to deliver those services. The contract also requires local mental health authorities and local IDD authorities to use a standardized assessment tool. That for mental health authorities is Texas Resiliency and Recovery. That assesses a person's clinical needs and determines the standardized level of care for both adults and children. This standardization creates consistency in the assessment process across the state. But as you heard, that said, there are local needs and local resource limitations that create variation in service delivery across the state. Those variations are driven, in my view, by the fact that the state is a very large place, that local needs vary by community, and that local entities have a varying degree of resources to be able to contribute to this effort. Okay, on my next slide, slide 4, this slide shows the responsibilities for the local authorities that go beyond just the traditional service delivery. So they're responsible in law for securing local matching funds, leveraging resources to enhance services, educating the public, facilitating local planning, identifying service gaps, collaborating with other stakeholders, and of course, responding in times of disaster. I want to make note of something because I know Madam Chair was on the select committee, and of course, Chairman Perry, you were on this as well, and others in the Senate were involved in the select committee related to the floods in Kerrville. You may recall in that hearing that y'all had in Kerrville that we had representatives from our system there who testified pretty late that night about the role that they played. So the Hill Country MHDD, which is the local authority, primarily they're based in Kerrville, but they serve a regional area on that map I showed you. They, along with 5 other local mental health authorities, coordinated a response that was focused on families, on people impacted by that disaster, and on first responders. And that work continues today. I just want to leave you with a data point about this. So in the first few weeks following the floods, those local mental health authorities had more than 18,000 service encounters. The typical volume for that area is about 8,000 service encounters per month. So that gives you a sense of the scope of that response. On slide 5, you'll see the state required local match for mental health and IDD services compared to the local resources that are generated. That slide pretty much speaks for itself. On slide 6, you'll see local taxing authority investments. So we've talked a lot about the resources component here. If you look at this slide, what it shows you is that from fiscal year 2020 to fiscal year 25, these are the local investments that are made by taxing authorities like cities, counties, hospital districts, for a total local taxing authority investment that exceeds $155 million. This data runs a year behind because it comes from our certified independent fiscal audits that all of the local authorities are required to submit to the Health and Human Services Commission on an annual basis. And I'll say this, in my view, I believe that the reason local taxing authorities are willing to make this level of investment is because they see the unmet needs in their communities, number one, and number two, they have accountability and oversight of these services because they appoint the local community leaders who serve on those local boards across the state. On slide 7, you'll see this is FY25 LMHA funding by financing strategy. Obviously, you can see in this chart that LMHAs are a big part of the state's mental health care system, but our system represents about 35% of the funding for behavioral health in our state. And Madam Chair has correctly described that local authorities act as a liaison between local and state governments. This is such a true point. It's an excellent point. Unfortunately, some mistakenly believe an LMHA or a local IDD authority is solely responsible for solving every unmet need for people with severe mental illness or intellectual disabilities. But just as a car can't run without fuel, this infrastructure can't solve these complex challenges without available resources. And one of the questions that we were asked to address, and I think it's come up in testimony, so I'll spend a minute on this, is how local mental health authorities balance resources amongst competing needs and jurisdictions. So I'll tell you, stretching limited resources is the most challenging of the responsibilities that we have as a system. While local authorities answer to their local governments and their appointing authorities, they also answer to their local boards of trustees, and they seek to address those local concerns. Much of their funding comes from the legislature for specific purposes, specific populations, and specific service arrays. So, for example, Health and Human Services Commission administers appropriated funds according to legislative direction. So, crisis funding for crisis services, right? Outpatient treatment funds for adults and kids, specialized programs that you've heard of like multisystemic therapy, coordinated specialty care, youth crisis outreach teams. Those are specific funds for specific purposes. LMHAs cannot simply move dollars from one category to another when local demand or expectations change. And I'll also add, this balancing occurs through service capacity management, coordination across multiple funding streams, and strong local partnerships. And in very practical terms, this means someone, somewhere, is always mad about something. That's what this means. So as members of this committee, I know you well understand the needs of Harris County differ dramatically from those of frontier counties and regions that serve sparsely populated counties. A locally governed system that we have today allows communities to respond to the best of their ability while still carrying on statewide priorities that are established by the legislature. So slide 8 shows you another view of this. This data, of course, comes from the data that's required to be submitted by all local authorities in the statewide reporting system. On slide 9, the committee asked us to talk about individuals, including diagnosis and demographic profiles who experience mental health crises and become frequent utilizers of public systems. You can see in this chart that 96% of the people served in our system are people with serious and persistent mental illness. One of the most important observations that I would put before you today is that the highest utilizing individuals are rarely defined by a single diagnosis. As we've talked about today, you have mental health issues with co-occurring substance use issues. You have serious and persistent mental illness with co-occurring intellectual and developmental disabilities. These folks have repeated engagement, either experiencing homelessness. They're more likely to cycle through emergency rooms, psychiatric hospitals, jails, shelters, and crisis response systems. This creates significant cost to local governments, hospitals, EMS, law enforcement, cities, and the courts. And so, in my view, I will say it's important to understand that the issue is not simply about mental illness. Rather, it's the intersection of mental illness with housing instability, addiction, poverty, and other chronic health conditions. And while many communities have made progress, and you heard about that in the earlier panel today, and you may hear about other examples later, I think about diversion programs, co-responder models, competency restoration programs. Those programs alone cannot solve the challenges of these really complex populations. So on slide 10, you'll see the red line represents state population. The blue line represents state-funded inpatient psychiatric beds. This picture is really where the story of investments our legislature's made in inpatient care begins. Limited access to inpatient care is a dynamic the Texas legislature and leaders like Lieutenant Governor Patrick, Chair Huffman, Chair Kolkhorst, and many others in this body have been working very hard to address in our state. The next slide is the slide that Judge Jan alluded to. This shows you that 75% of the individuals in the state hospital system are there because they are in the criminal justice system and in need of competency restoration. So what this means is that if you're a person who's not involved in the criminal justice system and you need access to inpatient care, the way you get that access today is through a locally purchased private psychiatric bed that the agency, Health and Human Services Commission, you allocate funds to them, they allocate funds to the local authorities that then go out and negotiate contracts with those local hospitals. These locally purchased beds are a lifeline for folks that are not involved in the justice system but in need of inpatient psychiatric care. On slide 12, I'll spend a moment on this slide. This shows legislative investments over time, looking from fiscal year 2019 to fiscal year 27 in the current budget we have. The first bucket is inpatient care. The second bucket is outpatient treatment for adults and children. And the third bucket is crisis response services. And this shows you the investments, as I said, over time. I will say, this has been described as kind of the three legs of the stool. It's also been described as the continuum. So in other words, you need access to inpatient care. You also need outpatient treatment. You also need crisis services. And what I'll say to you is that I believe the legislature deserves substantial credit. It's about $2.5 billion invested in our inpatient care system in the state. Those investments were needed. We vigorously supported those investments, and those investments will have life-changing impacts for Texans, to come. But what I will say is, when you look at outpatient treatment for adults and kids and crisis response, we need to have a balance between those three. I'm not suggesting that they all need to be equally funded, but what I'm saying is now the time is to look at what do we need in outpatient treatment so we can stem the tide of people going into inpatient care? What do we need in crisis response services so that we can stem the tide of people going into the justice system and into higher levels of care? I'll say, just for a quick history, the legislature was making targeted investments in outpatient treatment for adults and kids from about 2013 to 2019. In 2020, the pandemic hit, and federal funds became available through the enhanced funding that the federal government provided, and that federal funding became part of our system. And you can see in the blue bar and the orange bar, the difference, the decline there is the loss of those federal funds that were terminated in March of last year. So I will also say, over the last 5.5 years, we have not seen exceptional item funding requests from the Health and Human Services Commission for outpatient treatment or crisis services that made it through the process. Funding has come when individual legislators have submitted earmark requests or budget riders. And this means funds are not allocated across the state. They're only available in certain communities. So a sheriff may call you frustrated because they don't have a diversion center that the sheriff next door in a neighboring county has. And so I'll just say, we're really encouraged by the new leadership at the Health and Human Services Commission and hope funding needs in our system will get the attention that they really need. So I won't spend much time on slide 13. I know our colleagues from the Health and Human Services Commission are going to talk about that. I'll also touch on slide 14 quickly. The sheriff alluded to this, the Justice Involved Grant Program, the Healthy Community Collaboratives, the Community Mental Health Grant Program. I will say the 88th legislature expanded the Justice Involved Grant Program and Community Mental Health Grant. These funds are being fully utilized today. And as the sheriff mentioned, the local match requirements are sometimes difficult for counties to come up with, particularly if they've already got a grant project and they need something else because their needs have changed, or if they're a rural area and they're trying to come up with the match required. We'd like to see those requirements further streamlined, and we hope there'll be interest in that next session. Slide 15 is a map. It shows you where those projects are located. I won't spend much time on that, and I'll keep moving along. On slide 16, This is an investment from the 88th legislature. It was called Rider 52. It looks at crisis diversion programs, and you can see where they're located by this map. What I will tell you is this was an opportunity where the legislature appropriated funds to the Health and Human Services Commission, and the Health and Human Services Commission said to all of our members, you go out, talk to your county judges, talk to your commissioners, talk to your sheriffs, and submit plans, submit proposals that tell us what you would do if you were awarded that funding. So the total dollar amount of projects submitted, there were 47 projects, some submitted multiple projects. The total dollar amount was $233 million for the biennium, and the legislature appropriated $28 million to fund projects. There is always a gap between need and demand. Need and available resources. We recognize that, but we're hopeful that this is an area that will be looked at in the next legislative session. And then slide 17, and I promise, Madam Chair, I'm getting to the end of this. A lot of information to cover here. So what you'll see in your copies, the map is actually green. In the online version here, the colors are slightly different. I apologize for that. But what this shows is jail-based services by local mental health authority beyond the required crisis screening and assessment. So I think everyone here is well aware that crisis screening and assessment services that are funded by Texas are available in county jails when that's requested, right? But what we know is that very often the people in those jails need far more than just a crisis screening and assessment. They need access to ongoing services. So what this graph, the map shows you is it shows you the 140 counties that today are contracting with their local mental health authority. These are county jails in contract with their LMHAs to provide services beyond just that basic crisis screening and assessment service. So I will tell you, and we may hear, even if there's a local contract, there are still issues that arise from time to time in local communities. It's one of the reasons why we're absolutely thrilled to be working with the Sheriff's Association of Texas on this technical assistance effort. And Madam Chair, I was thinking about this in just 3 or 4 years ago, we did a similar survey, and it was 90 county jails that contract with their LMHAs. So this, to us, looks like progress in the right direction. And so what I'll say, knowing that there are 239 certified county jails in Texas, this means that LMHAs have agreements with nearly 60% of the certified jails in Texas. This is huge progress in the right direction. And then I will leave you on slide 18. I'm going to wrap up my presentation. We were asked to provide some long-term options to address complex populations that we've talked about. I will say, in my view, first, as we think about how to address these challenges, it really starts with the frontline outpatient treatment for adults and kids, and it starts with the crisis services. But beyond that, I want to talk about supportive housing, intensive community-based treatment models, strengthening integrated treatment approaches for individuals with co-occurring conditions, and then also continued investment in diversion and specialty court programs, which make a huge difference for folks. And so you'll see those recommendations there. In my the last two slides are just reference. Those are just different ways to look at information I talked about previously. And the last slide on the deck is my contact information. And I want to leave you with that, because if you are ever in need of assistance with your offices, if you or your staff are contacted, please reach out to us. Please reach out to us. And so the last thing that we were asked to talk about is, what does success look like for these populations? And I think that's a really important question. And I would respectfully suggest that success can't always be measured by the complete elimination of treatment or support needs or undesired outcomes. For some people, success means remaining in 12 months of consecutive services, or it means, for others, it could mean less inpatient hospital admissions, where you have many inpatient admissions in 1 year, and then the next year you're down significantly on that number. For others, it means avoiding the criminal justice system, or staying in treatment services longer, or reconnecting with family supports, as has been talked about in the panel previously. And I would just say, and I mentioned this to Mr. Gonzalez as he left, the person who is here representing defense attorneys, and I want to say this publicly for everyone here, a very good resource is the 988 number. So if you need help and you need to get connected to someone, please call 988. You can dial that from your cell phone and you will be immediately connected. There are 5 locations in Texas. There are members of our association that answer those calls for a big defined region. So if a family member that you encounter is in need of assistance, please help them. Get 988 as the option there. But as I said, the highest utilizing individuals often have the most complex needs. And so I would submit to you that measuring success is defined by stability, by recovery, by improved quality of life, and reductions in crisis-driven utilization. And so the next challenge we have before us is ensuring people don't have these repeated interactions with the crisis system in local jails and hospitals. And so I will say, on behalf of our executive directors and CEOs across the state of Texas, on behalf of our board members that serve as volunteers across the state of Texas, we stand ready to continue partnering with you, the legislature, with our partners at the Health and Human Services Commission, with counties, with hospitals, with local law enforcement agencies, and other local stakeholders, because together we can build a system that not only responds to crisis, but it helps people reach long-term recovery. And so thank you, Madam Chair, for the opportunity to testify. I look forward to the continued discussion today, and I hope I kept it as brief as I could.
Thank you.
Thank you.
We'll come back for questions. Ms. Dixon.
Good afternoon, Madam Chair and members. My name is Jordan Dixon, and I'm the Chief Behavioral Health, Disability, and Aging Services Officer at the Health and Human Services Commission. We are not going to go through all 71 of my slides, Madam Chair, so don't worry.
I was going to say you have less than 10 seconds.
Yes. So I started with just kind of an overview of our inpatient capacity, but I think that's been discussed quite a bit. I do want to mention just on slide 3, sorry, I'm supposed to be doing this, right? I feel like a professor. I do want to just mention the inpatient admission criteria. And this applies to most, but not all of our admissions, and I'll explain that in a little bit. But somebody has to be has to present a danger to themselves or others, or be at risk of serious deterioration. So those are the folks that those are the criteria basically for our folks who are with us on a commitment. Slides 4 and 5 are just more detail about the inpatient capacity we have. Yes, ma'am.
So 802 private psychiatric beds run by the LMHAs, is that right?
Yes, contracted through the LMHAs.
Y'all don't do that. They do that.
The appropriation comes to us, and then we fund them, and they contract directly with the private psych hospitals.
All right, keep going, and we're going to come back to that.
Okay, and as you can see, only 59 of those are forensic, so those are really civil beds, and they are also our higher turnover beds, and I don't say that in a bad way. Lots of emergency detentions, short-term temporary civil commitments. So you could see they served over 20,000 people in FY25.
A lot better than the state did when I read through this. Keep going.
Yes. We have a different population.
It's rare.
Thank you.
Rare.
I appreciate it.
Keep going.
Okay, so slide 5 is our state hospital system, which has grown. So we have obviously our kind of core state hospitals that are owned and operated by the state: Austin State Hospital, Kerrville, Rusk, etc. Then we have 2 hospitals that we own but are operated by academic institutions. That's the Texas Behavioral Health Center in Dallas, which just opened, and then the Dunn Center. And then we have hospitals that we neither own nor operate, but we contract with for beds.
Dunn Center in Houston. Keep going.
Yes. So 70 to 75% of our beds and our contracted beds are forensic. State hospitals are also the only inpatient provider that receives extended forensic patients. So we do have a longer length of stay. We get the hardest people to restore, the most dangerous people, etc. And our state hospitals served about 5,500 people last year. Our contracted providers served about 2,300. So altogether in these 3 different settings, including the private psych hospital, over 27,000 people received those inpatient services. On slide 6, I'm not going to go into a lot of detail on this. I do want to just mention a couple things that were brought up first to just like very clearly delineate civil from forensic. Forensic does not just mean justice involved. It is either not guilty by reason of insanity, which they are only committed to hospitals for inpatient, or it's incompetent to stand trial. So people can be justice involved but have competency. So I just want to clarify that. The other difference, and then for civil commitments, they have to present a danger to themselves or others or be at risk of serious deterioration. The other difference, and this was brought up several times, is for forensic commitments, we cannot discharge people to the jail, to the community on a forensic commitment without a judge's order. With civil commitments, and I'm not saying I disagree or agree with this, it is a commitment order, but the state statute says that discharges from civil commitments are either when the civil commitment expires or at the professional clinical discretion of the provider. So statute allows us to, our psychiatrists and those in private psych hospitals, to release someone when they no longer meet criteria. We often, if they agree to it, will keep people longer because even though they don't meet criteria, we think they still need inpatient care. We don't have to worry about the issue of insurance not paying for those days like some of the private psych hospitals do. So I just wanted to delineate that. And then our adolescent forensic program at Vernon, most of those kids are actually voluntary and they're with us as a condition of probation from TJJD. I will go on to our wait list. So you all are aware of our forensic wait list. We also have a civil wait list. Excuse me. Unfortunately, it is much smaller. It's 79 individuals as of June 1st. And it is basically, we maintain the wait list, but the individuals are placed on the wait list by the local mental health authorities who are managing kind of their local capacity. And so if someone cannot get access to one of the private psych beds or a state hospital or some other inpatient setting, and they need inpatient care on a civil commitment or just as a voluntary admission, they go onto that wait list. And then we manage it in one centralized place. And if we see that somebody's been on it for 2 weeks, 30 days. If we see that there's a child on it, we reach out to the LMHA to try to understand what's happening and can we troubleshoot and get this person into care. And then we also require the LMHA to do a clinical check with the person, depending on their setting where they're waiting, every 3 or 7 days to make sure they're at least as stabilized as possible while they're waiting. And then, of course, we have our forensic wait list. So I will talk about the forensic commitment process in just a minute, but once a judge commits somebody to inpatient competency restoration, that commitment packet comes to us, HHSC. We have 1 day to place those folks on either our clearinghouse wait list, which is forensic but not maximum security, or our maximum security unit wait list. Right now we have, you can see there we have about 1,585 people on our wait list, and you can see the breakout of maximum security and non-max. That is a big improvement from our height at FY22 when we were at about 2,600 people. And then our wait time in FY25 was 209 days on average, and so far for FY26, that's 189 days. So still I'm not bragging about that. We don't want people waiting 6 months, but we're headed in the right direction. And of those, I think I mentioned the new beds coming online thanks to y'all's investment between now and spring, summer of 2028. Because of the investments of the legislature, we'll be adding 717 new beds to our system. 496 of those will be forensic, and 140 of those will be maximum security. So that will be hugely impactful. I really quickly just want to talk about another effort we have, our forensic support teams. So we have piloted this in Travis County and Dallas County. and have just signed a contract with El Paso County. And this is where we have people go into the jails and work with people. A lot of people, especially if they're coming in with substance use issues, they regain competency while they're waiting, but there's not a assessment done. So we've identified people and asked the court to order a new competency evaluation. Or we identify people who are much lower risk and maybe they can be restored in jail-based or outpatient competency restoration. So in the last 14 months in just 2 counties, we've removed 221 people from the forensic wait list using those forensic support teams. So the only cost is travel and people. We would love to expand them to other cities. Okay, I will move on to the different types of admissions we have in our state hospitals. So voluntary admissions. Commissioner, I know you've talked to Scott Shacklin in particular a lot about walk-ins. So voluntary admissions have a different admission criteria than that.
On page 13?
Oh, I'm sorry, page 10.
Page 10.
I'm really doing a bad job, Sally. I'm sorry.
All right, there we go.
So the admission criteria for someone who just walks in and voluntarily seeks services or their parents bring them in or the LMHA is, we are hospitals, we are subject to EMTALA, so we have to screen and stabilize everyone who walks through our door. If the facility determines that after an exam that the person has symptoms of mental illness and will benefit from inpatient services, we can admit them. Out of the 2,370 walk-ins, and I'm using that in quotes for a reason that I'll tell you in a minute. In FY25, we admitted 66% of them. Now, if you go to the next slide, something I learned recently is you'll notice slide 11 says walk-in or unscheduled admissions. So of the 1,573 walk-ins, 77% were actually brought to us on emergency detentions. So because that's not a commitment, it was classified in our data as a voluntary admission. So there were only actually 350 true off the street walk-ins in FY25. And I know that's been a point of interest to you, Madam Chair. So most of those emergency detentions will turn into civil commitments to the hospital.
Say that again?
Most of those emergency detentions, if we can't stabilize them after we get an order of protective custody, most of them will turn into civil commitments, and most of our civil commitments start out as an emergency detention, either in our hospital or an ER or private psych hospital. And you can see there are the different facilities where, in particular, El Paso and Terrell, that have a very high percentage of their patients are walk-ins and mostly emergency detention. So El Paso, Center Blanco, you're probably aware the state hospital is right next door to, I don't know if it's the only ER or the busiest ER, so they just bring them right next door. And there's also really not a lot of outpatient services or crisis services, which hopefully that's being addressed through some investment from the legislature. Terrell it's just kind of part of the culture of that community. The police officers, the sheriffs just bring people to that state hospital. There's not a lot of other options. So we have asked the LMHA, and they are now embedded on the Terrell campus to try to divert people. And we're also hoping the new hospital in Dallas will divert some of that capacity. I'm going to keep moving to slide 13. So civil commitments, I mentioned as a court order where a person is at risk of serious harm to themselves or others, or at risk of serious deterioration, who lack the ability to make rational and informed decisions and submit to treatment. So a lot of these folks don't openly admit that they have a mental illness, or we're not medication compliant. And these are probably a lot of the folks that law enforcement is encountering and bringing in on emergency detentions. I mentioned this says civil commitments can result from these events. Most of ours are from emergency detentions. And just to give you kind of an idea of the volume. Sorry, I have too much paper here. So for FY25, we have 563. We had on average 563 civil commitments, and the rest of our 2,040 were all forensic commitments. Again, we are the only provider that takes the not guilty by reason of insanity. We have 392 of those, and 1,085 incompetent to stand trial commitments. And I said FY25, this is as of June 1st, so my apologies. So we are mostly forensic. The private psychs are mostly civil, and then our contracted beds are mostly forensic as well.
Give me those numbers one more time. 563, 2040. I was getting lost there.
Okay, so just for, let's see. Okay, so I'm going to give you the numbers for both our state hospital facilities and the ones we contract for. The total census as of June 1st is 2,508. Out of those, 1,857 are forensic and 651 are civil. And then of the forensic, the 1857 forensic, 1,465 are incompetent to stand trial commitments, and 392 are not guilty by reason of insanity.
1,000 what are?
1,465 are incompetent to stand trial. So they're committed to us for competency restoration.
Okay, and what's the reason behind the insanity?
The 392.
Are those long stays permanent?
They're not, well, some of them have been with us for 20 years, but their average length of stay is like 1,200 days. Our average length of stay for extended forensics is 341 days. So yes, NGRI has by far the longest length of stay. And our civil average length of stay is 92 days.
Keep going.
Okay. So I don't know that you need me to go through the different types of civil commitment applications. We get a lot, it says on page 14 that we only had 22 extended commitment admissions, but we were serving about 250 extended civil commitments in FY25. I did want to talk, obviously, if we restore competency to someone who's with us on a forensic commitment, the discharge is to the jail, and we do have some discharge requirements. But I did want to talk just about for civil commitments when we're discharging from a state hospital and when our contracted partners are, discharging from a state hospital to the community. And this applies to our contracted beds that discharge to the community. Just wanted to talk a little bit about some of the requirements we have. So we have in our rules joint discharge planning between the local mental health authority and the state hospital is required to start from the moment of admission, basically. So within 3 days of admission, if our state hospitals haven't heard from the LMHA, we will reach out to them. Often the LMHA reaches out to us before we, they know their folks and who's come to us. And so we work together to create a discharge packet and plan. So it's going to list where are they going to live, what kind of medication are they on, what dosage, what are their stressors, all of those things. And it will also include a psychiatric evaluation, a social assessment, physical exam notes, medical history, medication list, lab results, anything a practitioner might need to ensure continuity of care in the community. So that goes to the LMHAs when they're discharged. We are also, state hospitals are accredited by the Joint Commission, so we have discharge standards for that. And then I did want to just mention the the legislature, the 88th legislature, funded transition support teams to really focus on those folks with that probably are the frequent flyers. So we have at least one employee at every state hospital that is designated to provide like intensive support and case management for people who are discharging, who've been discharged and readmitted within the last 30 days, or have been in the facility for longer than 1 year.
SB 26.
Yes, ma'am.
Keep going.
Yes, SB 26 by Senator Kolkhorst.
I didn't do it for that. Let me take a bow. Is the DA out there listening? Okay, I'm working on this, okay? I didn't mean it like that, but I wanted to make sure that was that bill. I was like, Maureen, didn't we do that? Okay.
It was, yes, ma'am. In FY25, the transition team, specialist team, executed a total, that's a weird word. They discharged a total of 199 individuals with these transition teams that fall into those categories. And as of June 1st for FY26, we've discharged 194. And then we also, for that same population, our state hospital transition teams reach out to the LMHAs at 30 days, 90 days, and 1 year to follow up and see how that individual is doing. And then for our local mental health authorities, which Trina will talk a little bit more about the oversight, but we do require them obviously to participate in all of the discharge planning that happens while the entire time the person is with us, to agree to the outpatient plan, and then also to see the individual within 7 days of discharge. We also have a performance metric that they are at risk for. In other words, there could be a financial penalty if they have somebody under their care who readmits within 30 days. If they reach a certain percentage of people who do that, I should say. Okay, I'm going to go on to forensic commitments. So slide 17, I've already kind of talked about incompetent to stand trial, and that is pre-adjudication. They don't have the capacity to understand or participate in their own legal defense. As you can see, so there's 3 settings a judge can commit somebody to for competency restoration. Inpatient, which is those first 2 numbers on the slide, our state hospitals and our contracted beds, is obviously the most secure. It's the most expensive, and it's also the most effective. That is most often used by judges. We also, as you've heard, have jail-based competency restoration, and then we have outpatient competency restoration. Jail-based and outpatient competency restoration commitments are made to the local mental health authorities, and they provide those restoration services. If you go to slide 18, this is the competency restoration process, and steps 1 through 4 I can talk through. Those are really before they come to us. I do want to correct the time. It says that it takes an average of 321 days, and that is from the time that they're arrested to the time the court orders a commitment. For the first 3 quarters of FY26, that average was 427 days.
Whose fault is that?
Not mine. It is, I mean,
Keep going. I'm breaking my own rules. I want to jump in here. Come on, George.
I know
Keep
you.
going.
I know.
We're gonna come back.
Okay, and then steps 6 through 7, our average for FY26 is actually 189 days. So that's that wait list time I mentioned earlier. So I will say there's a lot of diversion that happens by our law enforcement before step 1. Between steps 1 and 2, there is a lot that happens based on legislative direction to screen people, to identify people who have mental illness, who have IDD, to try to either divert them or ensure that they're going to get services in jail. And that also, through that process, it's much more complex, and I can walk through it, but I'm seeing in your eyes you don't want me to. So so basically that starts the screening process, and eventually through a couple other reports and evaluations, it is identified that the person probably is not competent or could be incompetent to stand trial. At that point, the trial judge will order competency restoration evaluation. And I just want to, on slide 19, point out because I think I've heard people say like just anybody can do the competency evaluation and they could be biased. It has to be a licensed physician or doctoral level licensed psychologist with one of those following credentials. And the county has to pay for and either hire or contract out for the competency evaluation. If you go to the next slide, there, to my knowledge, is not like a standard competency evaluation form, but there is explicit direction and statute on what they have to consider. And competency restoration, as I think one of your past panelists mentioned, half of it is psychiatric stabilization to get them to the point that they can participate in trial. The other half is legal education on making sure they are able to make reasoned legal strategy choices, to testify if they choose to understand, the process. Slide 21, this is just like a comparison of the three different competency restoration settings. For all three of them, for a misdemeanor, the initial forensic commitment is 60 days. For a misdemeanor, it's 60 days. For a felony, it's 120 days. You can get an extended forensic commitment for up to 12 months, and those only come to state hospitals. And then I will just really quickly go through the different types. So on slide 22, this is inpatient competency restoration. And in FY25, this is just for state hospitals, we admitted 1,587 incompetent to stand trial, so people for competency restoration, and we discharged 1,257. So most people we are able to discharge. If someone is going to be restorable, and we'll talk about unable to restore and unrestorable in a minute. If someone is going to be able to be restored to competency, it's typically going to happen in that first 90 to 120 days. It's not impossible after that, but the chances get lower and lower. And about 1/4 of our initial competency restoration commitments will be extended to longer term. Outpatient competency restoration, the only thing I want to mention here is that there are some eligibility limitations. So an individual has to be their offense has to be Class B misdemeanor or Class A felony. So it has to be an offense that is eligible for bond. And then that criteria I mentioned of being a danger to yourself or others, they can't present a danger to others to be committed to outpatient competency restoration for obvious reasons. And then finally on slide 24, we have jail-based competency restoration. Outpatient and jail-based competency restoration are not available statewide. There are 19, sites for jail-based competency restoration, I think serving 36 counties. And an interesting thing about jail-based, and again, one of your panelists alluded to it, is you can have like a dual commitment where someone is committed to inpatient competency restoration, but if they're going to a jail to await their admission and that jail has a jail-based competency restoration program, the judge allows that to be attempted. So hopefully they can be restored earlier and not have to keep waiting for an inpatient bed. Before I hand it over to Trina, my last slide on slide 25. So these are kind of all the different outcomes that can happen. So let's say we're at the end of the initial forensic commitment for a felony. It's at 120 days. One option, of course, and the most common option is that the most common outcome is that we restore their competency. They go to jail, they face trial, and go through that process. We may say we're not able to restore competency, but we think we we think we can get there, and we will request an extension, an extended competency commitment. We might say we don't really see them restoring in the foreseeable future, or we don't think they are restorable. Some people are just not going to be restored. And at that point, this is where it gets kind of weird. The criminal court will hold a civil commitment hearing and leave charges pending and commit them to us civilly. The reason a criminal county judge is going to want to do that is so that they can keep tabs on that case and not hand it over to a civil court, which, I mean, that's their prerogative, and I understand those are usually the frequent flyers or folks that everybody in the town knows about. So they could do that, or they could do what's called a dismiss and transfer, where there's not a compelling reason to prosecute. The prosecutor will request a motion to drop the charges, and then the criminal judge will transfer the case to a civil court, and they will civilly commit them to us. So we do have people that are unlikely to restore that are with us. The average length of stay for someone who's been on a forensic commitment and then it's kind of converted to civil is 996 days. So we have, I think, of our about 2,000 folks, 796 have been with us for over a year. So we have a lot of people with very complex needs, people that will never really be able to face trial, and even people on long-term civil commitments that just are not able to be served in the community. I will hand it over to Trina unless you want to. Okay.
Good afternoon, Madam Chair and committee members. I'm going to talk about some of the housing options that we have available in our service array. But before I get into that, I'll talk about just broadly the levels of care that we have that are served in local mental health authorities. And these services are really designed to address unmet need, to keep people out of inpatient options, although we recognize that there are times in people's recovery as they're getting care where they may need an inpatient option. But by and large, our goal is to keep people in community with these services. And so the first slide that I'm covering on slide 27 just gives a general framework for the activities that you might see in some of the housing options, because as folks are getting treated in an inpatient setting, there's somewhere they need to go once they're released. And so some of these options that I'll talk about have 24/7 intensive support, clinical care, some case management, and some other things that are provided to individuals once they transition from an inpatient setting into the community. You can move to slide 28. So these are some of the options that we have by way of housing that we have contracts with both local mental health authority providers and private providers to deliver. We have step-down homes. We have home and community-based services for adult mental health, which is actually a state plan amendment. That is a Medicaid entitlement for people who qualify. So that's important to note. We also have healthy community collaboratives, which is in both rural and urban centers. And then we have projects for assistance in the transition from homelessness, which is a federally funded program. And then we have supportive housing and rental assistance, which is also offered at local mental health and behavioral health authorities for folks who are homeless or at imminent risk of homelessness. I'll talk a little bit about our state hospital step-down programs. We've been operating that for a few years now, and here's some data that just shows from FY23 to FY25 how many admissions, discharges, and numbers served. Currently, we have about 48 beds that we operate, but we anticipate having an increased capacity by the end of this fiscal year up to 72 beds in terms of capacity. The cost to operate that state hospital step-down program is about $492 per bed day for that option. And the average length of stay is about 324 days. And so we have people that are admitted into that program. We really work closely with our state hospital partners to identify people who can hopefully successfully transition into that community, focusing on the 365-day list. There's a a list that we monitor to see at the state hospitals, people who've been there over 365 days. And we really try to target that population to get them out of the state hospital so that there can be capacity freed up to serve more people. I'll go to slide 30, excuse me.
Madam Chair,
Yes.
quick question. Point of clarification. Did I hear you say we're going to have 72 state beds?
Currently we have 48, but
48
by the end of this year, we'll have 72.
Step downs.
Step down home
Yeah.
beds. Mm-hmm.
Kind of what we're talking about. Just start.
Those are the kind of places we need to focus.
Mm-hmm. For sure.
For sure.
So
Small number.
yeah, it is a small number, but we do have some good outcomes. And so what we
start
see,
that.
I'm sorry?
When did we start that, Commissioner? The program.
I think we started back in FY21, and we started with using block grant dollars because we recognized that there was that missing continuum piece. We heard a lot from providers that we just need something that's in between, people who can't necessarily transition to live independently in the community, but they need something more. They need more wraparound services that can hopefully help them get set up to transition to independent living at some point. And so to that end, we've had people transition from that step-down home into their own residences. We've had people gain employment based on those supports that they're getting in that option. I think in FY25, % of those discharges 100% did not return to the state hospital after receiving services in that step-down option. I'll move to slide 31, home and community-based services for adult mental health. This is the one that I mentioned to you was a Medicaid entitlement. We have 3 populations that we focus on, folks who have high hospitalizations, many visits to the ER, or back and forth to jails. Those are the 3 populations that we focus on with this particular program. As you can see from FY 21 to 25, we've seen a steady increase in that particular project. People discharged from the state hospital that to the HCBS AMH program, those numbers are on the second line there. And this is an unduplicated count of both numbers served and folks discharged. Right. In terms of outcomes, we see that there's decrease in crisis encounters, decrease in use of inpatient hospitalizations, and decrease in arrests for folks who get HCBS AMH. I'll transition to Healthy Community Collaboratives. Healthy Community Collaboratives started some years ago, and it initially started focused on the urban centers in the state for the most populous counties, to have a collaborative program focusing on folks who were at risk of homelessness or at imminent risk of homelessness, who have mental health and or substance use issues, to get a array of robust services to support them, to hopefully get them from being homeless and connected to community and mental health services. And so some of the top services that are used are mental health treatment, housing services, and supported employment services. We've served over 10,000 people in those programs. Right now, we have, I believe, 5 urban Healthy Community Collaborative programs, and we have 2 that are rural facing. Next slide is 34, which gives a snapshot. That doesn't show all the providers that we have doing that service, but it does show Tarrant County, Haven for Hope, and Crisis Center of Comal County, and some of the outcomes associated with their specific programming. So for Tarrant County, we see a reduced arrest and jail bookings rate, which was at 17.5% in fiscal year 24, and that's gone down to 11.9% with the goal towards getting to 0%. Haven for Hope, we have over 5,000 participants who enter the program as homeless, and then almost 5,000 avoided a new episode of homelessness in that program. And then for Comal County, we had occupied 18,000 of 21,000 crisis beds, 87%, reducing homeless duration and improving intensive services. Next, I'll talk about PATH, which is a federally funded program that is a formula-based grant that we get from the feds. And this program operates in 16 locations across the state. We just re-procure for that service. And so for 2025, we had just under $6 million that was allocated, similarly to what we have planned for 2026. And we have 16 locations that provide that service across the state. So this is a program that targets the homeless population who have mental health conditions. They're doing community outreach. They're going different places to try to connect folks who are not engaged in services that are homeless, to get them connected to care. The next slide just shows some basic data points showing folks who are enrolled in PATH that are then receiving community services, and that's just under 4,000. New people who were contacted or enrolled into PATH, and then people contacted by PATH-funded staff. So even though folks might be contacting them, they may not necessarily enroll in services, but they're going to continue to try to engage and outreach them to try to get them connected. Next, I will go to slide 37, which talks about supportive housing and rental assistance, which is a program that offers, as it says, rental assistance, moving costs, et cetera, for folks who might need to be housed or unhoused. We've served just over 1,500 folks with a total of just over 5,000 supportive housing encounters. And with this particular initiative, you see a decrease in crisis encounters before and after receiving that service, as well as a decrease in use of funded psychiatric hospitalization before and after receiving that service. So while we are not a housing entity, HHSC, we recognize that housing is a really important point to getting people stable in the community. If people's basic needs aren't met, like housing, it's harder to get them stabilized and engaged in services. We go to slide 38, I'll transition and just, I mentioned this earlier and talked about the different levels of care. And so within our local mental health authority system, we operate what we call the Texas Resilience and Recovery Model of Care. And within that, we have served just over 312,000 adults who receive those services. What you see there on that slide is the different levels of care that are really provided based on acuity level. And so LOC 0 is our crisis services. We have a lot of folks in our system through the crisis system. But if you are enrolled in any of those full levels of care that are listed there, you can receive crisis services, even though you're enrolled in one of those other levels of care. Our highest levels of care are LOC 3 and 4, which are intensive services. And LOC 4 is a evidence-based model that we call assertive community treatment. The other lower levels of care, that means they're seen less frequently. They may not have as high a need as people in LOC 3 and 4. And then I will transition to slide 40, which goes more into LOC 3 and 4. I think something important to flag based on the fact that we're talking about homelessness is that a good percentage of those folks who are in those higher levels of care do report housing instability, about 1/5 of those folks, which is just important to note. Next, I'll move to slide 41. This gets into our oversight. So as Chief Dixon referenced, the oversight that we do with our authorities is through our contract, right? We have monitoring activities that we do where we're looking at budgetary expenditures. We provide technical assistance. We do utilization management and review data to look at performance measures, one of which she referenced in terms of follow-up. That we assess on intervals of every 6 months to see how they're performing to hit a percentage threshold. And we have also our quality management reviews, which is on page 432. So we do an annual quality management review. We use a tool that looks at various variables, looking at Texas Administrative Code, contract compliance, and statute to make sure that our providers are adherent to those standards. If we have findings, they're put on a corrective action plan, and they have to respond within 30 days in terms of how they're going to remedy those findings that we identify in that process. We do also have the quality management arm. If we have, since we we do have some facility options like crisis respite, residential, et cetera. If any of those are newly coming online, our quality management team will go out and do an assessment of that facility and look at life safety issues and make sure that facility is ready and primed to receive clients that are going into those options. Right. I will go to slide 43. That just reiterates what I mentioned before in terms of being responsive within 30 days once findings are made and once a quality management assessment is done. And in fiscal year 2025, 100% of the CAPs were responsive to findings and verified to be complete at any subsequent visit. So we do follow-up. Once they issue it, give us the response in terms of how they're going to remedy those. We will go back to assess to make sure that those have been addressed. The last slide I'll cover just highlights some of the recoupment work that we do. If we have providers that fail to meet deliverables, we do take financial action and we'll recoup funds based on that. We also have done some recoupments around failment to meet measures. And then we do have some measures where we just focus on corrective action plans. If we issue corrective action plans for failure to meet performance measures, they have to respond within 10 days of that. And then we will monitor to determine if they remedy those. If over time there is no remedy, there are financial actions we can take, such as liquidated damages to do recoupments for those activities as well. And with that, I will close and open the floor for any questions folks might have.
Chair Moss.
Thank you, Madam Chair. We go back to slide 39. You may or may not know the answer to this. You've got, if I'm looking at this correctly, you've got different levels of care needed. Okay, is that a standard for the industry, or is that just something that Texas Health and Human Services put together? On slide 39, is that a standard? Because if it is, well, is it a standard?
I don't know that it is necessarily a standard. I think when people come into care, you assess what their needs are, and then you will tailor a treatment plan based on that in other systems. I know specifically for us, we have structured these levels of care to try and map to what the acuity looks like. Okay. So for example, LOC 1M is our lowest level of care, right? And because our system is really designed to support people who have the most chronic and persistent mental illness. LOC 1M is one that is hard for our staff or for clients to get into because they have to have demonstrated that they have had some level of recovery for an extended period of time before they can transition into that level of care.
Every agency has different standards, is what you're saying, pretty much.
Yeah.
Because where I was going with this is, if this is a standard throughout the industry, could somebody tell me what level do we find mostly in our county jails? At what level are we find highest level of this rating are we finding going to the county jails? You understand my question?
I do understand your question. Those folks are probably going to be at those higher levels of care, 3 and 4.
3 and 4?
Mm-hmm.
Okay.
Because they have higher needs. They probably have housing needs that need to be met. They may have some substance use issues. They have probably interfaced with the justice system several times or been hospitalized multiple times. So they're probably likely going to be in those higher tiers of care.
Okay. Thank you. Madam Chair, just so I hope you're hearing the same thing I'm hearing. The key word is housing. Mm-hmm. Key word we're hearing is housing.
Sarah Blanco.
Thank you, Madam Chair. Lee, thank you for your testimony. We've got just a question for you. You talked on one of your slides, you talked about the differences in investment from the state. You have inpatient care, you've got crisis response, and you have outpatient care. In listening to two of my local mental health authorities, Prima Care that provides care for my rural communities, and then El Paso Emergence, they're having similar issues, but Prima Care has issues recruiting workforce for rural communities. Emergence is dealing with competition from federal agencies or city agencies that pay more. Can you speak to any of the mental health workforce issues. And I think that slide may say something about it, but I wanted to get your opinion.
Yeah, thank you for the question, Senator Blanco. I really appreciate that. And, I was thinking about the survey effort that we did a few years back to look at the workforce challenges that exist. And I think you're absolutely right. This is something that affects large urban areas, and it also affects rural areas. The workforce challenges that exist have been present since long before the pandemic, but were exacerbated by the pandemic. So about 3 years ago, we did a survey of our membership, and 87%, nearly all of the local authorities, report challenges recruiting and retaining staff. And then 72% have reported in that survey unusually high staff turnover. One of the things that we see is folks will come into our system, they get trained, or maybe they're getting clinical hours and they achieve that threshold of clinical hours, they become licensed and certified, and then they move on to other systems. We see that happen a lot in our system, but the workforce challenge is a big part of it. And then I think about, our ability, to deal with market competition. To your point, for the example with emergence, where there's competition with other federal agencies that pay more, we are really hoping that there will be some attention in that outpatient treatment capacity piece in that middle bucket that I talked about, because if there are funds invested there, that can help us address some of the workforce challenges, also in the crisis system as well.
Great, thank you.
Thank you.
Senator Cook.
Thank you. So we've heard a lot about patients presenting with higher and higher levels of acuity. Lee, can you talk a little bit about what impact weak commercial coverage and thin network plans are having on delayed care and wait times?
Yeah, this is a conversation that's happening. Very often those plans have very high deductibles, and folks aren't able to meet that deductible threshold, and so you'll see folks that hit our system. One of the things that's interesting, and I appreciate the conversation with you and Senator Perry as well about IDD. Thinking about what the state has done in, I wanted to mention this model, outpatient biopsychosocial interventions in IDD. That is a program the legislature has invested in. It's at 13 local authorities in Texas today. It could be something that would be expanded statewide. But back to your question, I'll say I think often we see folks that have a commercial plan like that. In our system, the commercial insurance is a very small fraction of the work that we do. We're far more into the Medicaid side, and then of course into the low-income uninsured side. But those commercial plans tend to have really high deductibles, which means folks access care by hitting the general revenue funded system.
Okay, interesting. Thank you. Can you talk about the challenges that centers face with substance use disorder co-occurring patients in particular? Is there like split funding or nobody to send treatment referrals to? Just what's going on?
Well, I thank you so much for the question. I appreciate that. I think our state has made progress. We've expanded the Certified Community Behavioral Health Clinic model of care. That was a model that started at the federal level in 2014. The legislature directed statewide expansion in 2015. Now all of our members are certified as CCBHCs. I make that point because the model requires both a focus on mental health services and substance use services. But there are substantial gaps in capacity for substance use services. In fact, that was, and Madam Chair, I'll follow up with written testimony in our recommendations slide. I have some points about this. We really need to address substance use capacity in our state. There's some substantial limitations there. So I appreciate the question very much.
Okay, thank you. One more for you as well, and this is kind of just a point of curiosity. My staff let me know about a coordinated specialty care for first episode psychosis program, which is new to me. So can you just briefly describe that? Is there efforts to be done to bolster that? Just what's going on with it?
Yeah, this is one of those specialized programs that I mentioned earlier where the legislature has appropriated resources. Those resources have come into our system. And I know my colleagues at the Health and Human Services Commission can talk about this specifically, but what I'll say about first episode psychosis, a lot of times we're talking about the crisis interaction, right? We're talking about the interaction with jail. What I love about first episode psychosis is it's more upstream than that. So when a young person has their first psychiatric break, if you can get services to that person and to their family in that moment, you can stave off lots of costs that come downstream later when treatment's not available for people in those circumstances. Coordinated specialty care is part of that strategy, and it's one that I would describe as an effective prevention and early intervention strategy. I believe, you guys can correct me, I believe we are not quite statewide yet on it.
That's correct.
But it's an area where I think some attention would be really good.
Okay, thank you. And can y'all speak to the success of that or how it's going? Or
Yeah, we can probably send some data points. I know in past sessions, there's been folks who have come and testified about the success and some of the outcomes that we've gotten. So we can supply some of the data to this committee. To Lee's point, we're not quite statewide, but we, that particular project, 10% of our block grant has to be set aside to fund that. And then there has been, as he mentioned, some investment by the legislature, but we're not there yet in terms of statewide.
okay, thank you. And for HHSC, the previous panel mentioned the issue of psychiatric facilities that flip folks from involuntary to voluntary. Is that only happening at the private facilities that the state contracts with?
Well, I don't know that let me talk about what's in statute. So I think what they're talking about is somebody is on a civil commitment and then the hospital decides to discharge them, which also seems strange to me because it's a court order. But the statute right now says that people are discharged from civil commitments in one of two ways. The commitment times out so that the order expires, or at the physician, the clinician's discretion, based on their determination that they no longer meet civil commitment criteria, they can discharge them. So I think that I'm sure that we have discharged people before, law enforcement, or I don't want to insinuate that we haven't, but I think that we have less of an incentive than private providers who may have insurance limitations or other people coming in that they're going to get a higher bed day rate for. So sometimes we have people that are no longer meet civil commitment criteria, but our professional recommendation, and obviously if the order expires, we have to release them, but because of our clinicians, we will keep them a little bit longer because we don't think they're quite ready to be outpatient. So I think it's probably less common in the state hospitals. I do hear about that a lot, particularly from DFPS, with kids being discharged when they're, stable, but that doesn't necessarily mean they're able to be in the community yet.
Okay, that is helpful to me. Thank you. And just to follow up on the discussion we had about folks with IDD at shelters and jails and on the streets, is there any data or information on if waitlist spot opens up, does it have an impact on populations in jails, or does anybody track any of that together?
I'm trying to understand. So if the forensic waitlist, if a spot opens up,
I guess if there was an increase in funding for community-based care, could we say that would have a downstream effect, or is there any data on that?
I think that because the vast majority of forensic commitments, which is the majority of what the inpatient beds are for, specifically for inpatient competency restoration. Yeah. I don't know that would have an impact. I will say that I know we're talking about diversion, but I do think upstream investments, including in kids with high acuity issues, is beneficial. That's not really like our world and our part of the equation, but we see kids who were TJJD kids coming in and being forensically committed, for example. So, but I don't know that would impact the inpatient need. I will say, I think, I don't know a date certain when we will eliminate our forensic waitlist, but because of the investment the legislature has made, that's going to happen a lot faster. 500 new forensic beds coming online in the next 2 years is huge for us and for all of the communities we work with.
Thank you.
Thank you, Madam Chair. Real quick. So back to some of the rehab conversations, private sector. Last time we had a hearing, it's been a while back, but it's like a 90% recidivism for substance abuse for private insurance providers and private. So you go to a rehab and it's privately funded with private insurance. Mysteriously, when 30 days, I think, is the insurance, you're kind of healed and out on 31 days, and in about 60 days you're back. And through the industry's own testimony, 90% recidivism. So I go there to say we had some positive outcomes, but it looks like it's tied to housing, and that's homeless. That may not have been a substance abuse issue. That may have just been someone had a bad run and is homeless. So in that context, what does housing mean? I'm struggling with that. I shouldn't be struggling with that, but is this a permanent residence? Is it an independent living? Is it a residential in the middle of a residence that two people get to live in and kind of get time to get life figured out? Because where I'm going with that is I need to understand when you say housing, and to your credit, and everybody always says it, and obviously homelessness, it's pretty clear that housing's a conversation, but what does that mean when you say housing? Because here's what I know. People that have 2 kids, 2 cars, a mortgage, food, medical, have anxiety and depression about making ends meet every month.
Mm-hmm.
And we're not talking about providing a step-down service to meet that anxiety and depression. So I'm not making light of it. I'm just trying to figure out where is our responsibility and where does it begin and end on this conversation, because we tend to look to solving people's problems at creating other people's problems. So what does a housing mean when you say housing?
I mean, I think from our perspective, and having worked in the legislature when the AMH program was put into place, it was really cost avoidance because there was so much money being spent on these people who were in hospitals for years, in and out of hospitals. So I think from our perspective, we see it as kind of a step down, some supportive housing. They might need it for AMH. We might have people there for 2 or 3 years, but while they're there, it's not just about treatment. It's about helping them become self-sufficient and know how to be in the world and get employment. It is not an expectation, from my perspective, that the government will build a bunch of apartment blocks for everybody who has severe mental illness. So I would say ideally it is a step down.
So there's no time limit though.
So for the step down program, I think the target is 1 year, but I'm going to let Trina speak to that.
Yeah, the goal is a year to get folks transition, and they're getting all these supported services to try to get them to be independent and living in the community, which could include employment services and things of that.
So let me ask, do you contract with private vendors? I know Bruckner's has a good program that is kind of sort of a step down for getting people that were addicted, typically have family unit and are going back to college and going back to workforce and stuff. So there's just satellite private sectors. Are y'all 100% state-based, or is there a...
Yeah, currently for our step-down homes, we contract with local mental health authorities to do that particular project. The home and community-based services for adult mental health is private providers. That particular initiative has 2 components. We have recovery management entity and a provider agency. And so mostly that is private providers that are doing that. There may be 1 or 2 local mental health authorities
So
that are doing that.
let me ask a direct. Is LMH a owner of residences for this step down, and is the state the title holder real estate, or we have private sector that you're contracting with that owns that property? Which one is it, or is it both? Who owns the house?
You know, I don't know that I have the answer to that question, but I can find out.
I'm looking for 2 things. One, we obviously need more beds.
Mm-hmm.
And if we're not utilizing private sector models that have a history of this very same thing, it wasn't a new idea. It's a new idea to the state, but it wasn't a new idea. There has been lots of faith-based ministries that have had this connection. So the question is, 1, are we getting into the real estate business and providing housing? And if we are, okay, I just need to know. 2, is LMHA investing in residences on their own accord and becoming real estate owners? And 3, are we going to tap in, or can we tap into a vendor market that's already in existence that have a track record of doing this?
Yeah. What I will say is to be clear, the funds that we're giving is for the operations, like the provision of the service.
Okay. Good.
Not for the house itself.
Okay.
So I'll want to
Okay.
let me clarify.
And I'm just looking for, where does this end?
Perhaps I can.
And secondly, and lastly, Madam Chair, two things really. What you said in 28, we're bringing on forensic and civil. If I understood you right, doing the math, we're already under capacity on forensic. 435 beds or something, I think.
So
we're currently-
17.
we have about 1,500 people on the forensic wait list. We're bringing on about 496 forensic beds over the next 2 years.
Okay.
But there's turnover.
It's turnover. So that 490 might serve 1,500 people
I think it will.
in the system. Good.
I think
Okay.
short-term step down, diversion, and crisis is.
We talked about this earlier, and I said it that, the superintendent said if I could just place somebody in the home with no parent, we could solve all these problems. Who is responsible? Is it the LMHA or is it state employee that's responsible for follow up and step down? So we get someone stabilized, we turn them loose, and we pretty much know this guy's a frequent flyer. So in 90 days, he's back in, same drugs, same problems, off meds. Who's the go-to call him and say, hey, you got your meds today? Are you doing okay? Who's doing that? LMHA or hospital? I mean, that's
So let Lee jump in, but I would say the LMHA. One thing I will say is that a lot of these folks, when they do recidivate, it's because they are not compliant with their medication. LMHAs cannot force people to take medication. We require them to do a lot of outreach, a lot of counseling, but at the end of the day, to your point, Senator, if someone doesn't want to take their meds, they don't want to be well, then they can't hold them.
So there's a point in time, and I said it today, there are people that want the help and there's the people that don't. And I don't know how, but if you're 3 strikes or 5 strikes or you do something that shows clearly you have no respect for the taxpayer dollar and the system that we've created to help, we got to move on. It's just a fact. Because there's other people in line that are not getting help that would be willing to participate. Thank you.
Chairman Perry, if I could just really quickly,
Yes.
your question on the step down program, I'll give you one example and I'll go back as well and look at how these programs are working. But one example in Harris County, the state provides operational funding through the block grant, as Trina described, but it was a building that was on a piece of land that was owned by the county. And it was a vacant building at the time. It was renovated, and that program's in there now. So that's just one example.
Now, that's great, and I kind of suspected that's what it was, but I wanted clarity. And if the state's becoming a real estate, that's okay. If that's the path we do, I just want to know, because the more the state owns something, the more likely it becomes permanent, in the sense that if someone needs 20 years to rehab, the state will not pull them from that house. And I'm sure it's competent to be there, but it's probably not the best scenario. There's probably bigger things ahead of them. We just seem to put people in mediocrity and leave them there. And then we cheat people that really need a service. So, thanks.
Senator Blanco.
Thank you, Madam Chair. I think this question is more for Ms. Dixon. We're talking about mental health and homelessness. And as a veteran, I've got to ask, and understanding that TVC handles a lot of the mental health programs, and Texas Department of Housing and Community Affairs focuses on housing, and then the VA, right? But with this increased inpatient capacity coming online, is there any specialty for vets?
No, the legislature would have had to kind of designate that, so there isn't. And as you stated, we transferred our programs over. Do we have any ongoing programs? Okay.
So
If a veteran presents for services, they can access those services.
right, the state hospitals and
Mhm.
okay, then they'd probably be referred later on to the VA but if they present, they'll be admitted.
I mean, if they are incompetent to stand trial, I think they would be added to the wait list just like anybody else. So I don't want to give a false impression that they're bumped up to the end of the beginning of the line. Like for not guilty by reason of insanity, they are bumped up to the front of the line to get them into maximum security. I don't think we have a legislative designation or otherwise designation to prioritize veterans for inpatient capacity.
Okay, thank you.
Sir Miles.
When I say homelessness can cause mental health, what do you say?
I think it's a very much a chicken and egg situation. I mean, I think just like with abuse, people can use substances because they're trying to self-treat their mental illness. People can become homeless and then start to lose grip on reality, not have access to preventative care, develop anxiety, depression, schizophrenia. So I think it's hard to determine what comes first, and sometimes it's, as Senator Cook said, way back in their childhood that kind of led them to that path.
When I say wraparound versus permanent housing, what do you say?
So I would say wraparound or see wraparound as kind of more of the things that wrap around the temporary housing, like employment support, job skills training. I mean, some folks that, and I'll say the AMH program Trina talked about, a lot of those people are being diverted from state hospital. Some of those people have been on the street for years. They don't know how to interact with people who are business owners, teaching them interview skills. So I would see wraparound as like life skills almost for those folks, and that the housing should be temporary with the goal of stabilizing and reintroducing them to be productive members of society. And I think gaining employment gives you purpose and pride. I have a brother with schizophrenia, so it's very personal. He works full time. I think that employment is very meaningful and gives you a reason to get up in the morning. So
Last question, Madam Chair.
Mm-hmm.
When would you say that step down programs would cost the state of Texas, would save money for the state of Texas in the long run?
you would probably avoid
Kind of like what we say if we invest in education
Yeah.
on the front end of a child's education, we save money by the state of Texas incarcerating rather than incarcerating them.
I think for
Would you agree with me
certain,
on that?
yes, I think for certain populations that are, I mean, the state hospitals are the most expensive setting. And to avoid readmissions to those hospitals or to our jails, yes, I think that would definitely be a cost avoidance.
So just for clarity, step down programs, wraparound programs, long run saves the state of Texas money.
In the long run, yes.
In the long run, yes. Madam Chair, would you agree with me that we've been doing this the wrong way for a long time?
I think we're working on it.
Thank you.
I'm going to follow up with a couple questions. Do we know how many of these folks who get discharged are repeat offenders or have recidivism in civil or the criminal system? Do we keep those stats?
So I've been asking a lot of those questions. I can tell you that from FY, and this is just for forensic. So because I know there's a lot of discussion about people who get restored over and over the years. About 12% of the people on our wait list have been on the wait list before for another charge. I also asked how many of the people in our state hospitals are readmit within 30 days. That's a lower number. It's 2% of the population, about, I think, 46 people. But we're starting to collect data on recidivism and frequent flyers and that sort of thing. I don't know on civil, but we can try to get that.
Do y'all have the statutory ability to track those statistics?
I believe so, yes.
Do the LMHAs have statutory power to track those statistics, those stats?
Madam Chair, I believe that information is collected locally, and as I talk to our members, very often they know who those folks are that meet that criteria, high utilizers.
Please take this. Now that you have that, I want this to be very clear. I want those statistics.
Okay.
I want to know how many of those folks who get discharged are repeat either offenders or have recidivism in the civil and or the criminal beds. Okay.
Okay.
It's super important for us to attack this wait list and to also attack what the problem is. Okay.
Am
I real clear on that?
Yes, ma'am. We cannot compel private private psych hospitals to give us information and data.
You have contract beds, right?
Yes, ma'am.
I would not consider those private because they're contracted and you get your money from either the local government or us. Am I right on that?
Primarily that's the private
Okay,
psychiatric
so
beds.
all those private hospitals in the background, you can give them to me. We'd like to see them, but I want those tracked, what the state of Texas is paying for, okay? Because
Yes,
we need
ma'am.
to understand that churn. I mean, very specifically, we need to understand that churn to what Senator Miles is talking about, because then, again, we can't continue to build more and more beds. We can. I mean, they're expensive beds. You're not the most expensive. There is one more that's more expensive than you, the Dallas State Hospital. When does that open?
So we just had our ribbon cutting. I think it's September. No, wait, August 1st, I believe. I'll get the exact date.
Okay.
August
Will
1st.
how many beds are up there?
292, 200 for adults and 92 for pediatrics.
Okay, I want y'all to understand that. And we required them. How many? Now we own that hospital. That's an example where we are in the real estate business. But like the University of Texas Health Science Center, called UT Health in Houston, runs the Dunn. UT Southwestern is going to run this hospital. I think there's 75 forensic beds there.
I think you're right. I'm
bet-
going to have to verify that, but I think you're correct.
I think I'm right
Yeah.
on that. Every other bed that we're building right now, 50%, whether it's in Victoria or wherever it is, 50% of them are going to be forensic beds. Some of those are going to be maximum security to our district attorneys out there. We're working on this, okay? And I know El Paso, we're getting some maximum security. We're getting some maximum security in Lubbock. We're getting some in the Valley. We
Amarillo.
got some in San Antonio. That's what I'm saying, up in the Panhandle. We're trying to space those out. Those maximum security beds are the longest.
Yeah.
I mean, people stayed there the longest. Okay, right?
And they're more expensive because of the staffing needs.
And they're more expensive, about $2 million a bed to build. It's expensive. Got a good deal at Sash. Okay, so one more question. I wanted to say is that Senator Perry, I look at the step down beds that we talked about. Wouldn't it be like the 3 and 4 bed waiver homes that we have for IDD?
Yeah.
So there are vendors out there that we contract with. Am I right on that, Lee?
There are in the IDD system. Those are private IDD providers. Yes, ma'am.
But also on these mental health kind of step down beds, right?
Are you talking about specifically HCBS AMH? Yes, they're homes. They're I think have a max of maybe 8 people in a setting.
Okay, and then very quickly, I want to go to the percentage of walk-ins and admissions. Jordan, I don't love that chart on 11, and I just want a little more specific of if you're at Terrell State Hospital and 86%, what is that 86? Are 86% of the people in Terrell Hospital, State Hospital, walk-ups?
86% of the admissions in FY25 were walk-ups. I would say roughly 75% of those walk-ups are emergency detentions. So we can get the breakdown for each of these state
So that
hospitals.
means, as I tried to explain, what's going to happen in Dallas is, the cop cars, the wheels aren't even going to stop rolling. They're going to shove them out the door, right?
I mean, that's, I think, what Terrell community is kind of not hoping to dump all of their people, but that there'll be another option for where to take people
No,
on
so
emergency
didn't we transition
detentions.
Terrell mostly to forensic? And then we have the DFPS beds, the residential treatment center.
We have the TYC beds coming online next month. And Terrell will have 275 beds. I have to get the forensic
It's
breakdown.
very largely forensic. And the civil beds are moving to Dallas. I think I'm right on my memory here.
So,
and in the Dallas State Hospital will be a safety net hospital, like every other hospital.
mhm.
Same with what we're doing down in Harlingen, same Victoria, Beaumont. They're all safety net.
Yes.
Okay. And then let me see if I have a footnote here anywhere else. Lee, just because of timing, you're getting off easy today. Don't go home and think.
I'd be glad to come by and visit you anytime.
Yeah. Here's the one thing that, and I mean, we're going to have another panel that comes up here and doesn't say nice things about their LMHA or they want to be able to get out. I think that there's a lack of standard in the 39 LMHAs. And we all say, oh, they're all local. Oh, you know, those boards are so big and unwieldy. And I know there's going to be 5 of the 39 that come and say, we're operating perfectly. But a little bit what Senator Miles said on the one sheet where you're like LOC3 and LOC4 and LO whatever, there's not a standardization out there. I'm not just talking about that, about the intensity, but I think there's a lack of standardization. I saw the fines that y'all have done. I'm sorry, but $130,000, that's nothing, okay? Like, that's nothing. We've got to get more aggressive and either reinvent ourselves and be responsive to the district attorneys and the sheriffs and everybody else, because the local mental health authority, Madam District Attorney, what you were complaining about, I know you say yours is great, but so much of that I was sitting up here going, where's the LMHA? Where's the LMHA? It's in statute. That's why they were devised. So much of what we're talking about here is we kind of got the tools out there. Not everybody's playing their role. And I'm tired of seeing nice office buildings being built. I want to see more services out there. So we're going through sunset. Y'all are not necessarily going through sunset, but trust me, they are, which means y'all are. We're going to fix this whole thing, and we're going to get to a point where I think, you know, and I looked at your one chart here. Here, I'll even open this up. Okay, I saw, you know, in 1960, I shouldn't say this, but in 1964, I think when I was born, we had 14,921, I think that would be mental health hospital beds. And you know, do this intersection where we got 31 million and we got 3,216. But if you look at all the legislation that happened in 1963 on the feds, and I mean, we don't have insane asylums anymore. We don't put people in there to stay for the rest of their life. So I think our challenge is, that's a very misleading chart there, because I spent a lot of time researching your chart last night. Congratulations, because that's an erroneous chart. I mean, as far as there just was federal legislation and different things and different funding things that happened from 1963 to 1981 that changed that whole picture. We didn't say we're going to send you to the insane asylum. The movie One Flew Over the Cuckoo's Nest was actually a little bit late. I mean, all that stuff we were already doing, it was kind of a look back. So to Senator Miles's point, I think we have to discover a couple of things, and that is the churn, what programs are being effective, and then finally, this is my other thing, I'd like to know how much, when we talk about our mental health issues, and this would be some of the diagnosis, I want to know how much is driven by substance abuse. I think that's really an important point. And when I say this, substance abuse today is more intense than it was before 2019 because of the availability of it.
Yes,
now.
yeah, sure.
And I want to say something to my friend and colleague Sarah Blanco. You're right. I mean, man, we've been trying to keep those drugs from going across the border. We'll blow up your ship out if you're out in the Gulf of America or Mexico, whatever you want to call it. And yet, then, right, we got 9,000 stores that are selling something maybe even more dangerous. So, I mean, I think that's part of the discovery today. So the mental health issue is going to do nothing but increase. I did not go through the ad nauseum of my 1,000 pages and 2 reams of paper here, but the psychosis of, or the diagnosis of bipolar and schizophrenia that is on the rise with our young people. I mean, this is we're at the tip of the spear here. I mean, this is just barely or the tip of the iceberg. I think the iceberg underneath is going to get bigger and worse. So, Senator Hughes, and then Senator Sparks, and then we have 2 more panels to go.
Thank you, Madam Chair. And the chair asked about one thing I was curious about. Ms. Dixon, just a little more information so I'll understand. And thank you each for your testimony. Thanks for what you're doing on walk-in or unscheduled admissions. And so I didn't know about EMTALA applying to mental health hospitals. That's good to know. And so then, if someone is concerned about a loved one or about a friend, they could just go to Terrell, Rusk, fill in the blank, and Dallas, the new one in Dallas, and get evaluated. I'm asking. I'm not telling. I'm asking. Is that right?
Yes, we would have to do a evaluation, and if they need stabilization, we would have to stabilize them. And if we did not have space, we would have to try to transfer them somewhere else.
Under EMTALA. Okay, and so
Yes.
that's not. Now, it sounds like that's not the preferred way based on how the whole system works. Is someone getting there? Is that right? From your standpoint.
I would say the way with our capacity issues right now, yes, that is correct. And also that those folks who are not on a forensic or civil commitment ideally could be served in the community in a lower cost option.
Thank you. Thank you, Madam Chair.
Thank you, Madam Chair. Yeah, I had one question for Mr. Johnson. Your slide number 9.
Sir.
Those top 3, which is 97% of these diagnoses, have you seen an increase in those? That's, major depression, bipolar, and schizophrenia. Have you seen an increase in those in the last 5 to 10 years?
So, I'd be glad to circle back with our members and get a sense of that. This information that you have here is a snapshot from the state's data system, so it kind of shows the current picture. If you wanted trends over time, I'd be glad to look into that for you, Senator.
I would like to see that because I think we will see the answer to that question is yes. And again, our goal with this whole panel is to try and figure out how do we get the furthest up the chain to start addressing things.
Yes, sir.
And that might give us some insight into how we do that. Thank you.
Thank you.
Senator Miles, you got a follow-up?
Close out, Madam Chair, if I could. It's no question that mental health is growing. It's going to continue to grow, Madam Chair. And there's no doubt that it's affecting everybody, both rural and urban. I think when we address this issue, we need to keep in mind that it's addressing everybody. I bet I can ask this audience and this panel, if you've been affected by mental health in your family, and everybody's hand would go up. So what I'm trying to say here is, when we address this coming session, let's keep in mind that it's a growing matter. It's going to affect everybody, rural and state, black and white, Democrat or non-Democrat, and this is not a partisan issue. It's a human issue that we should be addressing. These are the kind of things that makes Texas strong when we address them, stronger. These are the kind of items that when we address them, it makes Texas stronger. So once again, Madam Chair, I look forward to working with you and my colleagues. I think I speak for my Democratic colleagues that we will come in with an open mind and wanting to participate and wanting to help to make Texas a stronger place and address this mental health issue, and show the rest of the country like we always do. Some things we feel are good, and some things we feel are bad, but it all starts right here in Texas.
Thank you.
Thank you.
Thank you, panel. Chair calls Sean Edwards, Susan Summers, Jean Gaines, Scott Centurino, and Rhonda Mundhink.
I'm not interpreting it. I guess we're moving down.
Should I stand during it?
Yeah, no, it's just. Oh, thank you.
Okay, so to these panelists, it's always an unenviable position to be the last in a long day. T-Chat, I know you're out there. You're going to be really quick. But don't repeat anything you've heard if you could. Shorten your presentations because we've gone through a lot. So Sean Edwards, we'll start with you and we'll work our way through.
Good afternoon, Madam Chair and members of the committee. Thank you for this opportunity to speak with you today. My name is Sean Edwards. I serve as the Director of Burleson Health Resource Center, Captain with Lavaca County Sheriff's Office, President of the Texas CIT Association, and a collaborative council member with the Texas Judicial Commission on Mental Health. I've spent 29 years in law enforcement, and for the last 20 years, my work has focused almost entirely on mental health and crisis intervention. I've seen where our system works and where our system fails. Everyone is one situation away from a crisis. We see individuals with untreated mental illness, people experiencing homelessness, those with co-occurring substance use disorders, youth in distress, older adults with dementia, veterans with trauma, families overwhelmed by life circumstances, and crisis affects every community in Texas. Our biggest challenge is where the people in crisis end up. Today, emergency rooms and jails have become the default, not because they are appropriate, but because they are fast, familiar, and always open. For officers, an ER is the quickest place to take an individual, but ERs are not psychiatric facilities. They often have no mental health beds, no psychiatric staff, long wait times, and chaotic environments that worsen symptoms. And for the individual, the financial impact is severe. An uninsured individual receives a minimum $3,000 bill for a medical clearance process that has no legal authority in Texas. Nothing in the Health and Safety Code requires medical clearance before psychiatric admission. Jails become the default for a different reason. They are easy and familiar. Many officers do not attempt to locate psychiatric beds or coordinate with the local mental health authority, even though jail diversion is required under Code of Criminal Procedure 1623. Most officers don't know the law exists because it is not consistently taught or reinforced. But jail is never the right place for someone in crisis. It criminalizes the illness, it increases trauma, and creates long-term system involvement. And the cost difference is staggering. $30,000 a year to house someone in a jail versus $10,000 a year for community-based mental health services. We are paying 3 times more for a worse outcome. Short-term psychiatric beds are limited, and people are discharged before they are stable. Discharge planning is often incomplete, creates a revolving door of crisis, ER visits, and law enforcement involvement. Highly utilization individuals, those with severe mental illness, co-occurring disorders, or no housing, are often repeat offenders. Are often not repeat offenders, they are often repeat survivors of system gaps. Texas can fix this. First, we must improve real-time communication between law enforcement and local mental health authorities, hospitals, and providers. We share crisis plans, bed availability, and consistent points of contact. Second, we must build a partnership, not a dictatorship. Too often, the relationships become territorial, and we share responsibilities and not unjust focus, an ununified focus of the individual in crisis. We need to get away from the us versus them. Third, we must utilize modern civil mental health processes. We need to reduce unnecessary visits and reduce jail involvement, reduce officer transport time, and increase critical response and critically The local mental health authorities must be empowered and required to fund stabilization longer than 3 days. 3 days is not treatment, it is a pause. Finally, Texas must invest in a proactive approach with trained mental health officers to help recognize who will recognize early signs of crisis, de-escalation safely, divert individuals from substance abuse and becoming dangerous situations, and build trust with families and communities. This is not just a public safety, it is a public health. Texas has the opportunity to build a crisis response system that is clinically driven, trauma-informed, cost-effective, and centered around dignity and respect with safety in mind. Thank you for your commitment in improving the outcome of Texas in crisis. I stand ready to support this work in any way I can.
Thank you. Appreciate it, sure. If you would state your name for the record, who you're with, and you may begin, and move that microphone.
All right. Thank you, Madam Chair and members of the committee. My name is Susan Summers, and I'm the Chief Executive Officer of Perimeter Behavioral Hospital of Dallas. And I'm here to testify on behalf of Perimeter and the Texas Association of Behavioral Health Systems. Thank you for having me. I'm excited to share and advocate for the mental health services our facility provides. I also have over 30 years' experience in the Texas market, both in Houston, the West Texas region, and now in the Dallas area. My facility is one of the 64 private freestanding behavioral health hospitals in Texas. 52% of all the psychiatric beds statewide are managed by the private sector. This is explained on pages 2 and 3 of our presentation. What's unique about our facility provides a variety of behavioral health services for the mental health community, from inpatient to outpatient, competency restoration, jail diversion, justice-involved programs, and contracts with both the LMHAs and the state. Our work impacts the mental health individual. Listed on pages 4 through 5 in our PowerPoint demonstrates the contribution that freestanding hospitals contribute to mental health. Perimeter Behavioral Health Hospital of Dallas has a unique connection with the 254 counties, their court systems, jails, and LMHAs. This connectivity provides a window on what is working and what the barriers we see preventing seeking mental health, obtaining competency restoration, and the cost and utilization of these services. Committee, moving on to page 6, we expand upon, again, there was a lot of discussion earlier, so I don't want to be rehash or be redundant, about the types of individuals that come to us, how they utilize our programs, but I want to focus on what is working. At our facility and our sister facility in Arlington, we service over 100 competency restoration patients. We have civilly committed patients in our facilities. We have individuals that are involuntary committed. We treat children, adults, adolescents, and geriatrics. This year alone, we have connectivity with a very large LMHA here in Austin, and we are now experiencing an over 85% restoration rate in competency. This has been very helpful because we've been utilizing the state's curriculum with enhancements. We have a proven and educated treatment team that deals with forensics, and we incorporate the assessments and the psychological documentation for evaluation on whether an individual has been restored. Again, we have great connectivity with the state. We talk to them daily. We meet with them weekly. We have treatment teams with the LMHAs to discuss progression for treatment with all the patients that we serve. This is important because the main focus is also improving the timeliness of what we're doing. We struggle with barriers to care as it relates to processes in court systems, how and when we can get the ability to manage medications or getting court orders. Sometimes this can expand for court order medications for 3 to 4 weeks while we treat a patient that's in acute crisis. This can also impact where that happens in the state hospitals. Competency restoration is effective. We utilize all of these treatment modalities to help the individuals working here. Every single ICR competency packet is reviewed by me. I look at the criteria for admission into our programs to ensure that we are treating the individual and utilizing resources effectively and making sure that we communicate back with our entities, is this someone that we can help? We do face barriers in the court system because they are burdened with the same kind of processes. We face increased court costs, delays in getting court hearings heard, and waiting on orders for court-ordered medications or involuntary commitments. Well, I've gone a little bit off of the PowerPoint here just because there was a lot of discussion earlier. We strongly advocate for what is happening in the community with competency restoration and seeing the effectiveness of what's happening. We've noted barriers to that, as again, we talked about the ability to gain medication management, having social determinants such as housing, the ability to keep a job. Other barriers that we're noting as well is that the reinstatement of benefits. If an individual is incarcerated, their benefits are paused. So you have to reactivate those benefits in order for them to receive continued treatment and follow-up care under services, including VA benefits, including Medicare. This can be challenging because if you don't have individuals at the LMHAs or in facilities that are familiar with re-enrolling or reenacting benefits, those can take more time delaying the follow-up care that's needed for these individuals, which in turn, as we say downstream, can reduce recidivism and costs associated with that. One other area that we noted being in a restoration program as well is that the delay in the courts when a person is determined that they are restored, we request a bench warrant, they go back to jail, they plead and show what they've learned to the court system. So depending on the timeliness of that court activity, that individual can decompensate while they're sitting in jail waiting to share what they've learned or not learned. And that, again, continues this wraparound, continuing the circle of competency restoration. I did speak with my partners as the state as well to say, is there a way since COVID that we can have connectivity with the courts while they're in the hospital to share where they are with progression and treatment, and are they ready to be heard for their competency restoration? So there's more that we're hoping to work and partner with the state, with the LMHAs about how we can improve the timeliness and connectivity to help them help us. So one of the areas that you focused on as well, Madam, was the standardization. Because we have windows into 254 counties, I have patients from all over the state. And everybody does everything different, as you mentioned. Everyone knows some stuff and they don't. And it becomes a challenge because they rely on us to be that central portal to educate them on how to file a court-ordered med. What steps do we need to do? How can I connect you with the LMHA? How can I share with you about discharge planning? You know, what is the best pathway for this individual? They rely heavily on us as that point of contact. And it's done, and there's no standardization anywhere that we can find. The biggest thing is just trying to find out, does a person have a medical issue? You know, is that something we can treat? And even that form is different from county to county all over the state. So we look at all of that. Again, when Senator Miles had mentioned about revamping or relooking strategically at what needs to happen to help these individuals and improve our processes and timely and shorten these wait lists, it's going to take that in order to standardize to get that done. So again, some of my recommendations, again, were very similar to what everyone has spoke about earlier. Medication management is huge. We do partner with the LMHAs to say, hey, are you willing to give an LAI because this person, you know, may benefit from that long term. We want to make sure that we've stabilized them. They're engaging in treatment. They're having successful treatment. They're ready to discharge. Can you continue on where we left off and be able to support them outside of here? One of the other factors that's been very helpful is the fact that we are engaging the LMHAs, the state, to come into our facility weekly. We want you to meet with our patients because they need to be able to trust and have a relationship with you to help them navigate this mental health system. They're able to meet with them, see what their progression and treatment is, advocate for the programs that the LMHAs do share and have available to them, and they have buy-in. Buy-in is very important for them when they leave here, that they're not going to a stranger necessarily. They have somebody in Mrs. So-and-so's face I recognize in order to say, I trust them, I'm going to continue on with the care and I'm going to follow up. And that person really can advocate for those services. We currently do that, especially with the LMHA that's here in Austin. They meet with me weekly. We are also on the pilot program with them for their discharge planning, the path, all of that. It has been a very successful relationship with them. Other LMHAs, again, they're different, and each one has their own uniqueness, and we adjust in order to make sure we take care of the patient. So,
Thank you.
those are my big recommendations.
Good. We've taken some notes up here. Appreciate it. Mr. How do you say your last name?
Centurino, ma'am.
Centurino.
Yes, ma'am.
It's got to be Italian.
It's the Italian part of Ireland. Just kidding.
Cute. Well, we've got FIFA going on.
That's
so
right. That's right.
it could be anything. Okay, go ahead.
Madam Chair, thank you for having me. Scott Centurino, I'm a visiting fellow at Cicero Institute. I've worked on these issues both at the state and federal level. I was an assistant attorney general in Louisiana. And from January of last year until earlier this year, I was special assistant to the president for domestic policy in the White House, where I coordinated the federal administration's efforts on homelessness, mental illness, and addiction across the board. A lot of what I was going to say has been said already, so you can dispense with the PowerPoint. I'll just try to highlight a couple things that have not been said so far. I'm still working on this issue like one of the former panelists because I have a family member who is seriously mentally ill. My sister is paranoid schizophrenic. She has severe bipolarism. I will never forget the first time I ever heard her scream in the shower because the ambient noise brought out the voices. They made them louder. And when I was in high school, and I'll just never forget that. And my family's obviously still dealing with that today. And before I ever got into politics or policy, I saw how broken this system is everywhere, not just in Texas, but a lot of people, to the points that have been made here, are aware of how broken this is. So first thing I want to do is commend you all. You all have invested in beds. You have SB 1164 last year, the expansion of involuntary civil commitment. I commend you for that. You all, I mean, heck, this panel here today, you all are doing work that no other state is doing, at least as seriously. So I really give you all a lot of credit. You've got major cities. Houston's the one I'm most familiar with, but you've got major cities that are trying to do the right thing in this space too, trying to take a new approach. That being said, the last couple hours have obviously emphasized that there are still problems that remain. But I think you've done the hardest part, which is you've recognized that a lot of this is a policy problem, and they have policy. These policy problems have policy solutions. To a certain extent, these problems will always be with us to some degree, but there are ways to handle this better, and I think you all are on the right track, and I would encourage you to keep going. You've come to grips with what family members of those with serious mental illness have to come to grips with all the time, which is there's absolutely nothing compassionate about letting somebody sleep outside. There's absolutely nothing compassionate about letting somebody die on an air vent. That's not the way. So you're on the precipice here, and the question is what to do next to close this gap between where you are and where you want to be, to eliminate to the greatest extent possible the most acute problem here, which is individuals on the street with serious mental illness. That word, that gap, keeps coming up, right? And that's just the second thing I want to focus on and try to fill in some gaps here that have not been brought up so far. So obviously some of the most frustrating cases in this space, the individuals who cycle in and out of the criminal justice system, have serious mental illness, they commit several crimes, but low level, and then ultimately they commit some horrible murder or otherwise. That's not the only problem in this space, but that's a major problem in this space. The main thing I'd want you all to leave with today is that and other gaps in this system, you all keep coming back to those gaps, right? Why are people falling between those cracks? It's not just about bed capacity, although it is. It's not just about, certainly for individuals with serious mental illness, it's not just about housing affordability. That's pretty unrelated to that population. It's not just about money. These are policy choices that are baked into your state code right now. And this is not unique to Texas, but I think the exciting part about this committee doing the work that you all are doing right now is you have an opportunity here to fix it. And I'll be specific very briefly, and then I'll close out with some big thoughts. So I'll give you one example from the civil commitment space and one example from the criminal context. In civil commitment, Texas state law has enshrined in its state code a bias toward the least restrictive setting. That's come up a couple times here. It has not been mentioned that we've just seen federal guidance released upending this entire area of law. It's not Texas's fault that that's in your code. That's something that has been rammed down Texas's throat for decades now. It is not necessary under Olmstead. The federal government has, yes, that's right, Madam Chair, under Olmstead, the federal government's Department of Justice has just reiterated that that is not something that's well grounded in statutory law. It's a constitutional question. There's serious constitutional questions around that. But that, whatever the federal government does in that space, that is built into your state law right now. And I don't know if that explains what some of the hospitals are doing in this space. I'm not from Texas. I don't pretend to be. There are other former panelists and maybe current panelists that can speak to that, but that may have something to do with it. That the bias, and you've heard it from some of the other panelists before me, the bias here is to move people to the least restrictive setting imaginable, which you can understand that impulse, but that's not always the right thing. And in a lot of cases, all that does is it prioritizes the best possible case scenario for the individual with serious mental illness. It does not imagine the worst case scenario for public safety, which is somebody who commits small crime after small crime in particular, even if it's not one that implicates serious bodily injury. That person, if they have a serious mental illness and are committing misdemeanors and even low-level felonies, they are dangerous. They are dangerous almost by definition. Now, you have to complete a more wholesome assessment there, but that should be baked into Texas law, that somebody who's committing multiple crimes and has a serious mental illness is a dangerous individual, and the least restrictive setting is not probably the best place for them, or certainly the public. I know, just personally for my sister, I would rather have my sister institutionalized than incarcerated, but I certainly would rather have her incarcerated than homeless. And I think most people who have family members in this situation probably feel the same way. So that's the civil commitment context. Again, I have a long list. I'm going to skip most of them unless you want to come back to them in questions. In the criminal context, you have statute after statute after statute where bail is just as viable an option as going into commitment if somebody is found either incompetent to stand trial, et cetera. There's a bunch of parts of the state code here that do that. And I won't list all of them, but I'm happy to if you'd like. And again, those all have in there, like, it's just as viable to let somebody out on bail as to commit somebody. It should just be a matter of almost automatic that if somebody is incompetent to stand trial because of a serious mental illness, the default should be shifting into a civil commitment scenario. Maybe that's not appropriate, but that should be the default at that point. And unless there's some reason not to go that route, that should be part of the code. All right, I'm gonna skip over a bunch of other examples for the sake of time. I think just the big picture takeaway here, there are other federal things that are probably worth mentioning. You all are probably tracking this as part of this topic, but it hasn't been mentioned yet, so I'll point it out. The federal U.S. Department of Housing and Urban Development has been working and has released a notice of funding opportunity to basically radically reorient the program at the federal level that funds homelessness programs in Texas and across the country. They are trying to turn an aircraft carrier away from things like permanent supportive housing and harm reduction toward things like transitional housing. I think that if this committee is not exploring every possible flexibility that is giving, that's about $200 million a year that is currently going to NGOs in Texas that, I'll put it mildly, I think you all probably would not all agree with everything they're doing. I think that you all can look at what other states are doing. Some states are considering making themselves, the state, a statewide COC. That's the technical term, Continuum of Care Program. It's confusing because it's separate from Continuum of Care in the mental health context. But this is a massive tranche of HUD funding that goes to homelessness programs. Other states are considering making themselves the continuum of care because they trust themselves, because they have to answer to voters. They have to consider what the success looks like in the homelessness space. NGOs have never been asked until recently, until this new shift in policy, hey, have you actually accomplished a reduction in homelessness? No, that's never been done before. And so if you're not plugged into that, and I'm happy to, you should be, and I'm happy to answer additional questions on that. All in all, there's so many pathways we could go down here. I just would encourage you to tighten up the code and look into every possible thing you can do to widen the aperture of the individuals we're talking about. Somebody who is committing multiple offenses and has serious mental illness is dangerous and should be considered for every possible confinement for their own sake and for the public's sake, and every possible warm handoff that can be given, so that if somebody is leaving the criminal justice system, it should be automatic to civil commitment. If somebody is leaving this, an inpatient service, it should be automatic to go to outpatient service unless there's some reason not to. The default should be a higher level of care. If somebody is escaping prosecution who has committed a crime but is escaping prosecution because of an illness, the priority should be to put that person into treatment as soon as possible. And if treatment is not available, they should be incarcerated until that's available. Period. Full stop. That's the way I think it should work. That's the way people with family members who are in this position feel about it. I think that's the way the public who wants to feel safe in their towns feels about it. So I could go on and on, but I'll pause there, and thank you very much for the opportunity, Madam Chair.
Thank you. Appreciate that. Very interesting. Ms. Gaines.
Hello. Good afternoon, Chairman Colkhorst, Vice Chair Perry, members of the committee, and the committee team. My name is Jean Gaines. I am the Assistant Vice President of Behavioral Health Services for the Memorial Hermann Health System, which is in the greater Houston area. We are one of the largest not-for-profit systems in the country with 11 acute care hospital emergency rooms and 8 other emergency rooms across the greater Houston area. Our emergency rooms are designed, built, and staffed for acute medical stabilization. We treat life-threatening physical emergencies such as heart attacks, strokes, and severe traumas. Our facilities are not licensed to provide mental health services. We have no licensed inpatient mental health beds. Emergency rooms are increasingly being used to board individuals in acute psychiatric crisis after being detained by law enforcement. The frequency occurs when the individual has no underlying medical illness, the crisis is entirely psychiatric, and an emergency room is fundamentally unsuited for someone experiencing active psychosis or any sort of rapid mental deterioration. Again, emergency room boarding forces these individuals against their will into the most clinically inappropriate setting. It unnecessarily delays appropriate assessment and treatment within our acute hospitals, and it significantly causes judicial complications under the current statutes of the Texas Mental Health Code. Chapter 573 of the Texas Health and Safety Code mandates that a peace officer shall immediately transport the individual to the nearest appropriate inpatient mental health facility. If an appropriate inpatient mental health facility is not available, then the officer must immediately transport the individual to a mental health facility deemed suitable by the local mental health authority. Our acute hospitals are not inpatient mental health facilities or mental health facilities deemed suitable by the local mental health authority. Nevertheless, more and more frequently, individuals are being detained and transported directly to our emergency rooms. There are many reasons for this trend. We have talked about them all today. Of course, limited facilities, competing communities, funding, costs, and medical clearance concerns. Once an inpatient bed is secured for an individual boarded in one of our emergency rooms, transport is further delayed due to the judicial complications under the current status of the Mental Health Code. First, certain courts will not authorize transport of an individual unless the emergency room files an application to civilly commit the individual within that 48 hours of the peace officer's detainment. This is based on the assumption that an individual boarded in the emergency room is being detained. However, Memorial Hermann is not a psychiatric facility, has never consented to individuals being detained in our emergency rooms, and has no legal authority to detain an individual. Second, access to the courts is often limited to standard business hours. In smaller counties, magistrates and mental health courts have limited hours which can stall transfers for days. On the other end of the spectrum in Harris County, we hit massive volume bottlenecks because our teams are working through what is the largest civil mental health docket in the state. Memorial Hermann has 4 different counties we work in: Montgomery, Brazoria, Fort Bend, and Harris County. That leads to the third problem. The specific requirements and processes for securing a transport is different from county to county, court to court, and some court requirements far exceed what is set forth in the code. Again, these complications arise from the current status of the code. To be clear, our objective is not to bypass our statutory requirements to fully comply with federal EMTALA obligations. General acute care hospitals will always provide comprehensive medical screening exams and stabilization when necessary. Our goal is to simply align emergency detention transfers with the appropriate clinical resources. To resolve these systemic imbalances, we propose the following. First, establish clear transport protocols. We must mandate that individuals under emergency detention are not transported to general acute care hospitals lacking licensed inpatient psychiatric beds unless immediate physical medical intervention is required. If a patient is physically stable, they must be routed directly to a facility equipped for a behavioral health crisis. Second, standardize the legal process. We urge the legislature to standardize emergency detention and court-ordered treatment processes across county lines to eliminate the heavy operational burdens caused by varying local administrative preferences. This standardization must also consider the acute care hospitals do not have the capacity to detain, and therefore, the 48-hour hold limitation should not apply for necessary physical medical interventions if they are needed. And third, mandate electronic submission. We need to turn the discretionary authority granted to SB 1624 passed in 2023 into a uniform statewide mandate. This means requiring a secure electronic system for the submission and approval of all detention documentation, completely replacing antiquated couriers that we currently use and tax-heavy local systems. In closing, we want to affirm that a high-functioning regional crisis network requires a structured, system-wide approach. We are encouraged by the major strides the state, counties, and cities in our region have made to advance local psychiatric crisis capacity, particularly through expanding mental health crisis units, such as 419 Emancipation Homeless Services Hub in Harris County. The hub is a perfect example of a designated front door that safely handles law enforcement drop-offs and connects individuals with the right resources at the appropriate time. However, to achieve lasting systemic change, this model must be scaled to meet the needs of all in the state of Texas. Thank you for your time, and I look forward to collaborating with you to implement these vital solutions.
Thank you. Thank you for your recommendations there. I appreciate it. And I think it is Miss Mundhink.
Yes, the D is silent.
Yes, thank you.
Great. Thank you, Madam Chair, Vice Chair, and members of the committee for this opportunity to testify today. My name is Rhonda Mundhink, and I'm the President and CEO of Haven for Hope in San Antonio. I'm a lawyer. I've had a long career in healthcare, and I have extensive experience in public health, integrated behavioral health, and innovative value-based delivery systems. Senator Miles, to put a fine point on the question that you asked previously, behavioral health and substance use disorder conditions are disproportionately prevalent amongst individuals and families experiencing homelessness when compared to the general population, i.e. the house population. This elevated prevalence occurs through three primary intersections or interaction pathways. The first is that conditions can precede and contribute to causing homelessness. The second is that being homeless can create new health conditions. And the third is that being homeless can make existing conditions worse, as you might imagine. Consequently, this is a critical topic as we look towards the future policy and funding decisions to address the most vulnerable Texans. What is incredibly unusual about Haven's origin story is that from day one, it was the vision of accomplished businessman and philanthropist, our founder, Mr. Bill Greehey, who was prescient in terms of understanding the impact of homelessness on the city of San Antonio. After inquiry, he determined that multiple sectors were responding to homelessness, but in an ineffective, uncoordinated, and cost-prohibitive manner. Mr. Greehey raised an initial $100 million to build Haven for Hope, 60% of which came from private sources. The relevance and significance of that is that it allowed Haven to evolve an evidence-based perspective as opposed to any particular and overlapping policy domain. And by acting long before other communities mobilized around the issue, Mr. Greehey gave San Antonio not only Haven for Hope, but the gift of time, 15 years of intentional response to this problem. So in June 2010, homelessness in San Antonio received an address, 1 Haven for Hope Way, a 22-acre campus with a small town feel. The campus really functions like a Lego base plate. It is the foundation upon which co-located services and successive levels of partnership up to the level of sectors can be built, like the adhering and scaffolding of individual Lego pieces, creating an engine that is capable of generating transformative outcomes and community-level impact effects by streamlining and synergizing the services that everybody has mentioned that address the root causes of homelessness. Haven is designed so there's no wrong door. Our South and North Campus eligibility criteria meet people where they are. A standout hallmark of Haven's design is its co-located services, which are provided by Haven and what we call integrated partner agencies. Co-location is vital as it reduces residents' opportunity costs to engage in those services. More than 80 partner organizations provide hundreds of services on or through the campus. The campus is also designed with a focus on treatment, healing, and recovery, with on-campus physical, behavioral, substance use, and spiritual health services. Collectively, the outcomes of these programs are truly remarkable. For example, Haven's acute care team is a powerful emergency department diversion program. San Antonio Fire Department EMTs are integrated members of this team and triage potential health emergencies across our residents. This program also has reduced unnecessary emergency transports and associated visits to our local ERs and has reduced it by as much as 85% as compared to before Haven opened its doors. Haven is designed with the end in mind. Our job, as we view it, is to propel people through our system back into housing, and I want to stress this is often private market rate housing, back into community as efficiently as possible without risking recidivism. Our model does not create dependence, nor do we warehouse individuals. Rather, we make time spent in an episode of homelessness count. We're proud of our model's results. There are many homeless initiatives focused solely on measures of effectiveness without any consideration of ongoing cost. Against these, Haven stands out as a proven, efficient, and already at scale intervention. Our average cost per diem is $58.64. For comparison purposes, the average cost per diem of Bexar County Jail is $87.17, and for a Texas Community Hospital, it's $3,441. An independent study has twice validated Haven for Hope's value proposition for San Antonio over the long term. For every dollar invested in Haven, Haven has returned $42 in community benefits. Over Haven's first 15 years, more than 52,000 unique individuals have been served on campus. Research examining those 15 years found that 65% of those clients came to Haven only once. And when those single-stay clients left Haven, they did not return to homelessness anywhere in our community at rates above 90% at the 1, 5, and 10-year intervals. For those people, their homelessness is resolved. When compared to single-stay clients, our multi-stay clients are on average 5 years older. They are more likely to be alone and without familial or other support. They report higher rates of behavioral health, substance use, and disabling conditions, and justice involvement. And they used 1,205 different service combinations or pathways during their stay versus 585 for the single-stay clients, which makes sense and is not surprising given their significantly higher needs profile. Within these multiple stay clients, there are again two distinct groups, 2 stay clients and 3 or more stay clients. Of the 2 stay clients, the average time between episodes of homelessness was 3.1 years, whereas the average time between homelessness episodes for 3 or more stay clients was 1.45 years, representing a more turbulent, cyclical relationship with homelessness than other client groups. But even within the multiple stay group, almost half exited homelessness after only their second try at Haven. So for these clients, after their second stay, their homelessness was also resolved. So this leaves approximately 1,000 multiple stay clients out of 6,500 clients annually who are not achieving stable housing within our community. How do we address this subpopulation? First, I want to thank this committee for its steadfast support of Haven for Hope's work. With the most recent Healthy Community Collaborative Grant through the Texas Health and Human Services Commission, Haven will be able to further strengthen our clinical model by expanding our ability to serve individuals experiencing significant behavioral health and substance use challenges. These new services include clinical case management and, as previously mentioned by other panelists here, medication management. Furthermore, we are also working on developing subacute service delivery models that slot in below inpatient admissions and/or post-acute stays. Haven is intrigued by the opportunity to produce value by arbitraging the relatively low cost of a bed that is already required and occupied by a homeless individual and parlaying that stay into appropriate short-term medical interventions, for example, respite care. If successful, this new model will have strong potential to reduce inpatient, readmission, and post-acute care costs for this population in much the same manner that emergency department costs have been reduced in San Antonio through the acute care station. There are not many viable reimbursement mechanisms for operating these contemplated services, and this is something that I would ask the committee to consider in terms of funding mechanisms for these subacute type interventions and delivery models. In summary, as this committee considers the future of health and human services policy in Texas, I respectfully ask you to view homelessness as both a housing issue and a health and human services issue, as you are doing. Texans who experience homelessness need shelter, but they also need coordinated care, behavioral health support, recovery resources, income pathways, and housing solutions. Haven for Hope demonstrates when those services are integrated, people stabilize, systems work better, and communities are stronger. Thank you so much for this opportunity to share Haven's story with you and the progress we have made. I welcome your questions and look forward to working with you to strengthen compassionate, effective, and accountable responses to homelessness across our state.
Thank you. Thank you, Ms. Munhink. Senator Perry.
Thank you, Madam Chair. I want to focus on Haven for Hope for a minute. And I'm going to qualify a few things. First of all, every time homeless comes up, you're one of the first names that comes to my mind. And your Senator Menendez is an awesome individual. And on this front, he's very much in tune and done. But we've had conversations on the floor. He sits right behind me.
And Donna Campbell.
Yeah.
She's
And
always
so-
talking to me about it.
And I had made a promise to both of those senators that I wanted to go see this place, but I have not made that down there. It's my fault. It's not anything y'all have done. But here's where I'm going to, and I'm not saying this is a bad thing. I'm just saying I want to make sure I have the understanding of how you work. Number two, it's something that we have to consider. I don't disagree with anything you said, sir. And I think my comments today talked about least restrictive may be the best idea, but it's probably not working. But back to you. My basic understanding is, for lack of you have corridors, if you will, where people walk in. And the first one is for better conversation. It's like a castle with walls, right? And you stay in this first level if you're on drugs and you choose not to get off drugs. You meet them where they're at. It was a comment you made. And for those people that choose to stay on drugs, they stay in that particular area, I guess, indefinitely. Now, do you provide methadone or how do you work with that group? But you just assume on the front end, you don't impose. If they want to move in, then you transition them in. But if not, that population base is off the streets, not committing crime, but they're in this space. Is that a fair assessment, or can you elaborate a little bit?
Yes, that is a fair assessment. We call it North Campus and South Campus. So on South Campus, again, understanding that on any given day, somebody is not prepared to end their addiction, somebody is not prepared to enter treatment, but there are methods that you can use to engage somebody that lead them to make those decisions sooner rather than later. And so on South Campus, the notion is that we understand that you may not be sober from whatever substance you may be using. Now, I want to be clear, you can't use on campus.
Okay. Good to know. I didn't know.
We don't
Good to know.
have harm reduction type.
You don't provide needles.
We don't provide needles.
Okay.
No, but we understand that it's a process. And so on our South Campus, the idea is that you can be using and be on South Campus. The difference, I would say, between us and most other emergency shelters is that we are consistently engaging that group in motivational interviewing techniques and any number of other behavioral health interventions.
There's an outreach.
That's exactly right.
And so as an outreach, how many, let's say 100 people show up today in that space.
Mm-hmm.
And I know you don't, in 2 days they're going to be over here. I know that, but how many move from the 100 into the inner circle, if you will, to start up that chain?
Yeah, so it's not necessarily linear. in terms of how people go back and forth between the two campuses. But what you do have, what's interesting is that the acuity is basically the same on both sides of the fence. But on the north side of campus, what they've indicated is that they're going to stop using, and the expectation is we're then focused on housing and income plans, and you must be making progress on your housing and income plans in order to stay on North Campus. So there's this very specific focus. That's the propulsion I was speaking of. So there's an expectation that you're working to get yourself out. There's a good overlap between the two campuses, but the pathways back and forth are not as linear as you're suggesting. So it's not Jacob's ladder. It's more of a cyclical.
So you really don't track, or do you track people that come in, stay at first level, and never come in? You don't know.
We do. I don't have that with me today.
So
but I
did
can
you
get
say
it to
6,500 per year? Did I hear you correct?
6,500 per year.
Out of the 6,500, there's a piece of those that stay out.
On South Campus?
On North Campus,
On North
I guess, would be where they stay on drugs effectively.
Not on North Campus, just on South Campus.
It's the South Campus. Okay. So we don't know the 6,500 if there's 500 that choose to never come in and change. Is that a?
I can get that for you.
Yeah,
don't
I
have
think that would
today.
be helpful. And it's not a downer. It's just
No.
we're looking for things that work.
Yeah, absolutely.
And so to that point, that works. So $100 million capital outlay. What's your annual operating cost?
30 million.
30 million.
Mhm.
And that's pretty much philanthropy with state support.
That's right.
You have federal support too.
We do.
So you're a composite.
We're a
just
composite.
an NGO
That's very-
of just like all NGOs are scraping
Yes.
for every dollar. Okay.
Absolutely.
And you have the statistics. You quoted some. I didn't hear the percentages, but that show that when people go through the north side and get out, that they're staying out, that they're
That's
into
right.
it, and that's phenomenal. So,
Yeah.
you know, Madam Chair, every time homelessness comes up, and I didn't want to go into the granularity. I worked with some homeless populations in Lubbock. We had a 100-bed facility where when temperature hit a certain level, they stayed. They were looking for chaperones. 100 adults, 25 women, 75 men, and they were wanting community chaperones. So I stayed a few nights. And after surveying the landscape, I just said, give me 10 people that can pass a drug test, that are here but would like to be somewhere better. And I've got a particular industry that says we will run them through a training, certify them, they're making $15 an hour. And actually, this particular industry owner had subsidized housing in the back. So we kind of have a continuum here for these guys, 10 people to pass the drug test. Found them. First level was transportation to get them to training, to get them to industry. I got in my car, to my wife's chagrin, and loaded up homeless folks and took them. And then eventually I promised them a bike. Here's where I'm going. Out of the 10 people, half of them were gone in the first week. Didn't want to go through training. I think we got down to 3. Completed training, got the job, first paycheck, gone. I happened to run into one of them a few weeks later. Said, hey, we love your heart. We love what you tried to do. Here's the truth. We love being out in the stars in the summer. You'd have to be an idiot not to eat 3 times in Lubbock, Texas every day of the week. And we don't want to be accountable to nobody. So right then I determined it wasn't the challenge of what to do. It was the challenge of figuring out which ones wanted you to do it. And then there's another subset of homeless that we haven't spoke to, but they're in the set. Family Promise is one of the NGOs that works with. These are families that were evicted from homes or lost a job, or for no reason other than that. They just ended up on the street as a family dynamic in units. Those are the people that are looking for options and opportunities. So I think your model is very interesting. And I like the idea that you got them off the streets, even though they're still users. I don't like the idea, but I think what I've heard you say and what Senator Mendez has said, look, they don't just come in and stay on drugs.
No.
If they're going to stay on drugs, they don't stay in. Usually because of that interaction and that faith-based kind of aspect, I think, where you give them some spiritual guidance and things, you move them, I think, fairly quickly. I'm just speaking for yourself. But so I like the idea, but it also bothers me that we're willing to just leave them. But after that experience, I'm like, Some people don't want to be bothered. And I think it's out of 10 people, 10 out of 10 said, no, thank you. So that's the challenge with the homeless that we can do. Substance abuse, trauma, whatever reason, and some organic, some that were just born, they just didn't fit. And those are the ones I worry about. It's about no fault of their own. They're in that situation. Some people made bad decisions. I have a redemptive quality, but there's also a point, to your point, at some point, you have to separate those that want help and those that don't. And the ones that don't want the help, that are continuing to be a problem for society, we got to go back to the institutional model. But thank you for what you do. I hope you don't take any of my questions
Not at all.
negative. I think more information about how you function. I will commit to you between now and session at all possibles, trying to make a trip down to see your spot.
We will make sure we're ready.
Senator Miles.
Be happy to have you.
Thank you, Madam Chair. Rhonda, I want to say thank you and commend you, as well as Haven for Hope as a representative. I've sat in some of our meetings in Houston on homelessness, and you all are definitely the platinum example across that's always talked about. And I have not committed, but now maybe we'll go together.
Let's go together.
Let's go do it.
Yeah.
Okay, let's
We'll
make
have
it
some
happen.
Mexican food in San Antonio, seafood in Houston.
We'll do it. We'll make it happen. So, but you are the platinum example of homelessness, and we're suffering majorly in Houston. So I want to commend you on that. But I also want to talk two areas with you. I want to talk the numbers you gave us earlier,
Certainly.
because that's what it's going to take for us to move in the state of Texas, in the Senate. We all know that. We got to. I heard you say the numbers, but if you could slowly go over them again.
Yeah.
All the way down from your $100 million capital
Sure.
program that started. So can you go through those numbers real quick with me again?
Tell me if I miss a number that you're interested in.
Okay.
So the initial investment was $100 million to
100
build the campus.
How did you? That was 60% of that was
60%
private.
of that was private.
Okay.
Private industry. Yes.
And then
When you look at the 15-year period that I was talking about, just over 52,000 unique individuals served in that period of time
2,000 individuals served
in 15 years.
in 15 years.
Of those 52,000, 65% only came to Haven one time.
the
And when
rest?
they left, for about, the average stay is about 90 days. And when they left, they did not return to Haven or anywhere else in the
Any-
homelessness system in San
Any
Antonio.
system, criminal justice system, or any other program?
Don't know about the criminal justice system. I'm actually trying to work on a data warehouse feed that would tell us that
Okay.
from Bexar County Jail. But that would be the first time that we have access to that information. But what
You're
we're
working on that
looking
now?
for is folks showing up within the homelessness response system within the San Antonio, Bexar County region.
Gotcha.
And we don't find them. So I think a conservative reading of that finding would be, yes, some have probably been incarcerated. Yes, some may have died. Yes, some may have moved, but it cannot possibly be 65%. So you're going to take some bites out of that number, but it doesn't equal the whole.
What does it take to house a person?
So the services that probably matter the most are case management. Your case management is basically your navigator, your cheerleader, you're not going to get lost. This is your individual guide. So even on South Campus where people are using and they don't necessarily want to engage in services, even on South Campus, we send case managers out regularly to engage with those folks on a daily basis, working, the area where those folks are, trying to get them engaged using motivational interviewing techniques and the like. So the first thing you need is case management. You need somebody in your corner. A lot of times these are people who they've lost their social connections. There are not a lot of people in their corner, and their self-efficacy and their belief in whether or not they can achieve anything is probably not where you want it to be to actually make a run at something different. So you have to get somebody up to that level. This is what case management is for. Then we have specialized case management. Once you have your sort of individual guide, your specialized case management are really focused on the obvious things. Where are you going to be housed? That's a conversation. As soon as you get on North Campus, you're not staying here. This is not your home. You are not going to be here for a long time.
Not a permanent situation.
This is not a permanent situation. Where are we going to get you housed? And how are you going to pay for it? So that housing and income plan, that comes along with income skills and development. So we have a large team. And what I will say is to get people house, particularly in private market rate housing, and to get people employed just in the market, in jobs that they're eligible for, you have to develop those relationships with both landlords and employers. You can't just, because they're not going to be right. These are not going to be your best employees day one. These are not going to be your best tenants day one. And so you have to have a relationship with the landlords and with the employers so that there's this understanding that this is a person who's working on standing up. They're not standing up yet.
Ms. Rhonda, would you say that y'all are also addressing on the north side some mental health people?
Absolutely.
Absolutely.
What's interesting is that the acuity is the same on both sides of campus. And we do launch people from both sides of campus back into the community, back into housing, back into, so Senator Perry, to your point, there is this moment in the grip of addiction where people make choices. People make decisions about what they're going to do and then move in different directions.
So we could say that STEP program, you're doing that
Yes.
STEP program on the north side.
Right.
as well.
So the other thing then that we're looking at to strengthen this is really then looking at, there are a lot of behavioral health interventions now that are evidence-based, that are very time limited, that can make a tremendous difference in terms of anxiety, depression, and PTSD. So those are the things that we're looking to really strengthen on campus, again, with this concept that they are already in a bed, the lowest per diem bed that you can put somebody in who has these issues.
Okay. And I heard you say $58 per bed.
$58.64.
$58, that's what it's costing.
Yes.
Okay. And would you say it costs, you ran out the rest of the numbers behind that?
So for Bexar County Jail,
Yeah,
$87.17
$37.
per diem.
Uh-huh.
And for a Texas Community Hospital,
Uh-huh.
an average of $3,441.
Okay. So on top of being the most economic, you're providing, Madam Chair, on top of being the most economic, you're providing the wraparound program, you're providing the STEP program, the investment is definitely showing to pay off. You said 44%. Did I hear you say 42%? Back to
Oh, for every dollar invested, $42 in community benefits
coming
returned.
back.
Mhm.
I don't know about y'all colleagues, but I would call that a win-win all the way across the board. I'm not a mathematician, but economic person, but I didn't study economics, but that's a win-win.
Absolutely.
I'm gonna ask you a question. What holds Houston back from doing something like this?
Hey, I don't know. I'm gonna have to talk to your. I'm
San
gonna have to call your old colleague. I'll have to call your old colleague,
San Antonio.
John Whitmire, and ask him what's the deal with stopping us from putting this
Well,
program
I
in.
mean, but how much was raised of the 100 million?
6% out of the 100 million.
60 million.
$60
So
million.
where'd you get the other
Of
40
private
million
dollars.
from?
Was the state, it was a combination of the state, the city, I believe there was one other funder, county.
But but even not at this magnitude, if we did something along the same frame line, and take some of these same concepts, and we input them into some of our programs that we already have, Madam Chair. I mean, it's no reason for us to not. I mean, it's no reason for us to invent the wheel. It seems like they've got a wheel that's running pretty smooth, without bumps. We don't have to take the exact thing, but take some ideas from Haven of Hope and input them into some of our state agency program where we are spending money. But I don't know.
Lower acuity patients mostly, correct?
No, not necessarily.
Okay.
There's gradations of acuity throughout the system. And that's what we look for when we look to placement, when we look to permanent housing placement and things to that effect. We're very judicious in terms of understanding who should actually go into permanent supportive housing. And even the way we do permanent supportive housing, we have a small project, is different than the way most people do permanent supportive housing. Again, we look at it as a sort of 2-year process.
And this
where we're
was
trying to get
really
people's feet
an
under them.
initiative by San Antonio. It didn't stop
Yes.
any county from doing this.
Completely a local initiative.
Locally driven.
Mm-hmm.
All right, Senator Miles, anything else?
No, I think that's it. I think this is a great start, Madam Chair, that we heard from them. Anything they bring Senator Perry and I together to go look at it together is going to be great.
And Senators, I look forward to your visit.
Okay.
Senator, you're next.
Thank you, Madam Chair. Ms. Gaines, Memorial Hermann is one of the largest nonprofit hospital systems in the state, revenue on the order of $8 billion. And in 2021, it divested its behavioral health inpatient capacity when it sold Prevention and Recovery Center to private equity. So your testimony is asking us to make sure that these patients don't arrive at your ERs, and you know I understand this issue quite intimately. But what is Memorial Hermann prepared to contribute to regional psychiatric capacity?
So one thing we're doing with
Can you pull that microphone?
is making sure we're aligning with community resources and partners. So when the patients are medically cleared from emergency rooms, we have referral sources that we can align them with. So we have a case management team that works, and we have hospital-based clinicians along with our psychiatrists to refer those patients to community resources to stay whole in the communities.
How much of Memorial Hermann's community benefit obligation under your nonprofit status is directed toward behavioral health specifically?
From a cost perspective, I don't know. I'd have to provide that information to you.
Thank you. Mr. Centurino, Olmsted talks about the least restrictive, most appropriate. People often forget that last part. What's the estimated cost of your preference for detention to local courts and budgets?
Senator, what do you mean the estimated cost of Texas? For what period of time? Give me a little bit more specifics.
So everybody who detains people is already bursting at the seam and bursting through budgets. So what's your estimated impact?
That's a great question, Senator. I don't have that number off the top of my head. I'm happy to provide you an estimate. I think that when I mentioned Olmsted, I think that's more about the principle that's baked into Texas law right now, which is an unnecessary burden on the state.
So Haven for Hope, Sheriff Edwards, my city's director of public safety, prosecutors in my district attorney's office, every single one of them has spoken to me or in this hearing today about the need for expanded diversion and an increase in community setting services. I do think it's really important to mention that the Cicero Institute is a think tank, and it was founded by Joe Lonsdale, a billionaire venture capitalist and the co-founder of Palantir, which is an infamous tech giant who is known for selling data for government surveillance. So my first question is, do you recognize that your testimony today is in diametric opposition to every single other person who's testified, who's a Texan, who works on the ground in this state? And my second question is your recommendation that we ignore all of them and listen to you instead?
Senator, no. I'd say that based on the testimony I've been listening to over the last couple hours, I'm in complete agreement with a lot of things that were said. The judges and the district attorney that have spoken, the folks in the law enforcement community have echoed a lot of the same things. A lot of what I skipped was because I agreed with them, frankly. I'm just trying to point out things that were not mentioned, like Olmsted and the continuum of care opportunity that's new. So no, I don't think they're diametrically opposed at all. I think we all, Senator Miles, I think you were the one that said we all want to solve this problem. We all think that there are better ways to handle this issue. I think there's a wide agreement on that. I think law enforcement is exactly right that jail is not the best place to treat people with mental illness. I couldn't agree more. There are better places to do it. There are also worse places to do it, like not treating them at all and leaving them in the street dangerous for themselves and the public. So I guess I'm missing the contradictions. Maybe you could be a little bit more specific, Senator.
No, I think you've answered my question, and I'm just so grateful to have all of the data from Haven for Hope today. We have a lot of data from all the folks who provide services to the homeless people in our region. So thank you so much. Thank you for your answer.
So I'm going to follow up with a couple of questions. I guess this is for Deputy Edwards and maybe Ms. Gaines. And I know sometimes, Deputy, y'all are directed when you call maybe your local LMHA and you say, we have this crisis situation. What did they instruct you to do?
So it's kind of different.
Lean forward.
It's kind of different from my experience, because when I started in 2006 as a mental health officer, we were training with our local mental health authority as in the MCOT. So I've been in the mental health system, and depending on what is said when they respond to a call and saying, hey, we need to take this person to the ER, a lot of times that has been because they were short-staffed, overwhelmed, and needed a secure place for that person to go until they were able to go and do an assessment for them. The mobile crisis outreach teams are required to be available 24 hours a day, 7 days a week with an hour response time. And so having that and a lot of officers not knowing that helps that individual get into appropriate treatment and care sooner.
I guess my question is, I think I've heard from your sheriff that the first thing y'all are told to do is to just take them to the ER.
Correct.
Rather than, maybe the mobile team that's available.
Right. And then going with what is in the health and safety code in 573 goes back to we're supposed to transport them to the nearest appropriate inpatient mental health facility. And
does that happen?
For when I'm involved, it happens, yes. We take them to the nearest appropriate inpatient mental health facility.
Okay.
So Senator, sorry, just can I follow up with a situation that just happened this weekend where we had a call, an individual, 19 years old, was taken to the ER for suicidal ideations. He was going to shoot himself. And the MCOT crisis worker responded out there to help law enforcement and said he wasn't suicidal enough to be transported to an inpatient mental health facility. Luckily enough, working in the mental health system, we called on in a favor to a inpatient mental health facility who gave us a free bed for that individual, and they ate the cost of it because they knew that person who was still saying, when I leave here, I'm going to kill myself, needed that help. The alternative would have been we would have taken them to Austin State Hospital, where that would have caused a lot more conflict with our local mental health authority.
Why?
Because as law enforcement, you can go directly to a state facility and they can't tell you no. They're bound by EMTALA, and that has just gone away from what we've done in the past. So working with our partnerships to keep that relationship with your local mental health authority, because that's ultimately, we can't do it without them, but sometimes we have to.
Well, does that, I think, go to what Ms. Dixon was talking about, the walk-ups and the chart, which is in one of these pieces of paper up here, the 86% walk-up in Terrell, or I think the number in Austin's a little low there. I'd like for y'all to check that number, but El Paso, if I did a survey of kind of the Austin State Hospital, I would find, I'm looking at Ms. Dixon, I would find a vast majority of the people are from this county. I mean, we kind of run a local hospital for Travis County. And it was always supposed to be a regional hospital. I mean, these were put in regions, and it seems like wherever the hospital is, we just run their local hospital, which then we still get the phone calls from the mayors and the county judge, y'all need to do more. Well, we're literally giving you a state hospital here in Austin, right? I mean, like, I'm pretty right. I know these numbers pretty well. So, I just want to get to that. That's something I don't like what you said, is that you'd have gotten in trouble with your LMHA if you'd have gone straight to Austin.
The state asks, a lot of times we'll ask the local mental health authority, why are you not working with your law enforcement?
Oh, so the LMHA gets in trouble.
They get in trouble and it kind of rolls downhill.
Oh, imagine that, Jordan. Let's get some of these numbers. I mean, like, so you're actually going outside the code when you take it straight to the ER, which is what Ms. Gaines says. I mean, like, you're supposed to find the first available mental health bed, but really the ERs that become the de facto, because our mobile crisis teams, maybe on a weekend or at night or whatever, can't be there. I'm just trying to get to the bottom of it, because trust me, I hear from your sheriff, and I hear from all the sheriffs out in my district about what's really going on.
Yes, ma'am.
You're not in trouble.
Oh, no, I'm not in trouble.
Okay. I don't want to get you.
I try to be very, very nice.
I know. You changed your
pretty
test.
good at that.
I just have to say that, I mean, like, for you to make the statement that you can't take them to Austin State Hospital, which is a walk up, which is EMTALA, which they have to take it, which is cutting through the thing, then that your local, your LMHA doesn't want you to do that, because then they're going to get a phone call from HHSC to say, why'd you do that? Or from the Austin State Hospital. You see kind of how I've lost some faith here on how this whole thing's supposed to work?
Absolutely.
Perhaps. Okay, great. To Cicero, and I still can't get your last name right.
Madam Chair, Centurino.
Centurino. I wanted to learn just a little bit more about this new HUD program. If you just let me know on that. What is that?
Yes, ma'am. So for the last few decades, the HUD Continuum of Care program is the technical name. Again, it's confusing because it sounds similar, but it's very different from a continuum of care in the mental health context. Continuum of Care program is HUD's primary funding tool for supporting local homelessness programs. And some of the features of it over the last few decades have been, I would say, counterproductive rather than productive. They've really prioritized permanent supportive housing with no strings attached, which are more expensive, rather than transitional housing, which is cheaper, and imposing some accountability measures, which we've all been talking about.
More like Haven for Hope, 90-day stays.
Yes, ma'am. Yes, ma'am.
Okay.
Haven for Hope is a great example of a program that works, in part because there's accountability built. I won't speak for them, but because there's accountability built in, they have a model that works. And in fact, one of the gentlemen that's running the Continuum of Care program at HUD now, Robert Marbert, has a long history with Haven for Hope. So it's very much in line with this new direction. One of the other program features is that about 95% of the NGOs, or this continuum of cares, which are just basically conglomerations of NGOs in a geographic area, they would be auto-renewed every year, 95%. There was very little accountability involved, not just for the individuals who were receiving benefits purportedly, but for the organizations that were receiving federal dollars. There's also very little data that was required of them. So like, if you all feel like you're flying blind a little bit in the homelessness space, you're not alone. It's because these COCs were never really required. It's always been a little bit of a veil around the data, in part because HUD never asked them for really robust metrics on which to judge them. So in other words, from one year to the next, over the last couple decades, a continuum of care in, you name it, a geographic area in Texas, did not have to say, hey, HUD, please give us some more money this year. Here's how we did last year in reducing homelessness. That was never asked. 95% were just auto-renewed. Yeah. And so the new direction that they're taking is as much as possible the opposite of that. Obviously, because of statutory constraints, they can't completely flip the script, but they're trying to move in that direction to fund programs that are actually making sure that people are moving into transitional housing, and then moving out as they become more self-sufficient rather than in the state of permanent dependency, and collecting more data and creating more flexibility so that states and cities can become continuums of care themselves.
I should know the answer to this question. I don't know who the receiver of these monies are in Texas and where I would trace these. And so I don't know if that's HHSC, if those are just directly to cities.
Madam Chair, so it is
TDHCA.
It goes directly from the federal government right now. It goes directly from HUD in DC to local continuums of care, which are just the conglomerations of NGOs. It doesn't have to be that way. It is right now. They basically, NGOs get together and they, like I said,
That was what you meant by some states saying, we'll do this.
Correct.
And direct that so that we could be the receiver of it. And I just want to make sure, like, I mean, I did a little reading on, I think, California's $24 billion that they tried to fix the homeless population. And I mean, even within, like, people like Democrats criticize Democrats on, like, there was nothing traceable there, and it certainly didn't solve it. And some people don't even know where the money went to. And so I want to make sure that we're very directed about accountability. NGOs of late have gotten some bad raps on lack of transparency and knowing where the money goes. So we'll work on that. And then finally, Miss Summer, I thought your presentation was very good. How do you access medical records or previous records for individuals that are in your psychiatric hospital for evaluation or competency restoration? And I mean, I guess what I'm saying is there a process to get those records if the person has been under the care of the LMHA or somewhere else or the jail? Do y'all have access to those, or is there HIPAA that violates that? I mean, how do you get those records?
Actually, if we're dealing with competency restoration, we receive a packet from the state that has all of their legal documents.
Okay.
I actually send them back a questionnaire requesting medical information. I need to know anything on the forefront that meets our exclusionary. From then, I request jail medical records, medication MARs, all of their private medical history prior to that to make sure, again, am I treating an individual I can help in my facility? So that information is shared through us with the individual LMHAs, the courts, and I send all of those requests for all of those records for the people that we're going to treat. The LMHAs themselves don't have those records. It is primarily through the jails that have that or the facility that they're at that time. The LMHAs can only connect it and share with us prior history that they've had with treatment failures or successes in their programs. And they try to connect and keep them in their catchment area so they can continue any follow-up care or wraparound services that they may need. That's primarily the most information that we get. If an individual does allow us under HIPAA to sign a release and get consent from family members on that too, we can receive supportive clinical documentation from them as well. Okay.
Interesting. Yes, Deputy.
Senator, just so I can follow up just a little bit on that, if a person is in the criminal justice system in the Health and Safety Code 614.19, I believe, under continuity of care, allows for that information to be shared.
Okay. So no clarification needed in that statute. Works good. Okay.
Ask one more.
Yep.
Apply for, thank you so much for Herman or Hope. But do y'all run into folks who have reached their lifetime limit of 190 days, psychiatric days on Medicare?
Is that for me?
Really for anyone who wants to answer, but yeah.
I'll be happy to answer.
Sure.
Yes.
Okay.
We receive that quite often, depending on the age of the individual and when they enter into psychiatric services, they can consume those resources rather rapidly, especially if their recidivism rates and they're going from facility to facility all the time.
Do you have an idea of like the scale of it or what percentage or anything like that?
I could tell you right now, I do have an individual in my hospital right now that is facing that, and he's 27. So depending on the age of they've been determined any kind of disability and receiving Medicare, it can happen rapidly.
Okay. Did you want to add to it or anything?
Wow.
Oh, no.
Okay. Thank you.
So there are some private facilities in the state who, if that person's benefits are reinstated, that could be a long-term living facility for that individual where they're getting life skills and just overall treatment and services. And those are a battle, but they're here. The hardest part we have when somebody comes out of the jail is getting their insurance reinstated, because a lot of times we're making individuals homeless because they've lost their benefits, they've been evicted from their house. So being able to get their benefits reinstated quicker, we can get them placed in long-term housing.
Okay. Any other questions? No? Good. All right. Thank this panel. I look forward to working with y'all on some great ideas out there. I'm going to call it up. And then we're gonna have And for our final panel today, members, this is under the monitoring charge by the Lieutenant Governor, Dan Patrick, who asked us to monitor the mental health programs and services provided through the Texas Children Mental Health Care Consortium. Through the years, there's been a number of bills that created that. I believe the original was SB 10 by Senator Nelson at the time. It, I think, was folded into Senate Bill 11 by a little crook, or like the House had a little problem. I think they killed Senate Bill 10, and then they kind of slipped it into 11 when they were about to feel the wrath of the chair of finance that session. Just a little bit of history there. So anyway, I believe I'm right on that. But at least one of those big mental health bills for children. The chair calls Nagla Ilarian and Dr. Laurel Williams. And as y'all begin, I may have to step out only because I have a constituent who tragically died over the weekend, and visitation is tonight, and I need to make it back to Sealy, Texas before 8 o'clock. So I'm going to be handing the gavel to Vice Chair Perry, but I want y'all to know I'm very interested in this program. We've worked on funding after Senator Nelson, I believe, created y'all, which I think there was, I'll be honest with y'all, it was after the shooting in Santa Fe that this came about. Wow, I keep remembering all these things. And there was some initial pushback and privacy and the things that we hold very dear in this state in making sure information is not shared. There has to be parental buy-in. We started in a small way, and then we've tried to expand it and make sure that it's available out there. So if you will, whichever one of you wants to start.
Absolutely. Thank you. My name is Nagla Ilarian, and I am the Executive Director for the consortium. Thank you, Madam Chair and Vice Chair and the Senate Committee for having us. And we're going to keep it as short as possible, but we have additional slides that are put in the appendix for your reference. And we're going to talk about the Texas Child Mental Health Care Consortium, which was established in 2019, as you said, Madam Chair, due to several tragic incidents and wanting to address and improve access to mental health services in the state of Texas. At that time, there was an existing collaboration that was meeting since 2015, and they met regularly in order to identify and address some mental health priorities in Texas and come up with the solutions that can address those. That group included the chairs of psychiatry for all the institutions in Texas, as well as state agencies and nonprofit organizations. This here on slide 2 is the consortium structure. So the consortium funds are attached to the Texas Higher Education Coordinating Board, and decisions are made through an executive committee. And this is the structure of the executive committee, which consists of 2 members from each of the 12 health-related institutions, the Health and Human Service Commission. We have 3 nonprofit organizations that are voted for, a hospital system, Rural Education Service Center, Texas Education Agency, the Texas Department of Family Protective Services, and the Texas Higher Education Coordinating Board are all members on there, as well as an administrative support entity. And that was voted for by the executive committee, and it is the University of Texas system that acts in that role. I'm going to pass it to Dr. Williams, who's going to talk about the programs.
Hi, my name is Dr. Laurel Williams. I'm the medical director for our CPAN and TCHAP programs that we're going to talk about briefly today. So thank you for allowing me to be here and talk with you. So when you see here on this slide, the Texas Child Mental Health Care Consortium actually is from the great work of the legislature, and really we were talking about all these downstream issues. This is sort of some of the really great work you've done to do things upstream. So all the things we're talking about within our consortium, I do think link back to some of the conversations we've had today. So we have the Texas Child Health Access Through Telemedicine, that's the TCHAP program, and that is a direct care service. We also have the Child Psychiatry Access Network and its sister program, the Perinatal Psychiatry Access Network. We have the Child and Adolescent Psychiatry Fellowship Program, which is about helping increase the number of providers within the state of Texas. And also the Community Psychiatry Workforce Expansion Program, which is about helping those clinicians learn about the community workforce out there so that they can want to participate in once they graduate. We also have children's mental health research that we're doing at 2 statewide large initiatives that we'll talk about briefly, and some other initiatives that we got through some of those funding during COVID related to youth mental health, youth-aware mental health, collaborative care model, and other workforce expansions. So I'm first going to talk about TCHAT. And so TCHAT is a program you can see here in the slide number 5 that is a short-term mental health care program for students that are pre-K up and through 12th grade. It's provided once we have a referral from the school system. After a family has provided consent that they would like the services, we will provide those services. The majority of the services that we provide are actually a psychotherapy, which is the most evidence-based programming for most youth mental health problems. So we're very excited to sort of have that. The next slide that you see here is related to just the services that we're providing. And so you can see here that we have, sorry, did we miss a slide? It's moving without me asking. Yeah, there we go. There we go. I was like, it's moving without my letting me do it. I'm not going to go that fast. So we have, oh my God, is it moving again? So we have about 81% of schools now covered since we've started. We have over 4.5 million student covered lives that we have access to the services. That's about 84% of students across the state of Texas can access the service if parent or family guardian gives us permission. And to date, we've had over 138,000 referrals. So we are seeing a lot of kids. And not only are we seeing a lot of kids, the top reasons that we're seeing youth for, people are often asked that question, is depression and anxiety are the top two reasons for why we're seeing kids, but also bullying, self-harm, anger, and aggression are also some of our top concerns. And for most of our kids, it's multifactorial. There's more than one reason for why they're being seen in our service. And so we see that as very consistent as to sort of what Madam Chairman said about what was the reason for why we were initially created, which is to address potential student aggressions that are directed at themselves and others. Moving on to the next slide, we sort of look at the sort of services that we've provided so far. We've been able to serve about over 74,000 students. And what we're really happy about is how quickly we can get them into the services. That's one of the things that we want to pay attention to, is that we're getting 83% of those enrolled students. Enrolled means that the parents have provided consent for the care within 4 weeks of the referral, and often sooner than that. The next slide that we have here is around to sort of like looking at the satisfaction of the services. And so we have both an internal and external evaluator team. And what we found here is that 91% of the families are satisfied with their TChat services. 85% of families are reporting that their children are better since being involved in those services. And the youth themselves are asked those questions, and 3.5 out of 4 is satisfaction for the youth. So we are seeing that both families and youth that are being served are finding the services are valuable and helping them get better. Moving on to the next slide, as far as just parental perception of those services, you can see here that when we asked for them to sort of say how effective, we have found that the families say that 97% of the families are feeling that the services were effective in addressing the mental health concern or issue that brought them to the services to start. So we're very excited to sort of see that sort of directly from parents and legal guardians related to TChat services. So that's our TChat service. The next service that the consortium provides is, like I said, that Child Psychiatry Access Program service. And one of the things that does, it's a real-time with primary care clinicians across the state. They can call and speak to a mental health professional, both a therapist and or a physician like myself, so that they can get evidence-based recommendations to help children and families that are in their office, also women who are receiving their OB-GYN services while they're pregnant or postpartum. So that is actually what the service of CPAN PeriPan is. When you look at some of our highlights related to the service for CPAN PeriPan, we have over 5,000 pediatricians and family physicians enrolled and over 1,000 OB/GYNs across the state. So far, we've done over 70,000 consultations for CPAN and over 6,500 consults for PeriPan. There's a difference there because those two programs started at different time points. These consultations have assisted over 51,000 patients in CPAN, over 4,000 in PeriPan. And most of the time, our calls are responded to for CPAN within 3 minutes. There can be speaking to a psychiatrist, and for PeriPan also within 5 minutes speaking to one of our perinatal psychiatrists. So one of our real goals here is rapid, quick conversations with those providers. When you look at the next slide and you're sort of looking at the sort of overall satisfaction, one of the things that we hear time and time again from those primary care physicians is how satisfied they are with the results of being able to access the CPAN and PeriPan line to sort of help people stay in their own community, not necessarily go to those next higher levels of care because their primary care clinician can assist in answering some of those questions and helping those families. The next slide is on our community psychiatry workforce expansion, and that is the one that I talked about where we are putting physicians, psychiatric residents, child and adolescent psychiatry fellows, people in training to be psychiatrists and child psychiatrists into the local mental health authorities and other community workforce locations in order to have them have a quality educational experience so that they will potentially choose to take those kinds of jobs once they graduate. We heard about the workforce shortage, and this is one of our small parts in sort of trying to help address that workforce shortage. Within that, we have provided over 500 residents with an experience within CPW and partnered, and about 20K patients have been seen within the partnerships with LMHAs. And as I said, 74% of those CPW graduates have stayed in Texas and continue to provide mental health care for Texans. And 56% of those graduates also started to work in a publicly funded organization. So we're really trying to get that workforce to assist us there. And then the last one is the Child Psychiatry Fellowship expansion. And so again, we're very pleased that since the consortium has been initiated, we have increased the number of slots for child and adolescent psychiatry fellows by 89% since 2019, including starting 3 new programs across various institutions. And 79% of those child and adolescent psychiatry fellows who have graduated from these programs have stayed in Texas to serve Texans. So we're very, very excited with that. And with that, I'm going to move it over to Nagla.
So if you look at slide 14, I'm going to talk about under the research initiative, the consortium has 2 statewide initiatives where it's a network with a hub and nodes across all the state, where one of the research is focused on child trauma and another one is on addressing youth depression and suicide in Texas. And it is providing kind of research for systems of care, and it allows them also to gain additional grants to help kind of focus that research in the state of Texas. Additionally, there is a grant for new and emerging child mental health research where the consortium is able to support 47 researchers over the past 2 bienniums. And the research they're conducting is really trying to kind of match them with state agencies' research priorities and making sure that the research outcomes are incorporated into the systems of care. So on the next slide, I just wanted to provide you with some updates related to the last session. And the consortium had asked us to expand CPAN, PeriPAN, and TChat to rural hospitals and clinics through HB 18. And currently, CPAN and PeriPAN are being offered to all rural hospitals in Texas, and that has been in place since May of this year. As well as we have been working on engaging more rural clinics in order to access these programs. Now, rural clinics have had access since 2020. However, we're expanding. We're trying to make sure that they know about the availability of the program and kind of engaging them. So starting September of 2026, we will be piloting TChat program to rural hospitals and clinics. And it's going to be covering most of the rural hospitals and clinics in Texas. And this pilot that's going to start is 6 months long. And then in March 2027, we're going to go statewide with all rural hospitals and clinics having access to TChat services. Other initiative or other House bill that was passed, House Bill 6, asked that we go ahead and provide all the resources that are collected through CPAN and TChat and put it on our webpage in order to have that available. And so that has been in place, and we update that on a quarterly basis. And then finally, there was a consortium directive to conduct a study on third-party reimbursement for the TChat program. And where that is we've hired a consultant who has completed all the data collection and is currently putting together the report, and we will have the report available by the end of the year. So under the appendix, we do have additional information if you'd like to ask any questions or want us to go through this. This is additional information on the CPAN TCHAP programs, as well as some of the ARPA projects that we've been working on. It also includes our budget and kind of the progress of that budget, including some of the ARPA budgets as well. So that concludes our presentation, and please let us know.
Thank you for being here. Real quickly, the ARPA money was 138 million or whatever, I believe is what it showed. So
Yep.
was that one-time expenses you didn't incorporate into your ongoing budget, correct?
We received that in, I believe, 2022, and that was extended over time.
Okay.
Therefore, we continue to utilize those dollars over a period of, I believe, 3-4 years. It expires by the end of this fiscal year.
Right.
And what we have asked from the last legislative session is, as the ARPA dollars winds down, is if we can utilize for certain expansion programs some GR dollars towards that, and we got approval for
So
that.
on the expansion program concept, I'm looking at how many schools have signed up. It looks like some decline, which is
Yes.
fine, and they may have their own thing going. Is that the general consensus?
Yes.
They already have something in place and don't need it.
Yes, we are unsure though, with the ARPA dollars winding down. Some of the schools, the reason they did not want to initiate is because they, through ARPA dollars, received some access to behavioral health programs. And as the ARPA dollars wind down, there may be additional schools that might reach
Want
out.
to come
and-
back on. So in that vein, and remind me and the members, I should know this, it's free to the
Yes.
schools.
Correct.
Now, if there is a hook to a actual psychiatrist that the family hooks up with, that's outside of funding, and they would be paying for that service. Is that is that
Yes.
right?
Yes.
Okay. So you're a connection, you're front line, but if it needs further, then the family's responsible for that payment.
Correct. So as Dr. Williams was talking about the TCHAP program, the way it works is we enroll and then provide short-term services. If the child needs additional services post the short-term services, then they would need to pursue
Their
use-
private
utilize-
path. I got it.
Yes.
Okay. Any questions, members? It's been a long day. I appreciate you guys hanging in there with us. It's not that you're not important. It's just we knew you knew what you're doing, and you were pretty straightforward. And it's one of the things that we did as a legislature. And I remember Jane Nelson being the champion and advocate for it, and we were kind of like scratching our heads. But I can tell you, in my rural districts that have bought in, appreciate it. They seem to be getting it now, where it's doing some things. And I think Sarah Wakefield there is training some of the workforce, and there's some of the interned and conversations. There's some of the front lines. So I saw it in action.
Yes.
And it seems to be working. Members, with that, if no other questions, thank you guys for being here and hanging in there with us. As a reminder, we will begin tomorrow at 8:30. I know that there's some on the panel that 8:30 comes after 5 p.m. at night. No, there's one in the morning. If there's no other business to come before the community, we stand subject recess, subject to call the chair.